I would like to invite Dr. B.N. Rao Garu, President-elect, to please come on to the dais. I would like to invite Dr. B.N. Reddy Garu, Secretary, IMA, onto the dais. Dr. B.N. Reddy Garu, Secretary, IMA. I would like to invite Dr. Lav Kumar Reddy Garu, immediate past President, IMA. We take pleasure in inviting Dr. Vijay Rao Garu, Secretary-elect of IMA, Telangana. And it's our pleasure to invite the Scientific Committee Chairman for today's session, Dr. D.C. Tirupati Rao Garu, onto the stage. And our immediate past President of IMA, Karimnagar, Dr. Lakshman Kumar Garu, to please come on to the stage. And our dynamic President of IMA Karimnagar, Dr. Ram Kiran Garu, to please come on to the dais. I request all the dignitaries to proceed for Jyoti Prajwalana.
Shubham kurutvam kalyanam arogyam dhanasampada. Shubham kurutvam kalyanam arogyam dhanasampada. Shatru buddhi vinashaya dipajyotir namostute. Dipajyotir namostute. Shubham kurutvam kalyanam आरोग्यं धनसम्पदा. शुभं कुरुत्वं कल्याणम् आरोग्यं धनसम्पदा. शत्रुबुद्धिविनाशाय दीपज्योतिर्नमोऽस्तुते. दीपज्योतिर्नमोऽस्तुते. शुभं कुरुत्वं कल्याणम् आरोग्यं धनसम्पदा. शुभं कुरुत्वं कल्याणम् आरोग्यं धनसम्पदा. शत्रुबुद्धिविनाशाय दीपज्योतिर्नमोऽस्तुते. दीपज्योतिर्नमोऽस्तुते. शुभं कुरुत्वं कल्याणम् आरोग्यं धनसम्पदा. शुभं कुरुत्वं कल्याणम् आरोग्यं धनसम्पदा. शत्रुबुद्धिविनाश.
I request Dr. B.N. Reddy, sir, to please come on to the dais.
Now I request Dr. Sampath Rao sir, President IMA, to talk on IMA schemes.
Okay. Good morning, everyone, to the nice venue of the Karimnagar conference. Very energetic team of the Karimnagar. So, dignitaries on the dais, starting with Dr. Ravindra Reddy, the National Vice President, President-elect Dr. B.N. Rao, Dr. Tirupati Rao, the Scientific Committee Chairman, Dr. B.N. Reddy, my colleague, and Dr. Lakshman, who are all other there, Dr. Pramila, Dr. Sanjeev, Dr. Dilip, Dr. R.K. Yadav, Dr. Agarwal, and Dr. Mutyam, everyone. It's a nice thing that we are starting a scientific session of our conference. Previously it used to be 2 days conference, but slowly it is getting into 1 day conference. Last time when we conducted at AIG a conference, it was a 2 days conference with the whole of the scientific programs on the first day, and on the second day along with the business meetings. The scientific sessions were also equally busy. I wish this time also the scientific programs will be under the chairmanship of Dr. Tirupati Rao, will go very, very rich knowledge to be given to the participants and the delegates. As you all know, the IMA is concerned mainly with the 4 activities: updating the knowledge of the members, problems of our members, public health, and the related activities. So among the updating of the knowledge, this is the scientific programs we need to take up very vigorously, and we should update, though we pass in our graduation, but many things have to be updated, and so that we keep always the latest knowledge with us. With these few words, I thank the organizers for giving me this opportunity. Thank you.
Now I request our scientific chairman, Dr. D.C. Tirupati Rao sir, to take over the session. I request National Vice President Dr. Ravindra Reddy sir to present his message.
Good morning, everybody. Dr. Sampath Rao, President-elect Dr. B.N. Rao, the bridegroom of the day, and Dr. Tirupati Rao, Dr. Lakshman, Dr. B.N. Reddy, Dr. Ram Kiran, and Dr. Lakumar Reddy, and my friends. It is indeed, it is a pleasure to come to the Karimnagar, because they have been regularly hosting these conferences, and the venue, the arrangements, and the activity, enthusiasm of the organizing committee is something seen to be appreciated. And I have gone through the scientific contents, scientific session. I congratulate Dr. Tirupati Rao for arranging an excellent CME programs, and with the eminent speakers of Hyderabad. The first speaker itself is a star speaker, and we have seen, I have gone through the list. So I congratulate you, Tirupati Rao, and organizing team. So I wish Dr. B.N. Rao and the organizing team a grand success for this conference. Thank you very much.
Now we invite Dr. Tirupati Rao sir, Scientific Committee Chairman, to give a brief message.
Very good morning and warm welcome to all distinguished delegates. When Dr. B.N. Rao asked me to be in charge of scientific committee, scientific sessions, some of my colleagues advised not to include many scientific talks in the session because IMA delegates will not be much interested. But I was able to convince them. I included about 9 to 10 talks. And my appeal to the IMA leaders also in the future also, please include scientific sessions in a bigger way, because in this era of digital revolution, we have to update our medical knowledge. It is mandatory for all of us to improve our medical knowledge. In order to be a good doctor, I think we need humanity, empathy, medical skills, and updated medical knowledge. That's why I have chosen very important topics in consultation with our scientific committee members, which are very relevant to the day-to-day practice. And I invited very renowned speakers from all over Telangana to deliver their talks. I am very much sure that you are going to have scientific feast, and I wish you all the best. With these few words, I announce formally the inauguration of scientific session. Now the first topic will be by Dr. Sampath Rao, President of IMA. He will be talking on the PP and WS. Please welcome, sir.
Right. Yeah, truly speaking, this may not be exactly the scientific program, but ఎంత సైంటిఫిక్ నాలెడ్జ్ ఉన్నా, ఎంత కరెక్ట్గా ఉన్నా కూడా మీ ప్రాక్టీసులలో ఏదో ఒక లోపం, ఏదో ఒక డెఫిషియన్సీ వచ్చే అవకాశాలు ఉంటాయి. కాబట్టి ఈ సైంటిఫిక్ ప్రోగ్రాము మీరందరూ బాగా సబ్జెక్ట్లో ఏముంది అనేది అంతా గ్రాస్ప్ చేస్తారు. నా మనవి ఏంటంటే, దానితో పాటు ఐఎంఏ మెంబర్స్ అందరూ కూడా మీ ఇంట్రెస్ట్ గురించి, మీ ప్రొఫెషన్ను ప్రొటెక్ట్ చేసుకోవాల్సిందిగా ఈ సైంటిఫిక్ ప్రోగ్రాంలో నన్ను ఫస్ట్ స్పీకర్గా పెట్టినందుకు ఆర్గనైజర్స్కు ఫస్ట్ థ్యాంక్స్ చెప్పదలుచుకున్నాను. PPW scheme, as you know, it comes to the rescue of all of you whenever you are in trouble. Next slide, please. Somebody to change. Next slide. Ikkada. Previous one. Ikkade undu. Yeah, all of you know the aims and objectives of the PPW scheme. It is to cover whenever you are in difficult times, both by the professional advice, expert advice, and the legal assistance, and by compensating if at all you are awarded by some negligence charges by the courts of law. Yeah, these are the important office bearers, including me as the chairman, Dr. K.K. Bajaj, secretary, and Yashwant Rao next. This is the one scheme where it is run by ourselves. It is the doctor scheme run by the doctors, for the doctors, and of the doctors. See, andaru adugutuntaru, why only our scheme? Our scheme is for our scheme. See, we are saving so many funds in the PPW scheme which can be utilized for any benefit measures, beneficial effect to our members. Suppose if you are in the other general insurance schemes, you do not have any control over your funds. And it is your home. Telangana IMA PPW scheme will treat you like a homely, if at all there is any litigation. Yeah, this is as you know, located in our office. Next. 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 Yeah. So it helps you in the difficult times. Next. The present membership is, the figures are given here, about 1600, nursing homes nearly 350, diagnostic centers, and we should double the membership in the PPW scheme in the next 3 years so that the scheme will be more useful to all of us. The recent, from 2018, we have increased the coverage up to 1 crore. Previously, it used to be only up to 20 lakhs. Because nowadays, if at all the litigation comes, smaller litigations, they just take care of by themselves or out of the court settlement. But if they go to the courts, definitely they are going to sue you for a bigger amount. That is why you are required to cover your professional risk of indemnity to a law. These are the different categories of the schemes, the individuals in that, the family physicians, specialists, the surgeons and super specialists. Next. The nursing homes category, diagnostic category, the fee structure is very, if not truly competitive with the general insurance companies, but definitely we have reduced the tariff for the nursing homes by 50%. Recently in the month of March. Next. So that is the different, how much you get discount for the seniority in the PPW scheme. You can say, see, if you are 20 years and above, on the existing fees you get straight away 50% discount. So in the same way, depending upon the number of years, you will get the discount. Next. See, this is the out of the court settlement which was not there previously. We have introduced out of the court settlement wherein the member gets some litigation. There is a gadbad at the hospital. So you need to settle it down. So how much the scheme can extend to you depends upon what category you are, how much the coverage you got. The monetary benefit of out of the court settlement will ranging from 25,000 to 2.5 lakhs. Next. Oh, this is all the different how much you get it. Next. Diagnostic centers. Next. Existing members also can increase their limits by paying the difference as calculated depending upon your individual scheme. Next. See, this is what 3-4 points. The argument is always the other insurance schemes are less, or so for that I can just in a tabular form, this is our own scheme. Our own means our own. We have all our own working. You have the familiarity with our office bearers and how to approach. Insurance schemes not in our control. Funds with us which can be utilized for our own members' benefits. In the insurance schemes, you will find small prints wherein people do not read them. And finally, when the case comes, whenever you are in the litigation, then the particular company will show that this is the terms and conditions. Whereas we don't have anything that small printage, small prints. Everything is transparent. Next. This is about since the inception of the scheme, 97 in United AP, 97. So we had about 450 cases from that time and till now, including the combined state benefit, what we have given from the scheme till now roughly extends up to 80 lakhs. Next. You all know that the Telangana IMA has started a health insurance scheme. This is a benefit scheme, not charging anything except the administrative charges. So this is how you have to tell your members that not only you get the membership in the schemes, but you will be eligible to become a member in the health insurance scheme by paying nominal administrative charges. Next. Of course, the managing committee, administration. Next. The council, which was not there previously before 2018, it is now council is formed for a better implementation and giving facility. And next. So this is all the what is the procedure you have to follow whenever you have got a litigation. You have to just send the complaint, whatever you get, legal notice to the scheme office, and we will take care of it. This is the legal, revised lawyers' fee structure. Members can engage their own advocates provided they are willing to pay for the difference of amount whatever the private advocates demand. This is most important. Guidelines from what you have to do. First thing is, whenever there is a notice, our members become panic. So the local branch of IMA properly told about the course of the treatment. Once you spare few minutes in convincing the patient properly, the attendants, the litigations will come to nearly 50%. Mainly the lack is we do not explain them properly. So that is the reason, apart from many other reasons why we get into litigations. I think in short, this is what I wanted to express. Thank you one and all for the patient listening.
Thank you, sir. I would like to invite Dr. Vijay Mohan Reddy, sir, to present a memento to Dr. Sampath Rao, sir.
If at all anybody has got any suggestions or questions regarding the PPW scheme, of course in the council it is already there, but here also if somebody has got any doubts, we can clarify.
Thank you very much, sir. Now moving on to our scientific sessions, and we are starting the session with a very important and very good session for all. So I would like to invite Dr. P. Chandramati Garu onto the dais. Dr. P. Chandramati, she is a senior consultant gynecologist and obstetrician and director of Sri Chandra Hospitals, Karimnagar, and she is professor of Obs and Gynec from KIMS, Karimnagar, and currently she is FOXY president, Karimnagar, and her special interests are high-risk obstetrics and infertility. And I would like to involve our other esteemed chairperson, Dr. Kasturi Pramila Garu. She's from Warangal. She's a senior consultant obstetrician and gynecologist there, and director of KPMM Nursing Home. And she is past president of FOXY Warangal and past national vice president. Presently, Madam is IMA Central CWC member. I'd like to involve the speaker of first speaker of today's session, Dr. Chinmayi Ratha, onto the dais.
సభకు నమస్కారం. I am very proud to introduce eminent speaker Dr. Chinmayi Ratha. She is from Hyderabad. She did her MS OBGYN, MRCOG UK, FIM SA and FICOG. Director Resolution Fetal Medicine Center, Hyderabad. Lead Consultant Fetal Medicine, Yashoda Hospitals, Hyderabad. Present Chairperson of Perinatology Committee. President SFM Telangana Chapter. She is not a national faculty. She is also an internationally known faculty member. I welcome you, madam. Please present your topic.
A very good morning, respected chairpersons and honorable dignitaries present here. At the outset, I would like to thank the IMA Telangana senior leadership for this opportunity to address a congregation of all specialities, because we are very used to speak to all our obstetrician colleagues, and I'm very happy to be with my Karimnagar obstetric and gynecology family here. But when we get a chance to address all the other specialities, that is a opportunity to understand the involvement of every specialty in our problems. So recurrent pregnancy loss may not sound like a very exciting, cutting edge topic to others, but understand that it's a very, very major problem for obstetricians and gynecologists. It has remained like that. And for all other specialities, sometime or the other, you will come across a patient who is struggling to get a successful pregnancy, and then you will wonder why this is happening, why things are not working out for this in a country which otherwise is struggling with a population problem. So most of the pregnancy losses actually are not even clinically known. Whatever we see as pregnancy losses are only the tip of the iceberg. So a lot of pregnancy losses are subclinical and we don't actually detect it. So what we detect is a very, very small proportion, and of that, recurrent losses, that is a woman unable to bear a successful pregnancy repeated number of times, happens to almost 1 to 2% of our population. So it is not a very rare problem, it's a common problem. And the prevalence depends on the the gestational age at which the losses are happening. The prevalence of losses at the earlier gestation age is even more. And it leads to a lot of heartburn, because achieving a pregnancy is one of the biological goals of humankind. In fact, the only way human race has continued towards the centuries is by pregnancies which lead from one generation to another. So a failure in that process is a very, very intimidating process for the entire family as a whole, and the couple and the woman in particular. So if you see 2% of pregnant women can experience 2 consecutive recurrent pregnancy losses, and about 1% may have even 3 consecutive pregnancy losses. So when we talk of recurrent pregnancy loss, for my obstetric colleagues, I just want to put this in perspective, that the latest definition has put the pregnancy losses before viability in this group of what we call as RPL, or recurrent pregnancy loss. So the gestational age at which we define pregnancy loss is before the period of fetal viability, that is 24 weeks. So when repeated losses happen before 24 weeks, we call it recurrent pregnancy loss, but we do not include extrauterine pregnancies or molar pregnancies in this group. So only intrauterine viable pregnancies which are lost before 24 weeks is covered under this topic. Now, again, why am I talking to all these specialities when it is such a pregnancy related issues? Because you have to choose your own challenge. So the challenge of recurrent pregnancy loss is not only for an obstetrician, but for a physician who's dealing with a person with the conditions that we will be discussing that may eventually land her up in a pregnancy and cause a loss of a pregnancy. So when you look at the risk factors for recurrent pregnancy loss, there is a whole gamut of risk factors, starting from genetic factors, anatomical factors, autoimmune diseases, infections and endocrine factors, although a large proportion, 40 to 50%, remains unexplained or unknown. Now, why we need to alert all the physicians about this is, you will have patients with endocrine disorders that are being treated. You will have patients with, some congenital renal abnormality who's being detected. Now, all these women are at risk of some or the other risk factor that can lead to pregnancy loss. And that awareness has to start. See, earlier what was happening, women with severe morbidity, children with severe morbidity were not reaching that age where they were going to get pregnant, or they were not able to get married and have pregnancies. Today, thanks to all of you, health sector has got better. People with severe morbidity are reaching that stage where they are getting married and looking for pregnancies. So, correcting these problems before they embark on a pregnancy will help in reducing the burden of recurrent pregnancy loss. So we have 2 or 3 important global bodies which give us guidelines regarding these important problems. And we have the ESHRE, the ASRM and the RCOG. So if you compare their latest guidelines on recurrent pregnancy loss, age, anatomical factors, antiphospholipid syndrome, embryonic factors, endocrine factors, genetic issues, lifestyle factors, and all the preceding pregnancy losses are all risk factors for recurrent pregnancy loss. And lifestyle modification is something which comes in the gamut of everybody, even before the obstetrician comes into the picture. So what is preventable? I think of all these things, counseling women about not delaying their pregnancy a lot, detecting antiphospholipid syndrome whenever it is detectable, even with small warning signs prior to pregnancy, endocrine factor corrections, and lifestyle modification. So when it comes to investigation, the good news is a rather non-invasive and cheaper investigation like the ultrasound has now been of very, very significant use in detecting congenital uterine anomalies. The latest 3D ultrasound images can be so good that what the guideline says is MRI is no longer a first line option for detecting these problems. So if you have a woman with recurrent pregnancy loss, a good 3D ultrasound, which can be almost done bedside for most of these women, would help us do that. Now, when you find uterine anomaly, you should look for other urological tract anomalies. So in the same corollary, if somebody is treating a woman for a urological tract anomaly, think of uterine anomaly even before they come to that age of getting pregnant, because that would solve a lot of problems before they actually start. If you detect an anatomical problem, the correction has to be a surgical correction, and there is now evidence to say that surgical correction of these problems by the gynecological surgeon will help in improving the future pregnancy outcomes. So if there is a septum, resect it. If there is an abnormal uterus, try to correct it. If there are fibroids or polyps, try to remove them. Now, what can we do to help women with recurrent pregnancy losses improve their future pregnancies? If it is a mid-trimester miscarriage, which is more because of a cervical incompetence, then probably looking at it early and offering a cervical cerclage may help. Now, all of us who do this again and again, we know that it's a desperate measure, and now the indication for cerclage is a history-indicated cerclage. So we can put in a cerclage, although it's not pure evidence that it is going to work. But as a desperate measure, one can put in a cerclage if it is because of cervical incompetence. Now, this may interest our physician or endocrinology colleagues that whenever we have an abnormal thyroid function and the presence of anti-TPO antibodies, the loss of pregnancy is a reality. So in case you're treating a woman for these conditions, or somebody who has hypothyroidism long-standing, she should be advised that before she plans a pregnancy, get the anti-TPO antibody levels checked. If they are high, the chance of pregnancy failure is high. The other problems that we have always worried about, PCOS and prolactin and all kinds of things, actually have not stood the test of evidence, and evidence says we don't need to test for all of them in cases of recurrent pregnancy loss. But testing for TSH and anti-TPO antibodies makes sense, and it should be good to delay a pregnancy in case the TPO antibodies are very high. Again, if you compare the three bodies, there is always little disparity in the guidelines, but for all practical purposes, supplementing thyroid in women who are known to be hypothyroid, vitamin D supplementation, and treating prolactinemia when it is proven hyperprolactinemia may help in some cases. What are the lifestyle changes? We always talk of lifestyle changes, but if you again break down into different pieces, only smoking and probably, avoiding extremes of BMI is something which is related to this kind of a scenario. Alcohol consumption, it won't be directly related to recurrent pregnancy loss, but these are all good practice points. I mean, there will be no harm. Everything that we do in medicine has to pass through the filter of do no harm. So, improving lifestyle of a couple is not going to do any harm, and sometimes it can have, parallel benefits in their situation. Genetic factors. When there are very early losses of pregnancy repeatedly, one has to think that there may be a genetically abnormal embryo there because of which it is unable to thrive. So in the genetic factors, establishing it is very difficult, but as genetics is advancing, there are newer methods of testing the products of conception in a pregnancy loss, and if the product of conception is tested via an array CGH, we are more likely to get the reason for why this problem happened. Doing random parental karyotyping for all pregnancy losses does not help, because now we know that karyotype yields very little information vis-a-vis the newer techniques like array CGH and exome sequencing. So when we are looking for karyotypic abnormalities, we are looking basically for unbalanced translocations. And that's why couples who say that we are completely normal, we never had genetic problem in the family, why should it happen to our pregnancies? That is because they may be carrying balanced translocations. A person with a balanced translocation will not have any problem themselves, but when they form gametes, they usually have unbalanced genetic material, and that leads to problems. So with these technologies now like array CGH, we are able to explain to some couples why this problem is happening. But again, having a product of conception array CGH which is abnormal only explains that particular pregnancy failure. Only if the parents are carriers of this problem, then it can explain recurrent pregnancy loss. Otherwise, just one pregnancy loss where the chromosomes are abnormal is not enough to prove that that is the cause for recurrence. So, checking, prenatal genetic studies can be done because the fetal karyotype is important or the fetal genetic composition is important. If it is proven that that is the reason for pregnancy losses, one can opt for a pre-implantation genetic diagnosis in an IVF scenario so that you avoid repeated losses and that the stress that comes with it. So parental karyotyping is not recommended as a routine basis by all bodies, but it can be done in some cases to prove unbalanced translocations. So here what is important is, unless you have a proof of what is going to be the chromosomal condition of the next fetus, you cannot just predict how many of these fetuses will have problems. So if the parents are carrying balanced translocations, they may or may not have an abnormal next pregnancy. So if you want to relieve them of the stress of a pregnancy loss due to this, a pre-implantation testing is always better because it does not predict how many people will have unbalanced translocations. Testing the male factor for sperm defragmentation and all those things have not really stood the test of evidence, and that is not recommended. So what is the therapeutic interventions that can be done? Again, like I said, we keep on harping on lifestyle, but it comes down to again smoking and alcohol and maintaining your body weight, because all the other things have not been shown to be useful in recurrent pregnancy loss. So thrombophilia screening, it is something very dear to all of us as obstetricians. But again, like I said, many of these patients might present with thrombotic episodes in the non-pregnant state, and that is where the physician can get alerted to these possibilities and alert the woman that if you embark on a pregnancy, do this. Because one concept which we lack in our country is pre-conception counseling. Women always come to us after they are pregnant and often 3-4 months into pregnancy. So if as physicians you can guide them to a pre-conceptional checkup with an obstetrician, then it helps in optimizing all these scenarios. So these are the common tests that we do: lupus anticoagulant, the anticardiolipin antibodies, and the beta-2 glycoprotein antibodies. So this is the international consensus statement on how do we diagnose antiphospholipid antibody syndrome in terms of obstetric performers. So we have to take the history of any vascular thrombosis, previous obstetric history, and there are definite lab criteria which help in diagnosing it. So a triple positivity, a woman who's LA positive, ACL positive, and beta-2 microglobulin glycoprotein antibody positive has a poor prognosis of having a successful pregnancy. So these women can be started with low dose aspirin 50 to 100 milligrams per day before they get pregnant. Pre-conceptional aspirin helps in a group that is a proven thrombophilia. And of course, if they have to continue the pregnancy, then at the positivity, when the urine pregnancy test comes positive, this aspirin is to be supplemented by low molecular weight heparin. So this is the only justified use of aspirin and low molecular weight heparin in obstetrics as of now. Immunological screening has not shown useful. ANA antibodies may be done just as an explanatory point of view, so that it rules out, because everybody will tell them about ANA antibodies, so please do them and tell them that this is not the cause of your recurrent pregnancy loss. Giving these medications, hydroxychloroquine or steroids or immunoglobulins, has not proven the test of evidence in every case, but I agree that individual cases may merit the use of these conditions, provided the doctor has worked it up correctly and done an individual counseling with the patient. Infections, not all infections, and definitely not the torch infections. So torch profile and giving rovomycin is complete no-no in recurrent pregnancy loss, but what helps is chlamydia, ureaplasma urolithicum, and this can be sometimes addressed by use of tetracyclines, and if it is tuberculosis, then appropriate treatment for the tuberculosis helps. Environmental factors is something which is coming off, to the fore now, because we don't know the number of toxins we are exposing ourselves to, considering all these things, even paints, caffeine, all kinds of things have been implicated in environmental toxins. We don't know whether we are using it as an excuse because we don't know what else to explain, but keeping your environment clean, avoiding exposure to these kind of problems might be one of the solutions. Progesterone is one of our most loved medications in cases of pregnancy failure, and there's a lot of studies which say sometimes we overuse it, but if you see this, January 2020, the RCOG published a point where they said progesterone could prevent 8,450 miscarriages in a year. So it's a little hyped. We don't know whether it's a pharma-driven hype or just it's do no harm medication which we can give in pregnancy. But using progesterone in these cases is a peer-reviewed, accepted condition. How evidence looks at it is something different, but it's something very, very much prevalent and can be done. But using multiple progesterones does not help. So it should be good to use one kind of progesterone and stick to that, whatever suits your practice. These are again not recommended, that is lymphocyte immunological therapy, IVIG, glucocorticoids or heparin without evidence. But progesterone, intralipid, endometrial scatching and granulocyte colony stimulating factors, there is still a lot of difference between evidence and opinion. So what is recommended is product of conception microarray, 3D ultrasound, APLA panel, the TSH, TPO antibodies, prolactin and sugars, glycosylated hemoglobin for all these women, because sugars and thyroid are really important. Hereditary thrombophilias plus minus, parental karyotype not in all cases. So sperm DNA, PCOS, luteal insufficiency, ovarian reserve does not work. Vitamin D supplementation for some reason is being identified for all problems, and that can be given. What therapeutic interventions? People ask about multivitamins. You can give them, but they really don't help. It's more like a placebo therapy. And one should understand that doing nothing in these cases is also a good option, because really nothing helps. Whatever you're doing is more like a placebo effect. So it's a lot of problems, because counseling these patients, we've understood the problem very well, but counseling them regarding what is the next step is very difficult, because you're dealing with a lot of stress and psychological trauma there. So people keep on asking whose mistake, women go into guilt, they go into depression, marriages break, families get disintegrated. So one has to be very careful that the psychological impact of recurrent pregnancy loss should not be lost. And there again, one may be justified in referring to a psychiatric counselor, because it has to be taken seriously. Women can go into depression to the extent that they may commit suicide because of these conditions. So the negative life event like a pregnancy loss has to be addressed as a psychological requirement. What can we do? We should have a dedicated recurrent pregnancy loss clinic. In an obstetric clinic, in the waiting area, if there's a woman who's full-time pregnant, carrying her children, coming there to the OPD, happy families running around there, that adds to the negative impact of her pregnancy loss. So when you are dealing with these patients, give them an exclusive appointment, call them at a different time, see them separately, and don't make them repeat their history again and again. So have one place where you've written the history. Train your staff not to ask that question again and again. So just like you put some kind of a sticker on seropositive women, you can put a sticker on these files that people don't keep on asking them, make them wait a lot, or add to their psychological stress. So individual evaluation of the investigations which is appropriate to each woman or a couple should be done, and one has to tailor make one's care to address the psychological needs of these couples. Because we are revisiting the challenges and I have the opportunity of addressing a lot of other specialities, I am just alerting all of you that while recurrent pregnancy loss is about the 24 weeks and lesser pregnancies, that is more the remit of the obstetrician, there are also conditions like recurrent neonatal deaths, recurrent stillbirths, recurrent unexplained recurrent seizures in the children, recurrent neurodevelopmental delays. All of you as physicians and pediatricians will be seeing these conditions. Please alert them that it may be a genetic origin, it may be preventable, and it is very useful to identify, analyze and work up this before the next pregnancy. Don't send them at 20 weeks for a TIFA scan, because that will be too late for solving any of those problems. So recurrent pregnancy loss can be redefined in many ways, and our challenge now is to identify each of these problems and prevent it from happening again. So never let things that you cannot do prevent you from doing the things that you can. So do whatever you can. And although it is a recurrent problem, we should not be making recurrent mistakes. What we can do, what we should do, what we cannot do, and what we should not do should be something that we are clear in this particular topic. And what we know is just a drop. What we do not know is a big ocean. So every medical conference, we will be revising these problems to find more and more out of what we do not know and make it into the what we know category. And remember, our first principle of medicine remains, first do no harm. Thank you very much for a very patient hearing.
Thank you, Chinmaya. Thank you. A small question from my co-chairperson, Dr. Chandravanti.
Hi, Chinmayi. That was a scintillating talk. No wonder. I just have a small question. With regard to this recurrent pregnancy losses in Rh negative pregnancies with ICT positive, indirect home stress positive, how to counsel the patients with regarding to the coming pregnancies? Whether should we counsel them that the prognosis of the next pregnancy depends on the titers, or do we have anything to do with this exon sequencing and microarray CGH?
So ma'am, when a woman is losing a pregnancy because she is rhesus negative and she has antibodies against the positive fetus, she will only have a problem if the fetus is rhesus positive. So we need to test the partner. If he is homozygous positive, then all the fetuses will be positive. So in that case, if the titers are very high, we start IV immunoglobulin in the early pregnancy and then put her on a follow-up for MCA Dopplers. If there is fetal anemia, then it can be handled by intrauterine blood transfusion. So early detection will help prevent problems in the next pregnancy. If she is having very high titers and she is having recurrent high drops, there is a small, window where you can offer them a gamete donation or an embryo who's rhesus negative. I have one such patient who's lost 7 pregnancies despite many these things. So she had this counseling and she underwent an artificial reproduction, and she has a RH negative embryo, and then she had a good outcome. Because it all depends on the blood group of the embryo.
Thank you, Chinmay.
Thank you.
Thank you, madam. Now I request the chairpersons to present a memento to Dr. Chinmay madam, and I request Dr. Sadarunisa madam and Dr. Geeta madam to please come on to the dais. Dr. Sadarunisa madam. I request Dr. Chandramati madam and Dr. Pramila madam and Dr. Geeta madam to present a memento to Dr. Chinmay. I request Dr. Geeta madam to present a memento to Dr. Pramila madam. I request Dr. Geeta madam to present a memento to Dr. Pramila madam. And I request Dr. Sadarunisa madam to present a memento to Dr. Chandramati madam. Thank you, madam. I thank all the dignitaries for their valuable time.
Very good morning to all of you. I request all the state leaders of IMA to assemble at Hall B for state council meetings. Thank you very much.
Thank you, sir.
We'll move to next session. Now I invite Dr. Jakula Vijay Rao, Honor Secretary, elect IMA Telangana, Finance Secretary, IMA for Family Security Scheme, President of IMA Hyderabad East Branch, National President of Indian Association of Occupational Health, Retired Head, Medical Division of Nuclear Fuel Complex, Hyderabad. Please come onto the dais, sir. Dr. K. Shamsundar, sir, the first pathologist of Karimnagar, Founder President, IMA Telangana State, Past President, IMA Karimnagar, Associate Professor of Pathology in RVM Medical College. Welcome on. Now I invite Dr. Shankar, sir, from Jagityal, Senior Consultant Physician Jagityal, Gold Medalist in MD General Medicine, Fellow of Indian College of Physicians, Academic Senate Member of Shatavana University, Karimnagar, President of APA Jagityal Chapter. Now I invite the next session speaker, Dr. K.C. Mishra, sir, onto the dais.
Give me the slide.
Good morning. Very good morning to all of you. So we are moving on to second session. The second session speaker is Dr. K.C. Mishra. He has done his super specialization in nephrology. He is HOD Critical Care, Yashoda Hospital, Somajiguda. He has more than 10 publications and 2 original research articles. Area of special interest is ECMO, extracorporeal membrane oxygenation, critical care and nutrition. Without wasting our much of time, let us hear from Dr. K.C. Mishra Garu.
Yeah, this ECMO, ECMO, it is a lifesaver. We have heard about it during COVID era, how it saved many lives. So ECMO, as Dr. Vijay Rao told, it is extracorporeal membrane oxygenation. It is a lifesaver. It is a prolonged mechanical cardiorespiratory support, especially indicated in cardiac failure and as well as in respiratory failure or both. So let us hear from Dr. K.C. Mishra, who is an expert in ECMO from Yashoda Hospitals. So he is going to speak on ECMO regarding the initiation, indications and maintenance and weaning also. So let us hear from Dr. K.C. Mishra, expert in ECMO. It is a lifesaver. Thank you.
Thank you very much, sir. Respected chairpersons, all my dignitaries, my senior, my juniors and my colleagues. So at the outset, I need to thank IMA Telangana to giving me this opportunity to be the part of this national conference. And for the first time, I'm hearing something like the first talk is in obstetric and second talk is in ECMO in my life, 15 years of my career till now. Really interesting to see the scope of medicine. You can see like the third talk, I believe, is in orthopedics. So ECMO is, let's say, like from 2009 onwards, it is like more and more being used. And in our hospital, in the last 3 or 4 months, we have used almost 7 or 8 ECMOs with a good result. Let it be VV or VA ECMO. So coming, it's a little difficult, yeah. Yeah, sorry for this. Basically ECMO. So what do we mean by ECMO? So ECMO is nothing but an extracorporeal life support. Extracorporeal means anything which is done outside. Let it be a dialysis also, which is an extracorporeal thing. In ECMO, there is a circuit, there is a machine by which the oxygen will be given to the blood. In the meantime, we will take out the carbon dioxide. It can be used in both failing lung, heart, or in both cases. Sometimes we support the lung, sometimes we support heart, or it can support both of the heart and lung. If you see the extracorporeal life support, it is usually divided into 2 things. One is ECMO, extracorporeal membrane oxygenation, and ECOR. ECOR is one of the things which is coming up in a bigger way, where we need to remove only carbon dioxide. There is no much of oxygenation issue in those cases. So coming to the history, we know like history is very, very important whenever it comes to anything. By history we will learn, and by which we can train ourselves, do better things so that in future we can do better things for our patients. Coming to the history, the first ECMO which was started was in 1971. If you see, this is nothing but a extended type of cardiopulmonary bypass, what they used to do in cardiac surgery cases. If you see the pump below, which was a huge one, and the circuits and everything was like really cumbersome. Now things have changed a lot. If you see, this is the first ECMO survivor. She was at the age of 1 day, they have started ECMO in this girl. If you see the girl Esperanza, she is her photo at 21 years of age. If you see, this is an article, which is a paper cutout. It's very, very interesting. If you, this is an Indian girl, actually father of our ECMO, Bartlett. He started ECMO on this girl when she was in the neonatal age. And that lady, once she became adult, she went into the medical schools. That important it is ECMO nowadays, where we can save of a person's life, let it be in the neonatal age group or in adult age group. Nowadays things have changed a lot from that cumbersome and big machines. Now we have the machines which are there on the right side, which are very small, which can be kept bedside. And nowadays we are shifting patients on ECMO all over the India. If you see during the COVID time, almost 100 patients got airlifted from different parts of India to use the hospitals. What are the indications? I will not go into detail because it is going to be difficult and it will take a lot of time. Coming to the indications of ECMO, there are three basic things. One is bridge to recovery. Like in patients, like let's say a COVID patient or H1N1 patient where the lung is really damaged, or a myocarditis, severe LV dysfunction patient where we are starting ECMO. These are the cases we believe these patients are going to recover. This is a case where we use ECMO bridge to recovery. We start ECMO, the patient will recover, we'll remove the ECMO. Second is bridge to decision. Sometimes patient will be so sick that they are not going to give you time. In those type of cases where time is very, very important, patient is dying, at least to get time we need to start an ECMO. For an example, when I was there in my previous organization, there used to be a cardiologist who fly down from Chennai. He had already severe LV dysfunction, he had an ICD in place and all, he was having continuous VTs, for which actually he came down. And with all our efforts also, he continued to have VT, continuous shocks, he was becoming unresponsive and all. He got intubated. With all efforts also, it was not getting settled down. To get some time in that case, we have started on VA ECMO. Afterwards, we placed a LVAD. In that case, left ventricular assist device. On left ventricular assist device, at least we could make him survive when he left. Afterwards, he underwent a transplant. This is bridge to transplant destination therapy. Sometime, once you get time, you can think of what next to be done for that patient to keep him alive. So for that same example, let's say bridge to decision, we have got some time, went for LVAD, then afterward the same person went into transplant. So indications coming to VV ECMO. VV is veno-venous, where we support only the lungs. Okay, when the lungs is the only stack, heart is looking good, heart is functioning well, in those cases we think of VV ECMO. VV ECMO, if you see, many guidelines are there which gave different forms of indications, but the two most important, if you see, one is ELSO and second is EOLIA. The salient points out of that is, in VV ECMO, whenever somebody's oxygenation is very, very poor, when the PF ratio is less than 80 or less than 100, where we believe their mortality may go beyond 80%. These are the cases where if you are not doing anything, they are going to die. These are the cases we need to think about a VV ECMO as early as possible, not too late, where if you are initiating too late, these people, they will develop some other organ dysfunction, maybe some infection, some organ dysfunction. When you are starting ECMO in these cases, later date, their chances of survival comes down. Murray score is one of the important score. Whenever we believe the Murray score is 3 or 4, these people have a mortality of 80%. These are the cases where we need to think about ECMO early. When it comes to VA ECMO usually we start when the heart function is not good. The patient is having severe LV dysfunction, may or may not have lung involvement, but if lung and heart both are involved also, we have to think about VA ECMO. The most common indication, if you see acute MI with severe LV dysfunction, fulminant myocarditis, severe cardiogenic shock, peripartum cardiomyopathy, these are all, like most of the time, recoverable. But at that point of time with the severe LV dysfunction, they may have recurrent arrhythmias, and those things can cause demise of the patient. In those cases, to buy time, and we can start ECMO. The horizon of ECMO day by day is increasing. If you see nowadays, we are starting ECMO. These are the basic things. Whenever there is a myocarditis, cardiac arrest, post-cardiotomies, arrhythmic storms and all those things, whenever the heart is affected, severe LV dysfunction, these are the cases where we can think of a VA ECMO, where the heart can be supported. eCPR. This is an interesting thing which is coming a bigger way. So what I am telling now is not only the heart and lung, now the horizon of the ECMO is slowly increasing day by day, and ECMO is becoming safer day by day. If you see eCPR, this is an interesting thing which is coming up in a big way. Patient having a cardiopulmonary arrest, in those cases, by only CPR, the survival chances are less than 20%. If you are starting ECMO early in those cases, mostly VA ECMO, then the survival chances increase by 14%. In this case, if you see, they have done a study. This is a randomized control study over 12 years. They have done almost 5,000 plus patients were enrolled in this one, where they have seen almost 17% increased survival when they have started eCPR or ECMO during CPR. Similarly, if you see this one, this was is a AHA. American Heart Association study. This, they have started eCPR in hospital cardiac arrest in pediatric patients. Pediatric patients, they have seen almost 27% mortality benefit. So eCPR is also coming up in a big way. If your hospital having the facilities of ECMO and all the people are there 24/7 and the patient is having in-hospital cardiac arrest, if the patient is not recovering over 5 to 10 minutes of CPR, we can think of starting of ECMO in these cases also. VA ECMO in sepsis. Initially, if, like maybe 5 or 10 years back, if severe sepsis is one of the contraindication for ECMO, nowadays we are seeing that in severe sepsis, when there is a cardiac involvement or lung involvement, severe cardiogenic shock and all, in those cases also, if you are starting ECMO early, that is beneficial. If you see this graph, actually the pointer is not working properly. If you can start ECMO early, within 4 hours of a patient who is having severe sepsis with cardiogenic shock, they have a almost survival of 60%. In the same case, if you are starting late, after 1 or 2 days of severe sepsis, the mortality from survival chances from 60% comes down to 20%. So in sepsis now, it is slowly coming up, but sepsis, severe sepsis with multi-organ dysfunction, if heart is involved, in those cases, if you are starting ECMO early, there is a significant mortality benefit. I will show one case where we have started and the patient survived. This is an interesting article. This lady who is standing, she was waiting for the lung transplant. She had a severe lung infection. Both her lung has to be, pneumonectomy has been done. Both the lungs has been removed. For 6 days, she survived only on ECMO. Without ECMO, she should not have survived. 6 days, she survived only on ECMO. Then she underwent lung transplant. This is the photo post lung transplant. So this how important it is, the ECMO nowadays. If you see extracorporeal membrane oxygenation, now there is a dilemma, ethical dilemma also. When somebody is on ECMO, let's say VA ECMO, you are supporting the heart, the perfusion is going on, you are supporting the lung, the oxygenation is going on. How can you declare a patient dead if the heart is not beating also? If somebody is on VA ECMO, if the heart stops beating also, you cannot declare them dead. This is an ethical dilemma going on with VA ECMO. That important it is when it comes to ECMO. At this point of time, ECMO is very, very important to save lives. Now, why, and as I have told, like from 2009 onwards, the ECMO usage and all has increased drastically throughout the world. In India, we are seeing significant increase in users of ECMO over the last 5 or 7 years. If you see, this is the trial, the landmark trial, that is the Caesar trial in 2009, during our epidemic of H1N1, which was causing a havoc throughout the world. This Caesar trial came, which helped. Actually, Caesar trial shown that there was almost, if you treat 6 patients, 1 patient will survive if you are starting ECMO early. Coming to the component of the ECMO, I will just go a little quickly. This is how the ECMO looks like, the whole machine. There are cannulas, blood pump, membrane oxygenators. There will be controller and tubings. This is the pump, very small one. These are centrifugal pumps, silent, can be used for days together. We have used in one case for 62 days without any single problem. There is hand crank, it is machine operated. If that is not working, you can crank it and shift the patient wherever you want. These are the cannulas. If you see the picture, they are both side, the femoral, one side artery and one side vein has been cannulated. The right side is the artery with a graft. These are the cannulas. Most of the time we use 2 cannulas. Sometimes a single cannula with 2 lumens also can be used, which is not regularly available. This is the oxygenator through which the blood will pass. Basically, the pump will suck the blood from the patient, that is the drainage cannula. Then the pump will push the blood into the oxygenator. In the oxygenator, the blood will get oxygenated, then it will go back to the patient through a infusion cannula. So this is the sweep gas, or the blender, by which we can precisely set the oxygen and oxygen or FiO2. You want 21%, you want 100% FiO2, you can set through this one. And sweep gas flow will decide about carbon dioxide removal when it comes to ECMO patient. This is the console through which you can change the RPM, rotation per minute, to increase the flow of the ECMO per se. And that is a warmer. The blood need to be warm because the blood is going out, can be cooled. So to prevent that, we need to have a warmer. This is how it works. So there will be cannula, like a venous cannula or the drainage cannula, which will go to the pump by a suction pressure. That blood will go into the oxygenator where it will get oxygenated. then that blood will come back to the person. How it works, ECMO? It minimizes hypoxemia. We know the hypoxemia is one of the major causes why the patient dies when there is having significant hypoxia. It decreases hypercapnia. By decreasing hypercapnia or removal of the carbon dioxide will decrease the right heart strain, which will decrease their mortality. Most important is minimizes lung strain. When we keep a patient on ECMO, we decrease the lung ventilation strategy. We ventilate them with very minimal tidal volume, very minimal PEEP, so that the lung damage or injury should not continue to occur. The ventilator-associated lung injury can be decreased drastically when a patient is on ECMO. This is one of the cases, our case, where we have done even proning. We have prone the patient on ECMO because patient was not improving. Monitoring, there is, because ECMO is not without complications, monitoring is very, very important when the patient is on ECMO. We require more people, more staff need to be dedicatedly there for the ECMO patient. If you see, first is sensorium, they may bleed in the brain. Cannula sites need to be checked because they can bleed anywhere because of continuous heparin need to be given for these cases to maintain that, and the blood should not get clotted when the blood is going into your ECMO circuit. Limb ischemia, because big cannulas will be placed in your femoral artery or vein, they can develop limb ischemia. More so with the VA ECMO, pre and post membrane pressures need to be checked to make sure that your membrane is functioning well. ABGs need to be done more frequently. Whenever we are giving heparin, most of the time we give heparin to maintain the clotting anticoagulation bit on the higher side. We check the ACT more frequently, activated clotting time. When you are giving heparin, there is a possibility of heparin-induced thrombocytopenia in these cases. Resting lung ventilation, early mobility. In our cases, we do early tracheostomy so that we can give less sedation and mobilize them early. These are the complications. Per se, the most important complication, if you see bleeding, they can have the most dreaded one if they bleed in the brain. But we have never, luckily we have not came across any case we had bleed in the brain. They may bleed in the cannula sites and all. Infection chances are relatively high. They can develop acute kidney injury or any other organ dysfunction can be developed in this kind of cases. Special consideration, limb ischemia, as I have told, is important to have a perfusion cannula when it comes to VA ECMO. Harlequin syndrome, I will not go into detail. This is a dangerous thing when it comes to VA ECMO. The upper body will receive only deoxygenated blood, whereas the lower body will receive the oxygenated blood. Reef circulation can happen if both the cannulas are very closely opposed. Weaning, again difficult. VV ECMO, when the lung improves, oxygenation improves, we can slowly decrease the sweep gas and remove the ECMO. In case of VA ECMO, if the heart function starts improving, slowly we decrease the flow. Once the flow comes down to 1 to 1.5, then we can remove ECMO. I am not going into detail of those things because in 20 minutes it's impossible to tell everything in detail. So now coming to few of our experience, like I will just tell briefly 3 of our cases what we have done recently. One case which is there still in my ICU or not, like yesterday I have shifted her to ward. See, this is a 37-year-old person, young fellow who is a software engineer, came with typical signs of cough, shortness of breath and fever over 4 to 5 days. The outside CT they have done, which was showing bilateral patchy consolidation. This is the outside CT, if you can see, significant consolidation bilateral. He was severely hypoxic. He got referred to our hospital. On the first day itself, we have to intubate him because his PF ratio was very poor. I believe you may not be able to see the ABG what I am showing there. PaO2 is only 47 with 100% FiO2. His PF ratio was 47 only at the time when he presented to us. We proned him. With 3 sessions of prone also, prone was not helping him. His Murray score was more than 3. Whenever somebody is not responding to prone, after intubating, there is no other option left for this kind of cases to treat. So after 3 days of proning, we thought that we need to start VV ECMO in this case. Actually, his influenza came positive. We have started VV ECMO. This was the X-ray, if you see, whiteout lungs on the day 1. On day 8 also, we were not able to wean the ECMO. He was still requiring almost 100% oxygen through ECMO. On day 8, we have done a CT scan again. The patient on ECMO wheeled the patient to CT scan. We have done a CT again. The CT is showing like this. The CT is really pretty bad. So on day 8 also things were bad. We didn't know like how the things will be in future. But slowly things improved. The next 8 days, we could remove the ECMO. So we got decannulated on day 16 of ECMO. After 4 days of decannulation, we could remove the tracheostomy. This is the patient with tracheostomy was mobilizing outside in my ICU. After shifting out in the ward, he was getting mobilized. The next photo. This is the same person came for follow-up after 10 days of discharge. See, this patient would have died if not have thought of ECMO or started ECMO in this case. For a second case, if she like 51-year-old female, this is quite interesting in the sense of medical way. Like there are few medicinal things also we had issues. For diabetic hypertension, obese lady, again presented with cough expectoration with chills and fever. He was admitted outside. She got intubated there itself, then shifted to us because he was not improving. If you see the outside also, the procalcitonin was high. That means he was having some secondary bacterial infection or some bacterial infection is going on. Her TROP-I was positive and pro-BNP was high. That means the cardiac involvement was also there. The differentials we thought viral pneumonia with a myocarditis because of TROP-I and pro-BNP was elevated. Secondary bacterial infection in view of the procalcitonin, which was significantly high in this case. We have sent a ANA profile. Our physician sent a ANA profile thinking of something like there was some rashes and all. The ANA profile came out to be significantly positive with Rho, SSA and all those things, which points towards a mixed connective tissue disorder. Then there was a dilemma that apart from this some infection, there may be some mixed connective tissue disorder flare. Then in this case, this was the CT when we have done. If you see the CT, there was significant involvement. It was not looking like pneumonitis, it was looking more of a pneumonia. And we don't see this kind of pneumonia and mixed connective tissue disorder flare. We prone the patient. We have a protocol. If somebody is not maintaining oxygen, we have to intubate and prone them. After 3 sessions of proning, antiviral, then diuretics and antibiotics and all things were not improving. There was a dilemma to start IVIG or plasma exchange. In those cases, we do C3, C4 levels to rule out there is a flare or not. C3, C4 levels were normal, so we didn't feel that it to be a mixed connective tissue disorder flare. So we just continued with our treatment. One fine day in the night, in prone position, this is her saturation. She dropped her saturation to 73. She would have died. At night, 11 o'clock, we initiated ECMO. But the dilemma was there was some cardiac involvement also. We need to start VV ECMO or VA ECMO. But when we have checked the cardiac function was good. When the cardiac function is good, better to go with a VV ECMO than a VA ECMO. We underwent a VV ECMO in this case. After starting ECMO, you can see the SATs were 98. So she improved. We continued VV ECMO. On day 10, we could decannulate her and we discharged her. Case 3, this is now the live case which we have in our ICU, 39-year-old female. Actually, she underwent LACS somewhere outside. After 7 or 8 days of LACS, one more minute, sir. LACS, she presented to the same hospital with significant PV bleed. When they have done an ultrasound and CT, they have seen that intrauterine bleed, atonic uterus, she was bleeding everywhere. So the diagnosis was puerperal sepsis in DIC. They opened up, they have done a hysterectomy in that case because the bleeding they were not able to control. Then she required many blood products during that thing and they shifted her intubated, in severe shock, requiring many vasopressors when she came to our hospital. 2D echo, when we have done, it was severe LV dysfunction. So in that case, we started on vasopressors. She was severely hypoxic, requiring almost 100% oxygen. On that also, our SATs were 82% only. CT chest, CT abdomen, we have done in our hospital because we need to have an answer why everything is like, why is she so bad? If there is some infection focus, something is there that need to be taken care of. For our surprise, the CT chest shown bilateral pneumonia and there was PT also, pulmonary thromboembolism, which were like we were not thinking something like that, whereas abdomen was normal. And she was having severe LV dysfunction. Then sepsis, puerperal, bilateral pneumonia, ARDS, pulmonary thromboembolism. She was in DIC, PT and repeated, everything was grossly deranged. Her fibrinogen level was low. Cardiac dysfunction, septic versus peripartum cardiomyopathy, maybe both the things were there. Pulmonary edema. Her BNP was also significantly elevated. In this case, we thought of thrombolysis, but a recent history of surgery with the DIC, we didn't dare to thrombolyze her. We started on anticoagulation, we started diuretics, prone ventilation, then we started VA ECMO. Thought was there, but we waited. This was the CT scan. If you see, both the lower zones were significantly involved. There was significant consolidation bilateral lower lobes. This was the your mediastinal window. If you can see bilateral upper lobe, there is some pulmonary thromboembolism in the same case. She was relatively doing well. Actually, on day 2, she was maintaining the vasopressor requirement and all were improving, oxygenation was improving. Suddenly on day 3, she started worsening. She started having high-grade fever. She started worsening on her blood pressure. She was requiring all the blood like inotropes and vasopressor required, noradrenaline and vasopressins. With that also a systolic PP was around 70. And that was the time we discussed with the family and we started on VA ECMO. Slowly, after starting VA ECMO, she slowly stabilized. And on day 5, we could decannulate her from the ECMO. And the oxygenation slowly got better. Then I removed the ECMO on day 5. Tracheostomy got decannulated. She is having some critical illness, myoneuropathy and AKI, which is slowly getting better. Actually, I shifted her to the ward yesterday. This is her picture, like after decannulation, when the husband is feeding her. So these are few cases where, like, without ECMO, they would not have survived. Okay, so ECMO horizon is increasing day by day. A few days back, which was a contraindication, now it is one of the indication of ECMO. Still very much underused in India, maybe because of many reasons, like finances is one of the biggest reason when it comes to ECMO. We need to consider early in suitable patients. Maybe ECMO going to be the next ventilator in near future. Thank you.
Thank you. Thank you, Dr. Misra, for your excellent presentation on ECMO. From audience side, any questions, please? If no questions, the session is concluded.
Very impressive. Very impressive.
I request the chairpersons to present a memento to Dr. K.C. Mishra, sir. Moving on to the next session, I request the senior consultant of Karimnagar, Dr. Raghuraman sir, to please come on to the dais. Dr. Raghuraman sir is a well-known figure in Karimnagar. He is a senior consultant physician and former API chairman, a man of true values, a philanthropist and inspiration to many young aspirant doctors. I request Dr. Pabbai Kailas Garu, Senior Consultant, Senior Interventional Cardiologist, to please come on to the dais. Dr. Pabbai Kailas sir is the first cardiologist of Karimnagar and of North Telangana. He is a Senior Interventional Cardiologist and Director of Pabba Super Specialities. I request Dr. Vidyasagar sir, cardiologist, to please come on to the dais. Dr. Vidyasagar sir is a senior interventional cardiologist and he is a consultant at Apollo Reach Hospitals and former consultant at Medicover Hospital, and he is a consultant at Rekha Sagar Hospital and Lakshminarayan Hospital. And special areas of interest of Dr. Vidyasagar are complex primary angioplasties. Now I request the speaker for today.
Dr. Ravi Kumar. I request Dr. Ravi Kumar, N. Ravi Kumar, HOD, Professor Nilafar, and National Vice President, Pediatric Department, to come on to the dais as a chairperson. He is my classmate and Dr. Elnam Reddy's classmate.
Now I request Dr. Kasturi Ravinder Reddy Garu to please come on to the dais.
This is moving slide. Should I take this mic now?
Topic. Prevention of good morning, everybody. It's my privilege and pleasure to introduce the speaker, Dr. Kasturi Ravinder Reddy sir, HOD of Medicine, Pratima Institute of Medical Sciences, very close to the students community and to the API Karimnagar chapter also. He is a senior interventional cardiologist and a professor and HOD of Medicine, Pratima Institute of Medical Sciences. He is a gold medalist in MD Medicine from KMC, Manipal. He has to his credit 36 publications in various indexed journals, and he is the principal investigator in 3 international drug trials. Dr. Kasturi Ravinder Reddy sir will be enlightening us about most important topic in the present circumstances about prevention of CAD. I think now we will start, sir.
Yeah. Thank you for the nice words, sir. And good morning to everyone. And I stand before you for, as a default today, we have a speaker coming from Hyderabad. Dr. Srinivas Kumar sir was supposed to make it. For some emergency reason, he couldn't make it. So I've been asked to give a lecture on primary prevention of CAD. I take this opportunity to thank the organizers for giving this opportunity. So my agenda today is the introduction of increase in CAD in India. If I say the epidemic is high in the world, it will be an understatement. What is the cause? What can we do to prevent the rise of epidemic in CAD? And preventive concepts, primary, secondary and primordial prevention, and role of statins, and the Panchasutra for prevention of 81% decrease in potential. Now, we all know the developing nations, we call the BRICS nation, Brazil, Russia, India, China and South Africa. This, as we moving from a developing nation, an underdeveloped nation to a developing nation, the incidence of CAD is going up. So you can see the graph how it's gone up, and South Asia, India and China are having a huge epidemic. And the percentage of patients with first MI, if you look at our data, less than 40 years, I think my cardiac colleagues will agree with me, every 1 in 4 patient is less than 40 who comes to our, this thing. We are in a rural setup, now imagine that. That is the thing. If you look at the South Asian population, the youngest MI occurs in Bangladesh. There's some reasons for it. They overcook the food, the folate content is less. So that could be one of the reasons has been postulated. But we do see a lot of acute MIs, less than 40, almost 1 in 4. Now, international trends, a lot of preventive strategies have come up. The graph is coming down. France is almost stabilized. Finland, other USA, they're coming down from larger Pepsis. They've gone for a smaller Pepsis, and lifestyle, physical activity, everything has made a change. The thing is coming down. The trend is coming down. That's why India, we see more STEMI. In the Western data, we saw non-STEMI. This is the difference what we have. We probably should have less number of patients having STEMI. We see a lot of this thing now. Now what happens to India now? The rising prevalence, it's like a hyperbola. It is going up. The tip is not going to touch anywhere. This is going to be very disheartening in the years to come. So coronaritis in India, 3 to 4 times higher than the Americans, 6 times higher than the Chinese, 20 times higher than Japanese, and up to 40% of the patients are below 45 years of the age. Now we always think the CAD is prevalent more in the urban. But look at the surprisingly, the rural community, we all working in the 2-tier towns, we see a lot of patients coming, farming community, young people. We had a lady, just a mother of a 6-year-old child last week, had only 30 years having a massive myocardial infarction. So the physical inactivity, the calorie dense food, high fat diet, stress. So it's evening out. It's not urban or rural divide. Now we see both segments, we see them. Now, primordial prevention. When do we start primordial prevention? We say before the risk factors start, we should intervene them. So this is one data tells you that 300 autopsies of US war casualties, 77% had coronary artery sclerosis. could be some infective cause, could be something, but it tells you that we need to intervene early. And why the Indians are having the largest study came, it's called the Mr. Hart study, 15,000 population, 52 countries they've checked out, and you look at South Asian countries, they've looked into it, and the culprit was lipoprotein, so ApoB by ApoA ratio, hypertension, waist hip ratio, and exercise. These are the four common factors which are more common in the South Asian compared to the European and the Western data. So we are worried about this malignant CAD among vegetarians. We see quite a lot of them. It's not this thing, young South Asians and the serendipitous discovery of elevated lipoprotein A, small a. This is a culprit which is emerging. And so what is lipo? Is a missing risk factor. And when we have no traditional risk factors, that could be an answer. Then it causes premature CAD and a risk amplifier in those patients who have already traditional risk factors, and it predicts recurrent MI among those on statin therapy, and it's quite common in South Asian Indians. The restenosis is very high and a strong oxidation specific biomarker and a major carrier of oxidized phospholipids and LPA2. So many people come here. Now we used to see the trend like children bringing their parents to the hospital. Why my father having a heart attack? Now we are seeing the trend that parents are bringing the children with a heart attack. This is a paradox has come now. So somebody asks us, I don't have any risk factors. I don't smoke. I don't have hypertension, diabetic. Why do you have? So the answer is thrifty gene. It's a typical Asian phenotype, refers to certain unique clinical and biochemical abnormalities, increased insulin resistance, greater abdominal adiposity, lower adenopectin levels, and higher C-reactive proteins. This phenotype is very typical for South Asian population. This is the reason we can blame our genes. Although if you are fit enough, we can take solace by saying I have a thrifty gene. Now most of the cardiac OPDs we have risk calculators. There's something called Framingham risk score. They take 7 variables to calculate the risk factor. So at 10-year risk, what is the chances of him having heart attack? So they take age, systolic blood pressure, cholesterol, HDL, hypertension, cigarette smoking, and a diabetes. Based on this, most of you can have in the apps, you can calculate your risk of getting a heart disease in the next 10 years. Some things were added. The modification came in with some strong family history of CAD was added. Then it was taken off, but still holds good. The Framingham risk holds good. Now, does it have the same value for Indian population? So the adjustment US Health Summit gave a small warning for the Indian population. They said even emigrates in the Australia and New Zealand, the risk, if the risk is having 10-year risk is 14%, they added 10%, 24. In the British guidelines clearly tells you if you are an Indian, then your risk, you should multiply the Framingham risk score by 1.4. And the Arabia, Middle East also they have made it to 1.8. And clearly the ACC clearly tells you whatever score you get in the Framingham risk score, you multiply by 2. If you have a 10%, then it goes to 20% for Indian population. And the US Health Summit recommendations are being a little stricter. The waist now, what was 40 inches for a male, now it's become 35. Okay, the waist for female is 31. BMI is coming down, obesity guidelines are changing now. The blood pressure targets are more or less the same. The blood sugar values, HbA1c remains the same. Physical activity also more or less the same. So the waist ratio is coming down. We probably need to change our waist. Prevention and control of CAD in India, 80% of premature heart disease, stroke and type 2 are preventable. So the 80% are preventable, 40% of cancer is also preventable, death is inevitable, but it does not need to be slow, painful and premature. So superior doctors prevent the disease, mediocre doctors treat before the disease is evident, and inferior doctors treat the full-blown disease. That's what we are doing most of our setup where we have more of high-tech medicine. We probably don't have a primary preventive strategies to prevent cardiovascular disease. So primordial prevention, primary prevention, secondary prevention and tertiary prevention. So what difference can it make? If somebody's cholesterol is there, if you reduce by 50% with statins, the risk comes down by 50%. And if you look at the high blood pressure, which irrespective of the blood pressure tablet you use, you bring down by 6% diastolic, you are going to decrease the stroke by 42%. And see the smoking, 50%. We spend little time in the OP telling the abscesses of smoking. Such benefit is at 50%. Body weight, ideal body weight and waist size also reduces by this thing. Physical activity, the more said is better. And fruits and vegetables, we probably don't have so many servings per day. and if you combine all of them, we can reach 90 to 95% of risk. Primordial prevention, it should come from the pediatricians, general practitioners, internists. Nowadays, they say the NECP guidelines tell you anybody about 20 years, first time you can get a lipid profile today. They were telling about prevention of the risk factors. Primordial prevention is prevention of hypertension, prevention of hyperlipidemia. So that is what it is. So avoidance of tobacco, sedentariness, obesity, physical activity increase, healthy diet. Coming to the primary prevention, here the risk factors have come and the disease is not coming. So we need again same cessation of tobacco use, exposure, control of cholesterols, BP should all have to be meticulously taken care. The intensity of intervention, it's like a higher the risk, we may be more aggressive. Somebody like NECP guidelines tell you somebody is an established heart disease with CABG or a PTCA, the target level of LDL is 40 today. So the more risk is there, the aggressive intervention is also important here. And whatever guidelines you take today, total cholesterol, everything, the NECP clearly says LDL is a target for us. LDL is a target value for us. So any change, 30 milligram decrease in the LDL proportionally decreases 30% mortality. So that is the thing. So we don't have, all the guidelines clearly tells you the LDL is still our target for control of your lipids. Secondary prevention has to be done by the physicians and cardiologists and aims to avoid recurrent heart strokes. And we have the four pillars of our preventive secondary prevention like aspirin, ACE inhibitors, beta blockers and statins. Wherever indicated, optimal dose with guideline directed medical therapy has to be given. Risk reduction in 5 secondary prevention strategies. You look at the statins, almost 25 to 45% reduction. Smoking, again, non-pharmacological has more value than our all pharmacological. So smoking cessation 15%, ACE inhibitors 20, ASET 20 to 30. So when you have a combination of this, you probably reach a little better value. The small changes made by a large number of people results in a greater benefit to the society than the large changes made by a small number of people. And what we see here, the high-tech hospitals in India have the resources focused on tertiary prevention. We have something called now quaternary prevention. They are telling quaternary medical care. Things are coming up. Still, that is only about 1 to 2%. We need to, larger percentage of population still have a primary and a secondary prevention medications are required to be far more effective and it could be less expensive. So what do we, secondary prevention, what is the data in India? There's a small study called a pure study to clearly tell that we are not really doing a good job in even secondary prevention. So antiplatelet drugs only 25% of the people were getting. Beta blockers 17%, ACE inhibitors, ARB 20%, statin very low, 15. It's a very good molecule. So in low income countries that include India has the lowest use of all these drugs. So this has to go up to have a very effective secondary prevention. So number of deaths prevented from primary, secondary, irrespective of this slide tells you, irrespective of the age of the patient, irrespective of the gender of the patient, the primary prevention scores over the secondary prevention. Almost you can see the last all ages 80%, 70 to 80% primary prevention is still norm and 20% is going to be secondary prevention. The 4 more lives saved with primary than secondary. So primordial is better than primary and primary is better than secondary. So role of statin, you all know it's now the OTC drug. You can go to the US, you probably can't get a rabiprazole on a medical shop, but you can get a statin. So over the counter prescription, higher the total risk, the greater the benefit. The effectiveness of statins in patients with established, it's well established. Statins, primary prevention, secondary prevention, significant mortality benefit in either thing. So consistent results have clearly shown in all the data that statins are a must. This is a random meta-analysis. You look at all the thing. The shift to the left favoring statins are very high. The ALHAT, AFCAPS, ASCAT, CARDS, PREVENT, PROSPER, all this clearly tells you that statins have been the mainstay of preventive this thing. So atherosclerosis begins in childhood and if statins should be estimated to benefit patients who are having at least 2 Framingham risk factors, which I told you the scale of 7 variables. At least 2 risk factors, LDL more than 100 or more than 1, if you're having 1 Framingham risk and more than 100, we can use it. Statin therapy reduces all-cause mortality by 17%, more than double than that of treatment of high blood pressure or a diabetes. 30% reduction in CVD events and in primary diabetes. To see prime post menopausal women, we have to be a little careful. A judicious use of statin. Whatever statin you use statin. Complete cessation of smoking and tobacco is pivotal. This is emphasis should be made for every single patient in our outpatients. The 150 minutes of moderate intensity exercise per week or 75 minutes of vigorous intensity. Nowadays they added a new thing like weight strengthening exercises 2 days a week has been added for the whole, exercise intensity. The healthy diet, chase your body mass index and the waist size, and BP target, I think you're all aware of it, 130, 80, and the LDL is less than 100, HbA1c should be maintained less than 70, and coronary calcium scoring. Older times, we see an old patient coming with a chest x-ray, he's got an aortic calcification, he merits an aspirin or a statin. Today, coronary calcium does not require any IV line, does not require a dye. Just go lie down in CT, 6 seconds you get a report. What is your coronary calcium? If somebody is having more than 300 coronary calcium, safely, and you can communicate to the patient that you are going to benefit with an aspirin and a statin combination. Thank you for the patient hearing, and this is our group of thing. We thank you for Srinivas Kumar, he didn't make it, but he conveyed the message. Greetings to all TS Con people, greetings and best wishes he conveyed. We have a Fax Foundation, we work together. We have over 10 hospitals under him, and we have Ravi Badena sir from San Francisco. So we have a group of cardiologists, we work together. So thank you for the, happy to answer any questions.
Excellent sir, Ravindra Reddy sir, you have stimulated everyone, and I am sure most of the young doctors here, they must be jealous about Ravindra Reddy sir, because you all have an aspiration to become the cardiologist. I'm also jealous by seeing his personality, you know. He had a scaphoid abdomen as a heroic personality. Of course, I have a more hair and more body. So, I didn't reach you because of two reasons. I'm taking a few persons' names in the gathering. My friend, physician, Vijay Mohan Reddy, he told me, hey, now this is the time you have to control your health, take care of your health. From that day onwards, I was 120. So now I am 100. So my physician friend, Vijay Mohan, has helped me. He is a preventing doctor. He is the preventing doctor. So you all should be a preventive doctor first before becoming a cardiologist. So that is one. And another person who has inspired me is a Professor Ramya. The scene the other day, she was playing shuttle badminton in Hyderabad in the indoor court. So then she said, I am playing, why can't you fellows not playing? So from that day, except today, all the days I am playing shuttle badminton. Probably that is the reason. Another, you said exercise, no sir. I am doing that. So of course, that is compensated by that. Detoxification is compensated by Lakshman. Night time he is giving the toxin. So that is another disadvantage coming to the Karimnagar. So, and I'm sure if you are not able to become a cardiologist, doesn't matter. That is the tail end of anybody's health. But you all should know how to prevent. Send the message to the community and society that how to prevent. That is the most important thing from MBBS doctor to any doctor who should be able to tell that. Second most important point, basic life support in a road accident or anybody suddenly falls on the ground because of the angina. What is the basic life support? You should implement, not teaching. I am a professor, I only teach, I don't do that. But you don't do that. You implement. So I am definitely going to see the better India, people like him who is inspiring us. Thank you very much.
Thank you very much, sir. Thank you. Thank you.
Thank you, sir. Now I request all the chairpersons to present a memento to Dr. Ravindra Rao, sir. Ravindra Reddy, sir. Dr. Lakshman sir to present mementos to Dr. Raghuraman sir, Dr. Papa Kailas sir, and the proud father of a proud son, Dr. Vidyasagar sir. All. Now moving on to the next session, we are going to have a wonderful session on neurology by an eminent professor. And now I request the chairpersons, Dr. Lavakumar Reddy Garu. He is a senior surgeon from Jangam and past president IMA of Telangana State, to please come on to the dais. And I request Dr. Dwarkanath Reddy sir from Hyderabad, who is a senior ENT surgeon and former Dean, Professor and HOD of ENT Koti Hospital. And he is past president of AOI Hyderabad and AP State Branch, and he is past vice president of IMA Telangana, and he is presently CWC member of IMA Headquarters Delhi and chairman of editorial board IAO, HNS and IASSC. And I request Dr. Burla Srikanth, our dynamic and young urologist of Karimnagar, and Director and Chief of Urology at Sri Lalita Kidney Center and Consultant Urologist at Medicover Hospitals. I request Dr. C. Mallikarjun sir to please come on to the dais. Yes, thank you.
Good morning, everybody. At the outset, let me thank the organizing committee for giving this opportunity. And today's topic being benign prostatic hypertrophy. Though it's not a life-threatening condition, but definitely it's a life-distressing condition. And we don't know whether it is a breadwinning disease for urologists, I am not sure, but it's a frequently discussed topic. And as regards the mystery behind it, as we all know that the hair becomes grey with advancing age. And what we know is, so also is the hypertrophy of the prostate. But here is Dr. C. Mallikarjuna, the eminent urologist, who is going to address the mystery behind as regards the etiology, as regards the health restrictions, as regards the recent advancements in the management interventions beyond TURP. And over to Dr. C. Mallikarjuna. He is an eminent, not only eminent urologist, he has been an eminent teacher going around the state teaching thousands of students. Thank you very much. Over to Dr. C. Mallikarjuna.
Thank you, Dr. Lav-Kumar Reddy, and thanks everybody from IMA of Telangana State for giving me this opportunity to be in front of you today. He said it may not be a life-threatening condition, that's a distress, that's the biggest problem. Majority of the life-threatening conditions are least discussed, but the things which are life-disturbing conditions are more discussed. You need to understand when you have it, then you realize how bad and how good it is going to be. Well, coming to the actually, he was talking about recent advances. This is one of the robotic surgeries of robotic prostatectomy being done. The DVC has been taken away, the prostate has been separated, the urethra is being cut with a robotic surgery. This is the newest advances which is happening in the present country today, or present day in the world. But am I going to talk about it? I don't think so, because this is a recent advance, but what we need, or probably forgetting now, is the basics of managing a BPH, which we revisit now on this stage. Coming to benign prostatic hyperplasia, a disease which has been diagnosed centuries ago, but still the enigma of managing it correctly still remains. Why do we need to revisit this today? The revisiting is, I'll show you some cases where we miss something and we need to relearn something out of those cases. The epidemiology of the disease, the pathophysiology of the disease, the evaluation of the disease, the treatment selection and conclusion. So I'll come back at the end. Coming to the cases questions, I'm going to give some cases. 60-year-old male, 55 grams prostate, grade 3, no minimal symptoms, seeks treatments as it can go to grade 4, which is a very common thing people come with. They doesn't mind surgery to prevent cancer happening. Shall we treat them? The second case, 42-year-old master health checkup, he has a grade 1 prostate, he has been started on Urimax D. He continues for 1 year and presents to a clinic again saying that he has got erectile dysfunction. What went wrong? Does he need treatment at all? 55-year-old grade 2 prostate, frequency, urgency, low volume, low flow, started on Silodosin, no response, TURP done, but he persists to have symptoms. Is it a failure of surgery or a failed decision making? A 67-year-old CAD, CHF, ditor at 8 a.m. in the morning, nocturia 6 to 7 times in the night, flow is okay, mild SOB, pedal edema is there, grade 2 BPH on ultrasound, no PVR, poor response with mirabegron. Is it overactivity or shall we do surgery for him? A 62-year-old central obesity, BMI of 40, he's got snoring also, nocturia, no daytime frequency, started on Urimax, no response, solifenacin added, no response. Shall we do TUR or will it help him at all? A 60-year-old diabetic on insulin, nephropathy and neuropathy, frequency, poor stream, PVR of 200 and of grade 1 prostatic hypertrophy. TURP, no response. Anything we missed, or we missing anything more? Last one, 51-year-old, RTA, multiple procedures 8 years ago, obstructive symptoms past 6 months, needs to strain to pass urine, grade 1 BPH, poor response with tamsulosin. Shall we go ahead with a TUR or change the medication? And the last one, yoga master, a frequency of 10 times in the day and 8 times in the night, Euroflow, PVR, everything normal, all drugs tried, nothing changes. Are we missing something here? These are the types of cases which we come routinely across. Another case, a 90-gram prostate, PSA 14, and he presents with retention, he gets into a biopsy, benign, undergoes a TURP, recurrence of symptoms after 6 months. Reason for poor improvement. These are the varieties of cases which we see. I've given 8 examples now. The last one being a patient who has been having a PSA of 12, started on Silodol D, and he comes back with a PSA of 6.5, presently presents with a bony metastasis after 9 years. If I answered these 10 questions, I think half of the BPH has been taught to you. Look at the physiology of voiding. What happens in a maturation cycle? Relaxed detrusor, tonic sphincter, relaxation of the external sphincter, relaxation of the internal sphincter, and contraction of the detrusor. This is a voiding which happens routinely. Every one of us know about it. But what happens in a physiology? Contraction, these are the 3 mechanisms by which the bladder relaxes. There's a pointer here. Okay, I don't know. Okay, the bladder relaxes and there is a contraction of the sphincter, and there are 3 mechanisms by which the bladder will contract and the sphincter relaxes. So what is mediating there is the sympathetic alpha activity, sympathetic beta activity, parasympathetic activities. These are the basic physiology of maturation. I think every one of us know. What happens in an abnormal voiding? If there are contractions in a relaxed detrusor, that's called overactivity or an overactive bladder. There is a poor contraction of the detrusor. It's an impaired contractility or atony of the bladder. If the sphincter doesn't relax when you want to pass urine, that is a detrusor sphincter dyssynergia. Or if there is an increased outflow resistance or a sphincter tone, that's a bladder outlet obstruction. So all these categories will cause lower urinary tract symptoms. So you don't categorize everybody who comes with a 60-year-old man coming with a lower urinary tract symptoms, said that it is being said because of prostate. No, any of these factors can be the reason why he is not able to pass urine properly. Lower urinary tract symptoms. What do you mean by lower urinary tract symptoms? Once upon a time, prostatism was a term devised, symptoms presumably related to enlarged prostate in elderly. That was the last thing which was devised 30-40 years ago. And the thing now is lower urinary tract symptoms. It's a constellation of symptoms related to disorder or dysfunction of the lower urinary tract, and it can be secondary to BPH in elderly. Coming to the symptoms, what can be the symptoms, lower urinary tract? There are 2 types of symptoms basically. One is a storage, another is voiding. That is relaxation of the bladder not happening properly. So what those storage symptoms? Urgency, nocturia, frequency, and urinary incontinence. Voiding symptoms, that means the contraction of the bladder and the flow of urine has to come. That is a hesitancy, spraying, poor flow, intermittency, straining, and terminal dribble. So these are the 2 basic varieties of lower urinary tract symptoms which we should know. So differential diagnosis can be many, out of which only one thing is going to be benign prostatic enlargement. So when it comes to pathophysiology of BPH, we all know that every male at the age of 50 years will have a prostatic changes which happen, which is called histological BPH, which is seen. But not all will show an enlargement of the gland, and not all will show symptomatology related to either of these 2. So you should understand obstruction associated with an age-related detrusor dysfunction is a thing what happens during a prostatic enlargement at that age. So BPH is one of the causes of lower urinary tract symptoms in elderly, not necessarily all the causes of lower urinary tract symptoms. 25% of men above 55 years experience lower urinary tract symptoms, but 90% of them show the histological change of BPH inside the prostate. So there is no relation between the lower urinary tract symptoms and the size of the prostate. This is one basic one thing which somebody should understand, that prostate not enlarged, you don't have a prostate, is not correct. So what is the etiopathogenesis of BPH, which is still uncertain in spite of being 100 years across? Possibly a small hormonal change which happens during this age, or a metabolic syndrome which came into the picture now, an ischemia, poor tissue hypoxia, inflammatory response, all put together is one of the reasons for BPH. So a metabolic syndrome also plays a significant role in symptomatology related to BPH or etiopathogenesis of BPH in these patients. And the last one is a stem cell hypothesis, wherein these stem cells which are there in the transitional zone will have a change at that time and leading to BPH, yet to be proven. So ultimately, if you understand, it is a combination of hormonal alterations, inflammation and metabolic syndrome and a tissue remodeling in the aging prostate. All four factors result in the benign prostatic hypertrophy. So what you look at the pathophysiology of symptoms in BPH or LUTS is prostatic hyperplasia. If you see, it's in the top. When you look at the prostatic hyperplasia, that is it. It leads to a bladder outflow obstruction. And this bladder outflow obstruction creates a detrusor response which can happen because of the outflow obstruction. You should understand that there are non-BPH causes of obstruction also which can be contributed there. And whenever there is a detrusor response, there may be related to detrusor aging effects. It can be neurogenic disease or a primary bladder disease. All these three things can be there which adds to the detrusor response, and that is leading to lower urinary tract symptoms. Not but the least, you cannot, a polyuria, passing a large amount of urine, cannot be ignored as one of the reasons for lower urinary tract symptoms. So when you analyze a patient of BPH, you should look at all these factors that can be related to the symptomatology in these patients. So you look at outlet obstruction, you look at detrusor dysfunction, and third factor is urine output. All put together will be the way you evaluate these patients. So cause of LUTS, if you look at all these causes, can be reason for lower urinary tract symptoms in this elderly. So if you look at epidemiology of LUTS, the problem is so much. All men more than 40 years will show histological BPH, will have a problem. Histological BPH is seen in almost all the people, but the true enlargement might be seen in only few, and people may have lower urinary tract symptoms with or without enlargement, and only few of them will have a bladder outlet obstruction who will be needing treatment or relief of obstruction. So not every histological BPH requires treatment, and not every symptom related to lower urinary tract are related to BPH. If you look at the histology of the BPH, it is adenoleiomyomatous hyperplasia. That means there is a glandular element called adeno, and there is a leiomyomatous element, that is the smooth muscles. So the treatment is revolving around these two elements. One is a gland, another is a smooth muscle. How it is evolved. If you look at the treatment, the whole treatment of any part of BPH is, you look at the bladder dysfunction, you take care of the muscarinic receptors. You look at the prostatic dynamic obstruction here, you take care of the alpha adrenergic receptors and blockers. You look at it, the anatomical obstruction that can have, that is because of the enlargement of the prostate, that is because of the adenoma in the adenomatous gland, glandular enlargement, that is 5-alpha receptase inhibitors. And you look at another thing which is a subvariety which comes in is a PDE5, that is the tadalafil, which takes care of the hypoxia factor, inflammation factor, and treatment of LUTS by that way. So there are only 4 groups of drugs which play a role in treating this benign prostatic hyperplasia. I think it's clear how to select, then we'll decide now. So whenever you see a patient of a prostatic obstruction, you see, evaluate and do a digital rectal examination, which most of us do. Ultrasonography is one of the factors to do. Post-void residue doesn't mean that it is obstruction all the time. Ultrasonography is only necessary to know the size of the prostate. Uroflowmetry is the most useful investigation, wherein you can see the flow patterns and decide what sort of a treatment, what sort of a pattern he has, and how much obstruction he can have. Prostate-specific antigen is not a part of evaluation of BPH, not a part. It should not be done routinely unless you suspect some, or it should not be routinely done in a master health checkups in a 40-year-old guys. Patients with lower urinary tract symptoms, more than 50 years, do deserve a PSA, not everybody, and there are many reasons why it can be raised also. Cystoscopy is never for a diagnosis of BPH, and it's for only an exclusion of other diseases inside the prostate or in the bladder, not for the diagnosis of BPH at all. Management options, if you look at, as I said, this already treats. If you want to treat the muscarinic, the bladder relaxation for overactivity, it is the muscarinic receptors. You look at the dariphenacin, solifenacin, etc. And the alpha-adrenergic activity, that is two types of it. One is a static, another is a dynamic. Static is nothing but the glandular component. You take care of it by 5-alpha reductase enzymes, that is the dutasteride and finasteride. And alpha-adrenergic activity is the dynamic component, that is for the smooth muscle, relaxation of the smooth muscle, that is done by tamsulosin, silodosin, or whatever drugs of alpha blockers you have. And a phosphodiesterase enzymes, which is PDE5, which improves the tissue hypoxia, decreases inflammation, thereby relieves the symptoms. So a combination of these drugs is the thing which is necessary. The same thing what I said till now is blocks alpha receptors, causes smooth muscle relaxation of the prostate, and 5-alpha reductase enzymes for decreasing the size of the gland, and then relaxing the detrusor muscle is by muscarinics and mirabegron. This is the 4 types of drugs that is used for the prostate. So algorithm of management: mild symptoms, you don't need any treatment at all. If you have a moderate symptoms with erectile dysfunction, alpha-adrenergic drugs with PDE5, that is tadalafil. If you look at a small prostate, very low PSA, only alpha-adrenergic activity or receptor blockers. If you have a large prostate, more than 40 grams, more than 40 or 50 grams, then only think about dutasteride or a finasteride combination with alpha-adrenergic activity. If it is a predominantly irritative symptoms, voiding symptoms, no obstruction, it is only bladder overactivity, then it is anti-muscarinics or in association with alpha-adrenergic blockers. If there is a very severe symptoms with complications, they may require surgical intervention. The history of surgery has gone back to 1926, where TURP was done, and now it is an aquablation. I'm not looking much about recent advances, because I am not interested in telling the recent advances, because I myself have not dealt many of those recent advances to the prostate. One thing is true: medical management gives relief, but surgery gives the best relief, provided it is indicated. Coming to the surgical treatments, if you have these symptomatology, refractory symptoms, urinary retention, bilateral adenonephrosis, recurrent UTI, gross hematuria, and vesical calculi, surgery is mandatory. There is absolute indications for surgery. Standard surgeries involve a type of TURP, a bipolar TURP, or a homeom enucleation of the prostate. These are the 2 ways of, I don't know why the video is not coming up. Anyway, that's fine. That's a standard TURP which is being done. It's a bipolar TURP which is being done. Even now, after 50 years of inception, still TURP is the way of gold standard of managing many of small sized prostate. Whereas coming to this HOLEP, what is being showing in the other slide is going to be a large gland which is more than 100 grams or 150 grams. You look at doing a homeom enucleation of the prostate. I'll stop this and play the other one. This is seen by everyone. Possibly this may be of some use. That's a homeom enucleation of the prostate happening for a glands more than 70 or 80 grams, where enucleation is the answer for larger glands. Why so? We come to the last part of our discussion, that is the newer ones are going to be aquablation, prostatic artery embolization, Resume, and Urolift. All of them are still being compared to TURP as non-inferiority trials, not as superiority trials. So don't think what is recent doesn't necessarily mean that it is good. That is about the prostatic artery embolization, Resume, and Urolift, which is coming to the market. Coming to the solutions, that gives you the message of what is the talk today. Coming to the first case, a 60-year-old male, 55 grams prostate, grade 3, no or minimal symptoms, seeks treatment as it goes, it can go to a grade 4, doesn't mind surgery to prevent cancer. Does he require surgery? Minimal LUTs, incidental BPH don't require any treatment. Surgery doesn't prevent cancer, because in surgery we take out the adenoma, the peripheral zone will retain, and the cancer happen inside the peripheral zones. So the BPH is in the center, the cancer is in the periphery. So doing a TURP or a HOLEP doesn't mean that you don't get a cancer tomorrow. Coming to the 42-year-old master health checkup, grade 1, 26 grams prostate. Guy goes on to a Urimax D and continues. 2 years later presents with a erectile dysfunction. It is no treatment that is necessary. Dutasteride causes erectile dysfunction. So don't prescribe dutasteride in less than 60-year-old people who are sexually active. 55-year-old, grade 2 prostate, frequency, urgency, low volume and low flow. Started on Silodosin, no response, TURP done, persistent symptoms. Why? It was surgery for overactive bladder, not for a prostatic obstruction. So it was a failed decision making of doing the correct job at a correct point of time. A CAD CHF on ditar at 8 a.m. Nocturia 6 to 7 times, flow okay, mild SOB, pedal edema. What does this means? He had no problem. What he had is nocturnal polyuria. Patients with CHF with this sort of a pedal edema, patients with, they do have recirculation, pedal edema, recirculation of fluid in the legs into the vasculature, and if you look at the output in the night, they do have a 2 liter or a 1.5 liters output, which makes them to have frequency at night. So you need to look at recirculation. So you shift the ditor not at 8 a.m. to 3 p.m. sometime. He gets dehydrated at that point of time, and whatever he has consumed will not be into the circulation at that point of time. So diuretic timing is going to be essential in these patients. Coming to a 62-year-old, central obesity, nocturia, and he's got a snoring, no daytime frequency, started on drugs, no response. Yes, OSA and snoring does produce nocturia. They do have high urine output, nocturnal polyuria because of CAP. You put him on CPAP, he'll be all right and he'll not be having any symptoms. Don't treat them with drugs. 62-year-old diabetic, nephropathy, neuropathy, frequency, poor stream, post-void residue of 200, 2URP done, no response. It is a diabetic cystopathy, a hypocontractile bladder because of diabetes. PVR doesn't mean that it is obstruction. It does show detrusor decompensation, not obstruction. Not obstruction. So bladder contractility has to be evaluated in urodynamic study before doing a TURP in these patients. If you're 51-year-old, RTA, multiple procedures and obstructive symptoms, needs to stay in poor response to drugs, he doesn't need a TUR. If he had previous surgeries, previous urethral catheterization, think about a stricture. He does have a stricture. Flow patterns on a retrograde uretrogram will diagnose whether it is a BPH or a stricture. So don't do a TUR, don't put them on Urimax without evaluation in these patients. 65-year-old yoga master, British trained man, who comes back and says, has got a lot of frequency, went to Himalayas, did all the yogas and came. And he says, I cannot control this frequency. How do I do it about? Do a bladder volume chart. How much is passing? Somewhere around 7 liters of urine is passing. If he's passing 7 liters of urine, you end up in passing 20, 30 times in a day. How can you pass it in 2 or 3 times in a day? So think about a bladder diary. Maintain how much is the urine output per day. You will understand whether the frequency is related to polyuria, that means a lot of urine, or really a BPH with LUTs. It's a compulsory water drinking which is very common in Indian subcontinent. 60-year-old male, recent retention of urine, 90 grams prostate, PSA 14, biopsy benign, undergoes TURP, recurrence of symptoms at 6 months. 3 issues. Never do PSA when the patient is in retention. It is obviously will be high. You will be unnecessarily doing a biopsy which is not indicated. You do a PSA after 2 weeks, you will not have that raised PSA and you don't need a biopsy. So biopsy was superfluous. 90 grams prostate do require a bigger procedure like an HOLEP because enucleation is necessary. Under resected prostate may allow the patient to pass urine temporarily, but he'll have symptomatology again at the end of 2 years. That's what has happened in this patient. A 70-year-old male, obstructive voiding 1 year, 45 grams prostate, PSA 12, started on Silodol D. What happens with dutasteride? The PSA decreases to half. And he presumes that he doesn't have a cancer prostate. 1 year later he comes back and he presents with bone metastasis, and at that time the PSA was around 30. So this is what happens. Never ever treat these patients. Recent onset of LUTs in a 70-year-old male, always suspect a cancer prostate. People with 70 years, recent onset, it is never a BPH. BPH pathophysiology happens between 50 and 65 or 70, not after 70. Cancer prostate should be ruled out in all these patients. DRE can be diagnosed in most of these cases. Dutasteride changes the PSA value, so don't get fooled by that. Prostate biopsy would have picked up the diagnosis in the initial go. Take-home messages. Pathophysiology involves physical bladder outlet obstruction, which is static. Bladder response is dead to sir, instability, low compliance, hypocontractility, increased smooth muscle tone, that is leading to voiding symptoms, and storage symptoms, vice versa. And the treatment model is going to be physical, do a 5-IRI, that is dutasterase and finasteride. Alpha blockers for relieving the muscle in the prostate, and anti-muscarinic and PDE5 to decrease the bladder response, and combinations necessary according to the need and assessment. Prostatic obstruction rare below 50, and most of the time it is cancerous after 70. Size of the prostate doesn't correlate with obstruction. Benign enlargement, BPH, is not precancerous. All urinary symptoms like LUTs, not because of prostate. Select the drug rationally after good evaluation. Surgery is safe and gives long-lasting results if it is chosen correctly. Thank you very much.
Excellent, Dr. Malli. I think you did a wonderful job as usual, and especially in this scenario. So we have several myths and cleared in regard to BPH, LUTS, and then about the PSA, and last but not the least about the indications and the procedures to be done in all these cases. Really wonderful job you have done. Excellent take-home message you have given. Thank you very much.
Thank you, sir.
Thank you, sir. Sir, when to start PSA screening, at what interval, and when to stop, with symptoms, without symptoms?
Well, I think the whole PSA screening started in West, wherein it was being done routinely for everyone, resulted in an enormous number of over-treatment of an early non-fertile prostate malignancies. So there is a change in the philosophy which has happened in the West also. So a routine screening in general population, like doing a blood sugar, is no more advisable. I think in Indian scenario, with our continent, we need to look into one way of managing it, that is an opportunistic screening. What is that? A fellow comes with you with a urinary symptoms, you need to evaluate him, you examine him, and possibly if he is more than 50, if with urinary symptoms they are thought to be because of prostatic obstruction, do a PSA. There is justifying in it. There is a second most important family history of CA prostate. You have to do a PSA every year and probably every 6 months if the brother is involved with CA prostate. These are the only two indications at present.
Thank you.
Thank you, sir. I request the chairpersons to present a memento to Dr. Mallikarjun, sir. It's always a pleasure listening to Dr. Mallikarjun, sir. Everybody, irrespective of the age, will become students of sir, irrespective of the age and the speciality. I request Bhagya Reddy, sir, to please come on to the stage. I request Bhagya Reddy, sir, to present mementos to the chairpersons. Dr. Dwaraka Nath Reddy, sir. Dr. Lavakumar Reddy, sir. And Dr. Burla Srikanth. Dr. Burla Srikanth is the favorite student of Dr. C. Mallikarjun, sir. Thank you all for your wonderful presence. Moving on to the next session.
We'll move to the next session, GI session. So to chair that session, I invite Dr. Ravindra Rao, sir, the senior surgeon and great teacher of all times. He has with teaching experience of more than 35-40 years of teaching experience. Professor and HOD of General Surgery, PIMS Karimnagar, past president of Telangana ASI, and awarded as the best accomplished surgeon for the Telangana in 2016. Now I invite Dr. Sanjeev Singh Yadav, sir, senior surgeon from Hyderabad, past secretary of IMA Telangana State, national chairman IMA Academy of Medical Specialties. Now I invite Dr. C.H. Rajamouli, sir, senior surgeon from Janagam and immediate past president of TSASI. And classmate of Dr. G.V. Rao, sir. Now I invite the speaker, Dr. G.V. Rao, sir, a renowned surgeon and
आप बोलते ही At the outset, let me thank our organization for giving us the opportunity to preside such a wonderful speaker's lecture now. It's my pleasure to introduce Dr. G.V. Rao. He is Director of AIG Hospitals. I think all of you know what is AIG Hospitals. It is really a wonderful hospital for which we should be proud. Asian Institute of Gastroenterology, and he is the Chief of Surgical Gastroenterology and Gastrointestinal Oncology and Transplantation Services. He has been awarded with BCA awardee. He is a president. Now recently he is elected as the chairman of the Surgical Gastroenterology, for which all we should be proud of it. He is a past president of IHBA. He is a past president of Society of Gastrointestinal Endoscopy. He is a board member of Asian Endoscopy Task Force. He is a board member of Asia Pacific Endolab Surgery Group. He is a board member of International Society of Fluorescence Guided Surgery. He is a board member of HPS Society, that is Hyderabad Public Schools. So with this brief introduction, I invite Dr. G.V. Rao to give us the lecture. He is going to speak on recent advance in GI surgery. Am I right?
Thank you. Thank you so much, Dr. Ravindra Rao Garu, my teacher, my mentor, Dr. Sanjeev Singh Yadav. At the outset, let me thank the entire executive of the Telangana IMA and also the IMA of Karimnagar for this invitation. If you look at the GI surgery, what has been happening, most of you, the surgeons here are practicing GI surgery for more than 4 decades. We've all been talking about morbidity and mortality of GI surgery, and this is basically because of the bleeding that we encounter, that leaks that we encounter during surgical procedures, that blood loss that happens during the surgical procedures, and the extensive resections that are in current day clinical practice. Now, the question that is repeatedly asked is, how do we reduce the morbidity and mortality of these surgical procedures? If you look at evolution of GI surgery, the initial part of the GI surgery, the outcomes were purely dependent on techniques. Subsequently, technology came in a big way, which improved the outcomes of these surgical procedures. Now, the question that is repeatedly asked is, how can these outcomes be further improved? Now, it looks like there is something beyond and behind all these things, which can certainly improve the overall outcomes of these surgical procedures, decreasing the mortality and morbidity of these surgical procedures. GI surgery as in today, it is not a separate specialty. It is part and parcel of gastrosciences, which involves surgery, endoscopy, radiology, oncology, and basic science. Surprisingly, each of these specialties have been practicing independently, and each have been thumping their chest saying that they are the best in the field of medicine or surgery or endoscopy. So each of these specialties have evolved parallelly, separately. But surprisingly, this is what something like this happened. 2 decades back, if you see, Marvel Studios used to produce movies based on individual persons. We had Iron Man, Captain America, Thor, Hulk, Black Widow. Surprisingly, each one of them had their signature techniques and technology, but surprisingly, each one of them had their own limitations and acceptance. And there's a lot of artificial intelligence that got incorporated into these movies, something like what happened into medicine also. So in the last few years, if you have seen, Marvel has changed the concept. They incorporated all these people together, and we talk about Avengers today. As in today, we don't talk about individual heroes, but we are talking about heroes who are working together to get the best of the outcomes in these patients. So I'm going to show you some of these emerging areas in GI surgery which have certainly changed the outcomes in surgery. These are nothing imaginary thing. These are what is being practiced in clinical medicine today. I'm going to talk about imaging beyond white light, laparoscopy, endoscopy, cooperative surgery, navigation surgery, artificial intelligence in medicine surgery, transplantation without immunosuppression, maybe genomics and surgery and future. We all talk about this white light laparoscopy. Umpteen number of videos are shown. Actually, we talk about 3D laparoscopy, 4K laparoscopy system, which talks beautifully about magnification that we get and the beautiful resection that we do during these procedures. But the biggest problem, in spite of these 3D, 4K laparoscopies, is identification of structures. Recognition of structures is sometimes difficult, and you cannot definitely say how well the organ is perfused during surgery or after resections. These are the pros and cons of this. Suppose some of you might have seen this movie called Predator. For the first ever time, this movie showed the concept of using infrared laparoscopy or infrared light to pick up camouflaged structures. This is the basis of what we do in currently clinical practice, the infrared laparoscopy or the ICG in clinical practice, wherein we inject indigo cyanin green and pick up these images under infrared imaging, and we're able to see structures, glands, which are beyond conventional white light imaging. We are able to pick up nodes like this, which are not picked up on conventional imaging, and we are able to check the perfusion of the organ during resection. This is the organ that is perfused, this is the organ that is not perfused after mobilization of the rectum, and even after anastomosis, we can check that the perfusion of this anastomosis is perfect, indicating that the chances of leak in these patients are very, very low. Simultaneously, if you're doing thoracoscopy, a lot of times we have difficulty in identification of a thoracic duct, and many of these patients come back with chyle leaks. Here we inject indigo cyanin green, and you can see that green structure here beautifully outlines the thoracic duct here. So ICG in clinical practice has made a dramatic difference in picking up lymph nodes beyond conventional areas of resection, identification of structures, and organ perfusion, decreasing the overall morbidity and mortality of surgical procedures. We all know about endoscopy and laparoscopy. There are pros and cons of each of these specialties. Endoscopy is flexible, maneuverable, has got an narrowband imaging as an accessory. But the difficulties or the cons are orientation is difficult, there are a lot of limitation of accessories and energy sources. Laparoscopy on the other side is rigid. We can do resections, dissections, anastomosis, hemostasis. We have ICG and IR as I've shown you. The difficulties are organ preserving surgeries sometimes cannot be possible. Suppose we integrate both endoscopy and laparoscopy. You take the pros of both the procedures, then what happens? Of late, we have seen that more and more of endoscopies are getting more aggressive, getting from the lumen outside the lumen. So we have this combination of endoscopy and laparoscopy, and the new specialty is emerging, which is called as laparoscopy, endoscopy, cooperative surgery. The theater for this looks something totally different, wherein we have both the endoscopic tower and the laparoscopic tower in the same room, and we have the endoscopists and the laparoscopic surgeons performing together so that we can do these procedures with minimal morbidity. Why are these becoming popular? Basically because we have a lot of these subepithelial tumors and early GI cancers which are being picked up now in conventional imaging modalities, which are increasingly detected, and we seem to understand their biological behavior better. And we also know that segmental minimally invasive resections are adequate for this, and these result in better functional outcomes of these patients. So based on these things, based on the amount of endoscopic involvement and the amount of laparoscopic involvement is involved in these procedures, umpteen number of techniques have been devised. I'm not going to the details of this, but basically it depends on whether the lesion is predominantly onto the luminal side or whether the lesion is predominantly onto the serosal side. Of course, there will be a gray zone in between, but lesions which are predominantly onto the endoscopy side go on for endoscopic resections. Lesions which are predominantly on the serosal side will go for laparoscopic resections. And we have this gray zone which go in for these procedures. I'll show you these beautiful videos. Actually, most of the laparoscopic surgeons are aware of this. You have a gist like this, which is onto the greater curve. Very simple, you put a stapler, sleeve it actually. The biggest advantage of doing an on-table endoscopy is we can see the staple line being fired, and any intraoperative bleed or a staple misfire can be judged on table, and then we can rectify this. So on table intraoperative endoscopy is very, very helpful in these procedures. But the biggest disadvantage of these procedures doing a sleeve resection is that we're getting good margin in one field and you're getting limited margin in the other field. These are the limitations of doing a sleeve resection. So now what we do is we do a combined endoscopy laparoscopic resection. So you can see this is a laparoscopy field, and we have the endoscopists doing the endoscopy simultaneously. This is the gist that is very close to the G junction. We mobilize the whole thing. Actually, the lesser curve is mobilized now. So what happens is actually these are the procedures which, I'm sorry about this, okay. Okay, I'll skip this. The biggest advantage is as we are doing these procedures, it is possible that, hold on a second. Sorry about this. I'm sorry about the biggest advantage. I'll just wait for the videos to run. The biggest advantage of these endoscopy laparoscopy procedures is that you're doing these procedures both with the endoscopist and the surgeon together. So what happens is actually the morbidity is reduced. So we allow the endoscopist to do his part and the laparoscopic surgeon to do his part. Oh, sorry, this is okay, fine. So you can see this actually. This is. So we try to staple this line. Actually, this is a gist on the greater curve. We try to staple this actually. Unfortunately, when we try to staple this, the endoscopist put the scope and he found that the endoscope was not going into the duodenum. So had we stapled this patient like the regular sleeve resection, this patient would have come back with vomiting in the post-operative period. And so what he did here was to do this endoscopy laparoscopy resection, wherein we injected submucosal methylene blue like what we do in endoscopy procedures, and subsequently created a big buffer in the submucosal plane and subsequently did this laparoscopic resection, dissecting that entire mucosa out of the view. Sorry, I'm not able to forward this. The biggest advantage of these procedures is that actually once you do this, actually you're able to preserve the organ, you're doing limited resection, and then once we mobilize this entire thing, we'll be able to just staple the mucosa, get the entire gist out. I only hope I can. Yeah. This is another example of an early gastric cancer. Here what happens is we inject submucosal methylene blue, and subsequently once you have done, what we do is we do a laparoscopically, we do a seromuscular incision. You can see this, we are injecting submucosally to make the lesion very prominent. Then we do a seromuscular incision on the laparoscopy side. So the submucosal injection that you have done endoscopically acts as a buffer, and you know that you're not going into the lumen of the thing, and once you're done, the entire lesion is inverted into the stomach by taking seromuscular sutures so that the entire lesion gets inverted. Now once this lesion gets inverted into the thing, then the rest of the thing can be done endoscopically. This is basically to avoid any spillage of cancer cells into the peritoneal cavity. So you can understand this, umpteen number of these procedures are designed to make sure that you do organ preserving surgeries. So you make sure that this lesion becomes very, very prominent on the endoscopy side by putting some material like Surgicel like this. So hardly there is any spillage of the cancer cells. Once you have done this seromuscular closure, this lesion can be excised endoscopically using the ESD techniques. Likewise, we have this large leiomyoma that we encountered in esophagus. Actually, initially these patients used to go for long segment resections or even esophagogastrectomies. Now we do the same procedure like what we have done on the endoscopy side, we inject submucosal methylene blue to make sure that we get a good buffer on the submucosal plane. Once you've done that, actually we can mobilize this lesion, splitting open the circular and the longitudinal muscles. We can see the methylene blue that is injected. We can separate the whole thing, and then at the end of the procedure, we can take this out. Now we all talk about colonoscopy and colonoscopic polypectomies, which is a standard of care. But we also have some polyps which cannot be resected colonoscopically. These obviously go in for some sort of minimally invasive resections. But now we have an intraoperative colonoscopy that can be done. This is just a classical example of a mucocele of appendix that we have seen actually. But for this procedure, this patient would have gone for a limited IC resection or a right hemicolectomy. Here what we are doing is to do an intraoperative colonoscopy, identifying the base of the appendix by transelimination. I hope I can just... Can somebody help me with this actually? Yeah, so you can see this. So we mobilize this, and then under transelimination we staple this lesion here. And at the end of the procedure we are able to check the integrity of the mucosa by transeliminating the colon. So we have umpteen number of examples to show where endoscopy, laparoscopy procedures can be done together. And then we also show the pros and cons of these procedures, and there's a lot of literature to show what is the role of the endoscopists and what is the role of laparoscopic surgeons. So each of these persons are trained together to work together so that these procedures can be done. Artificial intelligence is the most happening specialty in gastro-sciences, most curious, most invested, and most rapidly expanding specialty in gastro-sciences. Some of you would have seen this movie wherein this surgeon gets some eye drops instilled and is able to see beyond. I'd be very happy if we can see something beyond even before I rip open the abdomen. This is a fantastic movie that came in almost about 4 or 5 decades back, but this seems to have become a reality with advent of artificial intelligence. And today we have more and more of these science fiction movies which are showing this concept of artificial intelligence as in today. And for the first ever time, we have shown this possibility which can get translated into clinical medicine. So we all talk about frozen section biopsy. Here I'm using a cytoscope, which is a microscope which can be introduced through the laparoscopy or during laparoscopy, and we put this cytoscope, touch the nodule that we see on the peritoneal cavity, and we're able to get a real-time in vivo histology. I'm not talking about the static pictures that the pathologists talk about, but it's a real-time in vivo histology wherein you can see the blood vessels and the tumor emboli within the blood vessels. So now we have gone a step ahead, and now we have artificial intelligence which has got incorporated into this endoscopy. In the sense like we are depending on a frozen section biopsy, whereas this scope, suppose you put it and touch the nodule, it makes a diagnosis of a benign versus a malignant nodule. This is what is called as an endobrain. This has become very, very popular on the endoscopy side. For the first ever time, we use this endobrain on the laparoscopy side. Now, this is a patient with unexplained ascites, do a diagnostic laparoscopy. Here we take these biopsies and send them for frozen section biopsy. But here, I put this endobrain, which is in touch with this same scope, we'll put the thing, and this scope tells us whether the nodule that I have put it on is a benign nodule or a malignant nodule. As in today, I am not saying that it is going to completely replace biopsy, but this is a step forward wherein you can say that in the days to come, this is completely going to replace pathology. So as in today, it helps in targeting biopsies, and this is what is practiced in current day clinical practice. It shows that this lesion is about 90% chance of this being neoplastic. Now a lot of you would have seen these videos of laparoscopic Whipples being done. Actually, the one important crux is that actually at the end of the procedure, you don't do a proper anastomosis, it leaks, and the patient dies. Now the entire thing depends on the organ perfusion. Now I showed you the indigo ICG, which is used to check the perfusion of the organs. Now as in today, it is very subjective. Looking at the color, we tell it is whether it is adequately perfused or not. Now we require more objective evidence to show how much of it is perfused. So we require some artificial intelligence to get incorporated, and for the first ever time we have shown that we introduce artificial intelligence. Now it shows that this organ is 80% perfused at the margin. So it means if it is adequately perfused, the chance of leakage from this anastomosis is going to be very, very minimal. So from subjective evidence, we have gone to objective evidence and an artificial intelligence predicting the amount of perfusion of these organs. Intensive care nutrition is a subjective evaluation as in today. These are equation-based nutrition, and majority of these patients seem to have iatrogenic malnutrition. I call this iatrogenic starvation, basically because this is because of non-compliance to what has been taught to us, lack of knowledge, cost involved in it, and the egos involved in the intensivists. Now what we talk about is the nutritional therapy in ICU is a dynamic process which keeps changing, and we have to have evidence between subjective and objective evidence. We always used to write down this nutritional requirement of these patients in the post-operative patients based on these predictive equations. But of course, as in today, we have these algorithms which have completely replaced these equations as in today. We depend on artificial intelligence as in today. For the first ever time, they've shown this indirect calorimetry can predict the energy requirements better. And this system, which was so huge, has become so compact as in today, which can be used. It's a very, very simple apparatus. You attach a hood to the patient. It tells us the amount of calorie requirement that is required for this patient. This is nothing new. The sports personnel have been using it for years together, but for some lack of knowledge and because of the costs involved, we have hardly used this in clinical medicine. But this is coming into clinical medicine, and we have shown that using indirect calorimetry and assessing these patients, make sure that these patients get adequate calories in the perioperative period so that the morbidity and mortality is less in these patients. So as in today, indirect calorimetry is the gold standard. Though we have lack of equipment, the scarcity of skilled personnel, we need some people to interpret these things. There are high costs involved in this, but ICG nutrition seems to be very, very important in the days to come. Navigation surgery, again, this is not an imagination. Actually, some of you would have seen this Bond movie wherein this Bond navigates through these images, actually. People thought it's a fictional thing, but now this is the current day clinical practice. What we do is incorporate the preoperative and the intraoperative data like what we're doing here, and then we navigate through the entire procedure. We get real-time images like this. I hope you can see this. We are seeing the images of the liver there. We are seeing the blood vessels right on the monitor there. And we can plan our dissections based on these blood vessels so that we can avoid these major vessels that come in the path of this resection, decreasing the amount of bleed and also decreasing the radicality of resections on these species. These are the things that are being practiced in current clinical practice to decrease the morbidity. The other thing that has come into clinical practice, which are practicing, is the 3D printing of these organs. Even before you start the surgery, you 3D print this liver on a silicon model. This concept basically came from these coal miners who used to duplicate these coal tunnels onto the surface of the earth to decrease the casualties in the coal tunnels. This is the concept that we use in clinical medicine today, and this has really decreased the overall morbidity. So this navigation surgery and 3D printing improve decision making, decrease operative time, complication rate, improve the surgical precision, improve surgical safety, improve the clinical application. They facilitate orientation and localization and visualize the anatomy for teaching purpose. The other area of interest to us is this islet transplantation, which could be autologous or allogenic. Give me 5 minutes. Now this islet cell transplantation is autologous, no immunosuppression is required. If you're doing allogenic transplantation, it requires immunosuppression. Now this process of islet transplantation goes through this process wherein you take the pancreas and then isolate the islets in the basic science lab, which we have in our AAG as in today. These are the islets that are purified, and once they're purified, they're checked for the sterility of these things, and once it is done, they're infused into the portal vein, which get homed into the portal vein, and these patients become euglycemic. So we have this data which is presented to show that autologous ICG transplantation is done, and we have this data of initial patients who have gone through this. And AAG becomes the first center in the Asia Pacific region and one of the leaders in islet transplantation. So we all know about this autologous transplantation without immunosuppression. We are talking about allogenic also with immunosuppression. The question that is repeatedly asked, can allogenic transplantation be done without immunosuppression? Now, this is something like you're asking, putting in bio-artificial heart, you're asking about a bio-artificial pancreas. This concept, again, people ridicule, but for the first ever time, we showed this in non-human primates, wherein the islets can be isolated from pancreatic specimens, and then we did both allogenic and autologous transplantation in these animals, and all these animals survived basically because we put these islets in a device called Therasite, which allows only nutrients to pass through, it does not allow any immune cells to pass through. So now what is going to happen next is that we put these islet cells into these small devices like this and implant subcutaneously, and we are talking about islet cell transplantation without some immunosuppression, something like this, small device like this, which you have islets and it can be put subcutaneously, and this patient become euglycemic. May I have another 2 minutes? Okay. Mutations are known to happen in this thing. Actually, we all know that because of the environmental factors. And we have these sequences that have come into clinical practice which can identify these mutations that can happen. These are available in current day clinical practice, and there are a lot of things to show that if you go through this sequence, you'll know what are the diseases that you're prone to. The classical example is this lady, Angelina Jolie, who underwent bilateral prophylactic mastectomy based on this genomic sequence. And there are umpteen number of procedures that can be done based on this to prevent the overall morbidity. The biggest thing that science asks as in today is, can fibrosis be reversed? We have in our own basic science lab shown that fibrosis can be reversed in pancreas. So in the days to come, we're going to make sure that this gets translated into clinical medicine, wherein this entire concept of fibrosis will go, and we can treat this patient with chronic pancreatitis with drugs, avoiding major surgical procedures. So GI surgery is a part of unified gastrosciences. There is increasing role of ICG and IR-aided laparoscopic surgeries. Laparoscopic, endoscopic, cooperative surgery and navigation surgeries are emerging specialties. It aids in lab open procedures, improving outcomes, and it aids in physiological function, preserving oncological resections. AI is the most happening advancement in medicine. Perioperative nutrition management is very, very important, and indirect calorimetry is very useful. Islet cell transplantation with and without immunosuppression can help diabetic patients in future. Personalized medicine and genomic-based intervention will help quality of life and also lifespan in future. And antifibrotics will definitely redefine the entire surgical interventions in future. Thank you so much once again, and sorry for the mishap that has happened regarding the audiovisual part.
Thank you, Dr. GV. It was an excellent presentation, international presentation to our IMA Ts Con. And these new innovations, hopefully, especially the diabetic ones, will help, and the GIST ones will help our generation to come out of the diabetic status what we are having in Hyderabad today. Hope we have a better time to come. Thank you.
I got one question. Most of this cooperative surgery that you are doing in a submucosal, subserosal lesions, whether it is useful in other areas?
Yeah, then today, as I told you, basically we are using it in a lot of subepithelial tumors, just neuroendocrine tumors, early gastric cancers, early colonic cancers.
What is the status now, island transplant actually? What are the indications and when you are advising the patients?
As in today, in India, actually, we are one of the centers to recognize for islet cell transplantation. As in today, what is being done is autologous islet transplantation in patient undergoing pancreatic resections. To avoid diabetes in these patients, the islet cells are isolated from this and given back to the patient. But we're just waiting for the Government of India approval to do this allogenic transplantation. I think it will soon happen, maybe in a couple of months to come.
Can be applied to all diabetics now?
Yes.
Oh, thank you, thank you. Very nice, Dr. G.V. Rao. It's a wonderful lecture.
Thank you, sir. Now I request the chairpersons to give a memento to Dr. G.V. Rao, sir. I request Dr. Narendra sir, Dr. Mangilal sir, Dr. Arun and Dr. Lingam sir to join. Now I request Dr. Narendra sir to give mementos to chairpersons.
I request Dr. Arun sir to present a memento to Dr. Sanjeev sir. Thank you, sir. Thank you all. Moving on to the next session, I request Dr. P. Vijay Chandar Reddy Garu from Varangal. Dr. P. Vijay Chandar Reddy Garu is a senior orthopedic surgeon and past president of IMA and president of OASIS, the Orthopedic Association of South Indian States. And I request Dr. Bangar Swami Garu. Dr. Bangar Swami is he's an MS and MCH Ortho, fellow in spine surgery from Ims and fellow in joint replacement and arthroscopic surgery from Germany. He is a chief consultant spine and joint replacement surgeon and chairman of Reni Group of Hospitals. And I request Dr. Akhil Dadi sir, director of Srikara Hospitals, to please come on to the dais.
Yeah, good morning to all of you. Today we have got a very experienced orthopedic surgeon, Dr. Akhil Dadi, amongst us. He is known for joint replacement surgeon, especially, but he has chosen a topic of knee preserving. He did his MBBS from Gandhi Medical College and MS Orthopedics from Ims Hyderabad. Done fellowship in joint replacement at Germany and spine surgery at Ims. Is the chairman and managing director of Srikara Group of Hospitals. He has got a vast experience of doing more than 23,000 joint replacement, and he has got a personal world record of doing more than 30 knee replacements in 13 hours. I present Dr. Akhil Dadi to go ahead with his talk.
Thank you everyone for calling me here, Ims Ts Con, and what a wonderful conference this has been. There is so much learning from the predecessors. So definitely most of us, when we start our practice, our treatment is directed towards 90% is towards conservative, that is preserve the joints. All of us know that there are 4 stages when you look at it at the X-ray wise, clinically and radiologically. Stage 1 and 2 is where you will be stuck to your preserving the joint in lifestyle changes, medical management, exercises, injections if for a few patients, which could be steroids, PRP and hyaluronic acid, any one of this. Whereas in stage 3 and 4, where the bone also starts getting involvement and there is more of cartilage involvement, you would go either towards cartilage directed surgeries, Oates and Macy. I will tell you in some time what they mean. If there is a lot of malalignment, there will be osteotomies, and then breadwinners for us is the knee replacement for those severe osteoarthritic or rheumatoid degenerative cases with severe disability. So today we are here to talk on the recent advances, if there are any. But more than that, what has been proven, as Dr. Mallikarjun said, let us talk about what has already been proven in our hands rather than talk too much about advancements, and a little about the negatives which we think are advances, especially the injections. We all know that either trauma or arthritis would lead to an end-stage arthritis, and we want to avoid this stage and preserve our naturally given joint. So there is a whole gamut of pathophysiology. One is with age and genetics you get predisposed to osteoarthritis. The other is with injury or with overload, being obese, or with instabilities, it leads to osteoarthritis. So if you look at it, grade 1 and 2 is where most of the space is maintained radiologically. Grade 3 is most of the space is gone. And in grade 4, there is a subluxation, that the femur moves away from the thing. Now, even today, from the more than now 2 decades, the mainstay of treatment for millions remains glucosamine, which is a dietary supplement for knee pains. Now, I will just put it as glucosamine coming from the West. Most of the people who stay in Australia and New Zealand, their children, they send this fish oil instead of glucosamine. This is a small observation. And a small observation from my side has been that the glucosamine which is available in India, the Indian brands, whatever, works better than the brands which are sent by most of the children to their kids from the United States, but that's a different story anyway. Another issue which leads to osteoarthritis in our Indian scenario is squatting. Even today, Peddal Mundu Kurchogodano, and Indian toilet is still so rampant because many people still stay in a rented house and it is cheaper for them to have an Indian toilet there. This leads to further degeneration. When you have a small degenerative process starting or a small injury, they still continue to use the Indian toilet. Another thing, the other extreme is where people in our city want to be too health conscious and they do this overrunning. So by overrunning on the tires, which is your knee joint, it leads to osteoarthritis. Right. We all know glucosamine remains our mainstay, but today the biggest fantasy is injections is back or not. Previously, steroids were given because they were cheaper, but in the city we do not give steroids, except for the rheumatoid arthritis. Except for the rheumatoid arthritis, we do not give steroids because there is a very, very small chance that it leads to Charcot's arthropathy or it leads to infective arthritis. So we don't take that kind of risk. That leaves us with two more injections, hyaluronic acid injection preparations, which have been there for the past 2 decades, again used in stage 1 and stage 2. Not very sure about the results in stage 3. Previously we had to give 3 injections, but now it's coming as a single injection. Cost is a problem. But now the latest hero on the block is PRP, which is nothing. Most of you are well versed with PRP. We'll talk about. So it is very obviously platelet rich plasma. Blood is drawn, put in a small machine, a centrifuge, and you get a layer of buffy layer where the platelet is rich. The basic idea is that platelet has got a lot of growth factors in it, which stimulate the growth in the cartilage. 2 or 3 injections are given with 3 or 4 weeks of interval, and it should not be mixed with lignocaine or with steroid. In properly indicated stage 1, stage 2 patients in whom the glucosamine combination of yours has not been successful, we give this. So our numbers are very limited. 80% of the people have found relief for the first 6 months. We would not say that this would last more than 9 months. So definitely a novel treatment only for stage 1 and 2. Some patients you might have to give for stage 3. It is only when the supplements and the change in lifestyle does not work, is not approved in severe stage 3 and stage 4. Now these are the pros, but what are the cons? It is neither FDA approved nor it is approved by the Arthritis Foundation nor by the Rheumatology Association. So it is not approved for knee osteoarthritis or rheumatoid arthritis. It is costly, so sometimes when it doesn't work, patients have a bad taste of it. Patients, especially coming from outstations to us, giving it in the 2nd or 3rd week becomes a difficult task for us, and it lasts only for 9 months when it is given in the proper cases. So the other involvement is if your ACL is torn or your menisci is torn, how are you going to deal with it? Whether you need to deal with it surgically so that it does not on the end stage lead to arthritis, and cartilage. Now cartilage, the way there are grade 4s, when cartilage is damaged either by injury or by degenerative changes, your treatment in the first 2 stages or the first 3 stages of cartilage loss, which is assessed by an MRI, more specifically an MR cartogram, is with braces and medicines in the stage. These are non-surgical. Offloading braces are used. The surgical is whether we can take cartilage from somewhere else, whether it is autologous. You can take cartilage from the patient's own body, or you will have to do a cartilage transfer in a Macy. You will have to decide. Another surgery is an osteotomy. These are advances which are injections based. I think it's still a lot of time to come in the market anyway. So coming back to what you can do with the cartilages, for smaller lesions you can do, you can drill. You can drill microfracture, you can do for less than 1 centimeter, and the fibrocartilage grows instead of the routine cartilage. This is one procedure. The second procedure is that you do OATS, which is an osteochondral autograft transplantation. Okay, I'm not able to get this. Now, what you do is from the non-weight bearing area of the patient, through arthroscopy, you take a punch and you put it in the area where he has lost the cartilage, which has to be less than 15 millimeters in diameter. So these are the instruments which are used. Right. There's another procedure where when the defect is large, you will have to take an osteochondral allograft from somebody, send it for, you can also use the allograft. We are not doing this in India. In India, what we do is we send the cartilage to a center somewhere in Pune, where in 6 to 8 weeks he grows it bigger. He grows it about 1,000 times bigger in area, and you come back and put it to the patient. But the second time when you do this procedure, when the defect is big, it has to be an open procedure. You cannot do a closed procedure in this. This is just to show you the normal OATS, where you take a punch of the cartilage from the non-weight bearing area, which is generally on the lateral side of the patella. So that is the hole you have made. And then I'm not able to take this forward. It will take a lot of time. Okay. Fine. So we talked about two procedures. When the defect is small, it comes from the patient. When the defect is big, also in India, the cartilage comes from the patient. You send it for growth somewhere, and you after 8 weeks you again put it back. Fine. So this is what is done in India. They do the culturing of chondrocytes and the surrounding bone, periosteum, with the periosteum is taken and it's put on the lesion. Fine. So advantages are hyaline cartilage is regenerated again, larger defects are repaired, and where your smaller previous interventions have failed, you can do the bigger intervention. The limitations are definitely it is expensive and it is a two-stage procedure. So we are almost talking about a cartilage transplant in this case, where we are preserving the joint. This is a very big defect, and video na play yan. Okay. I'm sorry, I'm not able to play the video. Anyway, the next thing is when there is a lot of deformity, something which has been there from now 4 decades, is an osteotomy, where you are still preserving the joint, where generally the medial compartment is completely worn out badly. The lateral compartment is not worn out a lot. So you break the bone to make the alignment correct. That's called an osteotomy. And now previously it used to be, if you look at on the extreme side, that was previously used a small clip, but now we are using a plate which has got a bone growing thing inside it, which excites the growth and fills the defect of the osteotomy. So summarizing, in early stages you can use your PRP and DDS. In late stages you do knee replacement, but fibrocartilage, which we are talking about, which is in between, provides a lot of relief. There are a lot of advances in arthroscopy. Smaller defects you can do OATS, and in larger defects you can do the Macy. Of course, once your knee joint is completely worn out, what we do now most is of course the knee replacement, which is not a part of the topic today. And today as just now Dr. G.V. Rao sir was talking, so from computer navigation we have now come to robotics and artificial intelligence completely aiding us in doing a more accurate surgery and in placing the implants well to increase the longevity of the implant. We are more known for our knee I'm more known for the knee replacements, but most of our patients have to be managed conservatively. With this, we are also one of the largest doers of oxynium in the world, and we are the first in South India to get the robotics. I would also take this opportunity to tell you that we have completely shifted our Secunderabad facility, which was our first facility which we opened in 2013, to RTC Crossroads, which is a bigger facility. With these few words, I thank you all for your patient hearing and giving me a chance for this.
Yeah, thank you, Akhil, for nice delineation of how you can preserve the knee joint, especially stage 1, stage 2, and even stage 3, I think. Stage 4, anyhow, your domain of knee replacement. Thank you very much. Swami, anything? Any questions from the audience? If anyone is there, he is ready to answer regarding osteoarthritis of knee joint, which is a very common disease any IMA member, any doctor can encounter usually in their practice, knee joint pain. And you know that to start with anti-inflammatory drugs and the physio plays a vital role, especially in stage 1 and stage 2, apart from your glucosamine. And also the PRP has become a common practice now, injection intra-articularly, even for stage 3, early stage 3. Of course, stage 3, when there is a malalignment or the varus component, usually we are going for the osteotomy procedures, as you already described. I think if there are no questions, and we'll end the topic. Thank you very much once again.
Thank you, sir. I request Dr. Sridhar Rao Garu to please come on to the dais. The senior orthopedician of Karimnagar to please come on to the dais. I request Dr. Sridhar Rao Garu to present a memento to the chairperson, to the speaker, Dr. Akhil Dadi. I request Akhil Dadi sir to present mementos to both the chairpersons. I request Dr. D.C. Tirupati Rao Garu to present memento to Dr. Sridhar Rao sir. Thank you, sir. Moving on to the next session, I request Dr. Srilata Reddy Garu, Senior Gynecologist from Karimnagar. Dr. Srilata Reddy Garu did her MBBS from KMC Warangal and MD OBGYN from Gandhi Medical College. She is a Senior Gynecologist at Lata Maternity Hospital, serving the people of Karimnagar for more than 40 years. She is a past president of IMA Karimnagar and past president of Foxy Karimnagar. Thank you, madam. Now I request Dr. Kavita Reddy Seelam from Nizamabad. Dr. Kavita Reddy madam did her MBBS from MS Ramaya Medical College, Bengaluru, and MD from JJMC Davangere. She is a senior consultant obstetrician and gynecologist from Nizamabad and past president of IMA Nizamabad and present state zonal vice president of IMA Telangana. And I request Dr. Jyoti Budi, the speaker for today's talk, to please come on to the dais. I request Dr. Vijayalakshmi madam, senior gynecologist from Karimnagar and women doctor swing chairperson from Karimnagar, to please come on to the dais. I request Dr. Padmini Madam, Senior Gynecologist from Jagityal, to please come on to the dais. Dr. Vijayalakshmi Madam, to please chair the session. Dr. Padmini Madam from Gynecologist from Jagityal.
Good morning.
Welcome, Madam. I request Dr. Srilata Madam to introduce the speaker for today's session.
So, good afternoon. Dr. C. Jyoti Budi is a well-known fertility specialist, known all over the Telangana and AP state, especially in Karimnagar. She is having her branch for past few years, and I think almost everybody, every gynecologist in Karimnagar district knows Dr. Jyoti. She is a medical director of 49 fertility centers, and she has been trained in reproductive medicine from UK, Dubai and Germany, IFS certified clinical embryologist, trained more than 200 gynecologists in IVF techniques. So let us hear from her and let us enlighten our knowledge. Thank you. Thank you, Madam, for the kind introduction. A very good afternoon to everybody. So, at the onset, I would like to thank Telangana State IMA organization for having such a beautiful, platform they have given, where most of the time when we go as a gynecologist, we have a set of only gynecologists. This is a platform you have given me, and you invited me to share this platform with Solverts here. So thank you for that, and thanks for all of you. I am staying between you and lunch. Spare me for 15 minutes. I'll just finish my presentation. So to start off my talk, I will go and start with a very good note. This is the words from Henry's own mouth. He says, anyone who stops learning is old, whether it happens at 20 or at 80. And anyone who keeps learning is always young. So today I take this privilege to call all of us young here. We are here to share our knowledge and our zeal to education. So if you see this, on Shukla Paksha Chaitra Masa, January 20th, trillions of years ago, 224 BC, Lord Rama was born. So to pursue Lord Rama, his father Dashratha had made a homam called as Putra Kameshti Yagnam. What I mean to say is, the wish for childbirth is not new. It exists since trillions of ages. I got a chance to hear all Solverts here. I am taking you from the field of which is emergency, which is required, to another field of passion. A passion like, to hear father and mother is a dream for everybody. So I am just getting you to this field of fertility. So now, as we all know, for every field there will be some rules and regulation. Recently, 2021, there was something called as an ART Act in our reproductive field. So how did this impact to all the fertility specialists? So that's my talk today. And with due respect to our Honorable Prime Minister Modi ji, I am a fan follower of him. I respect for all the duties he does. But you all know the speech on 8th November 1960, one night 8 p.m. he comes just in front of the media and says, Bhaiyo aur behno, from tomorrow there is no 1,000 rupee notes and 500 rupees notes. What happened to us? We were like first scratching our brain. Is it really true? So, but then it hit everybody in the society. So similarly, in our field, in the fertility field, on 25th January 2022, we got a Prema Patra from the Gazette of the government. What is it? Suddenly, it just dropped in our, in our mail. So what is? We were also confused. What to do?
as a fertility expert or as a gynecologist or any field, we always, when we are having lot of OPs from morning, 8 o'clock we start our day, sometime night we do duties, and we are like, okay, we are always working so hard. Why is somebody pulling our leg? What is a mistake we have done? These things come to our mind. But of course, if you see the guidelines, how it has evolved, especially in ART practice, from 2002 to today, lots of changes has happened. 8 guidelines have been released, and every time a guidelines are released, it means to say there should be some change in the practice. So if I have to highlight some salient features of the previous guidelines, if you see 2008, a oocyte donor, a lady who gives eggs, she could give for 6 times. The guidelines had told that. And look at the sperm. A man can give for 75 times. But then they thought, okay, 2008 guidelines, there was a lot of problems. A man can have his own genetic 75 kids. That is too much. Now government realized something. So it started refining. And then in 2014, it says that donor of egg can give only once. Sperm can give maximum 25 times male. But then now all this is gone. Now they have come with a new rule and regulation, and it's so important for all of us to abide by it. In a general physician level, what we need to know about ART practice, before the law, see, law means we should always understand it is associated with a crime. It is associated with punishment. Guidelines means, okay, I don't know the guidelines, I made some mistake, it's okay, I'll learn from somebody. But when it's a law, if you don't follow, it's considered as a crime. So before the guidelines, what was our practice in fertility? We had some guidelines to follow, and fertility practice was divided basically in 3 levels. As we all know, primary level is a basic, like an infertile couple gets treated. Secondary level is little advanced, and a tertiary level is really complicated cases was dealt. Now, at present, the law says it is only 4. They have categorized it in a 4 level. One is ART level 1, then ART level 2, and then a ART bank, and then is a surrogacy clinic. Though clearly they have mentioned we can't mingle. ART level 1, 2, ART bank, and surrogacy. Before, what was there? There was only guidelines. There was no national board. There was no state board. Nobody was monitoring it. You do the practice, whatever. If there is any problem, then court will, hear it. But now, all we are, monitored. All the level, from each level, from ART level 1 to ART bank and surrogacy clinics, all are being monitored by something called as a state board. So government has taken it, it's like a pride for them. They have taken it very seriously. Every state has a state board now. And this all states, example, we have a very strong board in our Telangana. They are doing really good work. And then this has been monitored by a national board. Before, if you had to start a fertility clinic, it was very simple. Everybody knows. You just take a license, put a board, you start doing your IVF practice. But now, it's not so easy. We need a separate license for this. And then, before, only guidelines, it was not punishable. But now, any mistake, you don't follow the guideline, you are punishable. So what is a punishment? If I say, first time you make any mistake, you don't follow the law, they charge you 5 lakhs and it extend up to 10 lakhs. That is still okay. Without knowing the law, I've not read the law book, I'm not sure you can. But second time, if you make a mistake, doesn't end with money. It is imprisonment. They're very, very serious about it. It starts at 3 years and it can extend up to 8 years. See, we follow good practice as a doctor. We know, okay, this is ethical practice. This is what is good. But when there is a law, we have to abide by it. The set of rules are there. So what happened after hearing all this, we fertility doctors decided, okay, if we make one mistake, then we'll change our profession. Because second mistake is imprisonment. We can't take that. So people started thinking to go for a hotel management or a poultry or go for a real estate. This was the talk when the law came into the action. But then we all know ignorance of law is no excuse. If some mistake happens unknowingly, we can't go to the court of law and say, I didn't know. It is very important to know the law. So why did government become so serious about, this law is so many instances happens and then they think, okay, we have to make organized chain of fertility. It should not be, because here we are playing with gametes. So it should be more organized. It should be more dependable. So if you see in our own country, what about the incidence? WHO says 8 to 16% of reproductive age couples have this problem. That means to say, if you just go deep dive, in your own family there is one couple who is suffering. So I was hearing Akhil Dadi's about knee, something which there is associated with pain. The whole family supports them. Yes, you have pain, you have a fracture, 6 weeks treatment, I will give you rest. But infertility is not like that. There is one couple who is there in your family who can't express more. Hey, it's okay, no, it's not associated with any life. But then if you just sit and talk to them, you can understand their, in this lifetime, if I don't have kid, it is something. So it's our responsibility, if it is a law, it's not like giving up. We have to follow the law and then go ahead. So general obstetrician, where all this infertile couple can go. For basic treatment, and any gynecologist can take care of it. They don't have to go to any expert. They can do the study, they can see the, follicular study can be done, is there any problem? And then even minimal invasive surgeries like laparoscopies, endoscopy, endometrial surgeries, PCO puncture, all this can be done in the general gynecologist level. And then registration is not at all required for them. The regular practice every 5 years we can renew it. Who is required to do IUI? One gynecologist. That's all law has told. Before they had told even a kind of technician. Nothing now. One gynecologist, if she knows follicular study, if she knows how to prepare the sperm sample, she can start the center. And then 3 instruments are very much mandatory. Very minor instruments these are. So it's not so difficult. Of course, there will be inspection by the board and they will certify, yes, this center can go ahead and do IUI. So records has to be maintained. Now, before, just to take you to this, whenever a donor IUI, say suppose a couple come and husband's sperm has an issue. Now this lady, he has sperm issue, azoospermia. Sometime because of so many reasons, if they have to go for a donor sperm in a general gynecologist level, before we would have seen it was easily available. Now it's not like that anymore. It's, they have to go to ART bank. It's like a blood bank. I think in coming days, we will be hearing something like a ART bank very commonly. So it is legal. It's not at all any problem. You have to go in a proper channel, go to the bank, give the requirements, and they will supply the gametes. So there is no confusion now. Why this all happened was just an example I would like to share. In one of the ministerial level in national board, there was maids there. So one of the, she was not able to conceive for 8 long years. Then he asked the, ministry person asked, what happened suddenly you became pregnant? So then they understand that they go somewhere, somebody puts donor gametes and the husband doesn't even know. So all this practice is no more now. It is going to be very, very, very organized. So if we have to start an IVF center, very important, what is level 2 clinic where an IVF center can be done, we have to again apply for a state board, about 1 lakh rupees is the application fees. And what do we need? 4 important people to run an IVF center. Because we personally had an inspection from the state board. They are very nice. They just follow the law. 4 people. Who are the 4 people? Of course, first is a fertility expert. Now, a gynecologist is different and a fertility expert is different. It is not gynecologist anymore. Very, very clearly they have mentioned fertility expert. And then second is an embryologist. Third is an anesthetist, of course. And fourth is a counselor. They are very particular about counselor. In our center, we had actually, when they came for inspection, we had a very good counselor who was trained, but they wanted very specifically, BSc degree. So they have given us a rule book, what we need to follow. And we need to have these 11 instruments. Of course, to run any IVF center, these instruments are mandatory. Now, who is a gynecologist and who is a fertility expert? They have clearly mentioned. If you see here, they have given that a fertility expert has 3 years training in a fertility center. First point, compulsory 3 years of practice. It's not practice, she has to have a training. Second point, she can be a DM fellowship doctor. Again, DM doesn't end there. After DM, 3 years more experience. With these two, 50 egg pickup she should have done. She should have a logbook, and they're very serious about it. They went on digged us, and then they asked us our logbook. They saw everything. So if these are maintained, we can call as a fertility expert. And now all practices where we can write a board of fertility center may not exist from now. It should be properly authenticated fertility center. So what about ART bank? It's something like a bank. This can be started by any registered medical practitioner. What do they do in this bank? They only deal with third-party reproduction. That means to say, a person who donates egg, she can go to the bank. A person who wants to donate sperm can go to the bank. This is the only place where they can, store the gametes. We can't store it in our IVF centers. They have made it very clearly. Now, when it comes to fertility, I feel it's a story of a scientific romance. The smallest cell of the body, that is a sperm, meets the largest cell of the body, that is the egg, and then a pregnancy happens in the fallopian tube and a baby is born. So it's at general practitioner level, we all should know about fecundity per cycle. What is fecundity per cycle? It is the capacity of a couple to become parents in one cycle. You would have got many patients who says, my husband came for 2 months from Dubai, in 2 months I did not become pregnant. It's not possible, because in one cycle, even if everything is fine, pregnancy rates are only 20%. Then a nice guideline says, given 1 year time, 84% will conceive. Why I put this point is, we need not hurry. We have to explain them all these. And then now important, one more about the law is, you would have heard previously a lady of 75 years becoming pregnant. Now it can never be possible. If she is above 50, we can never do fertility practice and we can't do anything on her. So it is a very, very important, changes what they have got here. So where can we treat? General gynecologists can do investigation, follicular study. IUI can be done in level 1. All IVF can be done in level 2. Donor everywhere in ART bank. And surrogacy, especially there is a surrogate clinic. Different it is now. Fine. So of course multiple pregnancy. They have told very clearly we can put only 3 embryo maximum. Ideal practice is to put only 1 embryo when we do a transfer. So you may not see anymore so many multiple pregnancy now. All chances of multiple pregnancy will come into control. See, good practice is ideally 1 blastocyst. We call it a single embryo transfer. Of course, in certain situations, 2 blasts can be transferred. About donor egg, if a lady wants a donor egg, she comes to the IVF center and then, she comes to IVF center, then we send her to the bank. In bank, what do? They get the donors and then they will attach the donor Aadhaar card with the recipient now. Very, very important. If a lady is giving egg only once in her lifetime and her Aadhaar card is associated with the self. So there is no changing of gametes, very, very clearly. And all this data has to go to the state board and then to the national board. And we have to have an insurance of this, and it has to come through a metropolitan magistrate. So they are very serious about it. So now people, if they have to go to a fertility center, you can go boldly and tell all your friends that if they need the treatment, it will be most of the time, gametes are very, very clearly given by law how we have to follow. So there will be no more wiki donors who can keep giving sperms. Okay, surrogacy. Again, when it comes to surrogacy, we all know every time, actually we see only the tip of iceberg. All these film stars get surrogate done by some other route. But what about our people who doesn't have uterus? who has a small uterus. We have so many ladies suffering. Somebody outside there do something, it ultimately hits our people here. We have so many ladies with so much of problem, adenomyosis, thin endometriosis, who are not able to go for surrogacy because of all these reasons. Of course, it's very important step taken by government. It is good. We all have to abide by it. They have done it really well. See, if a lady wants to go to surrogacy, she has to go to a surrogacy clinic, not an IVF center now. And then the surrogate clinic will go to the state board. There is a state board with people sitting there, and this state board will decide who needs surrogacy. There is a essential certificate and a eligible certificate. So after that, they will decide, yes, this lady has problem, she has to go to surrogacy. Somewhere it is becoming like a kidney transplant. They have become very strict. So they have given some essential criteria. Who are the lady who needs surrogate without any uterus, T-shaped uterus, or any problems. Of course, reasons of infertility is increasing. If you see this clipping, I don't know whether my video is on. It's a funny clip. I took it from this movie. Can we get the volume, please?
मतलब ऐसा नहीं कि पहली बार हुआ, यूएस में कई केसेस ऐसे पहले हुए हैं, लेकिन हमारे यहाँ पहली बार।
लेकिन हुआ क्या है डॉक्टर?
हुआ ये है कि there has been sperm mix-up. Please.
What do you mean by sperm mix-up? यानी क्या मिक्सर? कैसा मिक्सर? डॉक्टर साहब हमें भी हिंदी में बताइए। जी।
See, after all these movies, our face became like this. Actually, they show some rotten things in the movie. We don't do that. It can never happen. We have so much of data loggers working day and day with the alarm system. So one movie changed our... After that, believe me, hundreds of patients came to me. Madam, sperm mix-up hota hai kya? I had to sit and answer them. So we should be very careful when we watch movie. We have to deep dive and see what is really there waiting for us. If we have to say about reproductive age, look at this Mahabharata. It was not new. In Mahabharata, in those days, IVF was existing. How was Karna born? He was a Suryaputra. So it's all there from before. It's not new. And look at this. Our Gandhari, she produced 100 kids in 100 pots. Already surrogacy was existing there. You know, in one pot, she used to put sperm, egg, and one culture media. And she had 100 kids to fight the Pandavas. So if we go deep dive and see our Vedas, hats off to our Indian brain. It is such a fantastic, everything is there in our Vedas. So I sometimes want to go to this Hippocrates and say, father of modern medicine, please clap for our Indians. That's what is at the end of the day, no? We are there everywhere. So, okay, this is about, I'll just, because of paucity of time, we had, it's an arbitrary name I have chosen, it's not really Shilpa and Sagar. We did an IVF, 9 embryos we got for her, 3 straw. In first straw, we did embryo transfer, she delivered 2017. And then second straw, it was negative. And then third straw, again she became positive. It means to say, with one IVF pickup, we have given birth to 2 kids. So it's such a wonderful technology. So there is something called as freezing of sperm. It's, any ladies who are having any issue with the like childhood cancers, they can all go for freezing of eggs, sperms or embryos. So major points of concern, I will just go fast because I think, So this was all the initial. We all thought, what is this law? Do we have at the, light at the end of the tunnel? Of course, once we all went to the ministry and requested them and got the little law changed also, they were ready. And because of, they have made it very easy for us now. At the end of the day, what I mean to say, I end my slide with this last slide. Things keep changing. Even law is not to make our life miserable. I learned it actually. They want to make us more organized. They want us to do a good job. So from this Amitabh Bachchan's great dialogue, I learned a lot. He says, as long as we are in practice, we come across several challenges. We should know how to overcome it successfully. Jab tak jeevan hai, tab tak sangharsh hai. Thank you so much for the patient hearing.
Thank you, Dr. Jyoti. It was an excellent and really informative talk you have given. Foremost, I would like to congratulate you on completing the 10 years of your 49, which has successfully given birth to so many lives and made so many couples happy this day. I have 2 questions for you.
Yeah.
You have told DM and you need for a level 2 ART, DM and or fellowship in reproductive medicine. Is it fellowship is recognized by the MCI?
Yeah, of course, when it comes to fellowship, it need not be only fellowship. Say suppose we have so many IVF center which is already existing practicing now. Say suppose some centers are 15 years old. They don't need the degree at all. By virtue of their 15 years, they get the license. 3 years is the demarcation. You should be in the practice for 3 years. You should have either worked in the fertility center for 3 years. You should get a statement that 3 years she was worked with us, then that should be enough. And with the 50 years, 50 pickup logbook we need, egg pickup has to be done.
Second question is, we are from 2-tier cities where we do not have ART banking. We have mentioned that for IUI, you need to take the sperms from ART bank.
Yeah.
So what should we do in small towns or cities, second-tier cities?
I can understand, because when any law comes, actually the society is not ready to face the law, because they make a law, but slowly we have to, maybe in some days you will start getting banks. In fact, in our Telangana, we understood 52 people have, raised requests to start a ART bank. It will start slowly. But at present, we have some banks which has already inspection has happened. You can get the free sperm from there.
Can we get it from Hyderabad to
Karimnagar
or Nizamabad?
Easily with the cans you can get.
Okay. Thank you very much.
Thank you.
Any
Thank
more
you.
doubts?
Thank you for the patient hearing. Thank you so much.
Thank you, Madam. I request the chairpersons to present a memento to Dr. Jyoti, and I request Dr. Nayani, Head of 49 in Karimnagar, to please come on to the dais.
Very excellent presentation, Dr. Jyoti.
Thank you, sir.
On behalf of Karimnagar IMA, we congratulate you.
Thank you.
So much. Just one legal point, I want to raise it. A man, if he wants a baby, he can't, unless he is like a Karan Kapoor or something like that to have a surrogacy. Suppose if a lady, if she wants, I want a baby, but I don't want to know the father. I don't want to know because I have got enough to feed him, grow him up and all these things. But just what I want is, I want a baby. Can I have it? So if such case comes to you legally, and society, whatever it is it possible?
Yeah, good question, sir. Actually, now the latest law says in Indian government, ideally, we usually when a patient comes to us, we take the marriage certificate also, Aadhaar card. But there is also a skeptical point, as you told, for the female. Initially, IUI practice was used, since now donor gametes has become very difficult, we have kept a stay for all this, because donor gametes can be done from the bank itself. So if she has to have a kid, she has to go to the bank, she has to give her Aadhaar card, and then again, these are the grey areas in the law now, which has to be answered. There are some 15 questions, as you have asked, not only for female, especially for a surrogacy also. There is some small changes what they have done. And another question we have is, when we do donor pickup, when we have some 15 eggs for a donor, they have told only 7 eggs you have to remove. Now when we are trying to take the eggs, how can we remove 7 eggs and leave the rest of the eggs? So these 15 queries we all gynecologists have to discuss with the government, and even they have promised us. Recently our board, our Indian Fertility Society and Assisted Reproductive Society both went to the ministry and raised these 15 points, because sometime when they make a law, sometimes they are blunt. Their intention is very good to make it very organized. But what happens is, somewhere, some stringent, which is not practical things has been there in the law. So this point also is one of the point. So at present, we are not encouraging, sir, if a female wants also.
So in your opinion, a lady has to be married to have a child?
At present situation, maybe a guideline may come little in later days. All these points will be addressed.
Is it not against human rights? If she wants a baby, but I am not married, I don't want to marry, but I want to have a child. I can feed them, I can guarantee, I have got a good job,
In fact, sir, what you have told, I have put the evaluation.
I'm a psychiatrist because the cases come to me like that.
Yeah. I have put the slide where there was evolution of guidelines. Before, for surrogacy, they did, a female without a male partner, she could take a child through surrogacy, not for male, because she can take care of the baby. But now in this new law, they have made so many, challenges and all these day-to-day problems. There are something which has to be listed. But at present, we are really not encouraging the donor gametes because we need a ART bank which is getting channelized and inspection is happening from the state board.
Thank you, Jyoti.
Thank you, sir. I request
Jyoti,
Dr. Naini.
I have a question.
Yeah.
It's a very informative session, and we don't know anything about the law. And the surrogacy is a very hot topic nowadays.
Yeah.
And is it legalized? And are there any centers here, or in Hyderabad, or here?
Yeah. So, example, for surrogacy clinic, which was doing surrogacy before, have applied. We, in our center, we have 7 centers. One Dilshuk Nagar center, we have applied for surrogacy already. So we got a call from the state board. They are coming for the inspection. Once inspection happens, it's very easy for us because once inspection happens, they give us a certificate. We put it in the front desk. And then patient, we have to send it to the state board. They will decide now. So surrogacy can be a safe practice from now. It won't be any hidden, because government is involved now. Once they say, okay, this lady can go for surrogacy, it's easy for a clinic to do the job.
So now it is not registered right now.
Inspection is started happening, but surrogacy, I think for ART clinic they have finished, but for surrogacy they have started now. Yeah.
Thank you.
Thank you, madam, for a wonderful session. I request the chairpersons to present a memento to our speaker for today, and I request Dr. Naini, head of 49 Karimnagar, a young and dynamic ART specialist in Karimnagar, to join the session. I also request Dr. Purnima to join the team. I request the speaker to present memento to Dr. Srilata Medreddy, madam. A memento to Dr. Kavita Reddy, madam, from Nizamabad. A memento to Dr. Vijay Lakshmi, madam, from Karimnagar. And a memento to Dr. Padmini madam from Jagatyal. Thank you all. Now the session is put to pause for a lunch break. We'll have a short lunch break, and I request all the participants to return back by 1:45 p.m. sharp. We'll be having a session by Vijay Diagnostics, followed by 2 very important sessions. And the lunch for the drivers is provided outside. And I request all the drivers to have their lunch outside near the parking lot.
and once again I thank you all to have Vijaya Diagnostic Center as being a part of the TS Con 2022. I'm Dr. Bikash Chaudhary, and my presentation today is all about Vijaya Diagnostic Center and its journey in the last 40 years out here in Telangana and Andhra Pradesh and elsewhere too. So let me start off. Our story of Vijaya Diagnostic Center started with the vision and of one person, that is Dr. Surendranath Reddy, who had the idea that good diagnostic services should be available to everyone, which is to deliver the best-in-class healthcare to its patients and facilitate the provision of timely, affordable and state-of-the-art diagnostic center and at the state-of-the-art diagnostic center. Now, in these 40 years, Vijaya Diagnostic Center, we crossed a lot of milestones and being a pioneer in a lot of different fields. Now, for example, in 1981, we were the first center to introduce ultrasound and radioecography. Till 2022, we are still pioneering a lot of things. Like, for example, this year itself, we were the first center to offer dual source CT scan in Andhra Pradesh and Telangana, and also CBCT with 38 phase analysis, all in AP and Telangana. Now the strength of Vijaya lies in two particular pillars. That is, one is its human resources, which includes over 200 plus radiologists, pathologists, microbiologists and technologists. So total, these are very competent and they are well-trained people so that they can give the best possible results to all our clients. We also have 100 empaneled doctors who helps us fulfilling this commitment to our clients. And Vijaya Diagnostic Center is spread across right now more than 17 cities, and the number of centers that we have across India now touches about 140 centers. Now the question here is, in India we have a lot of chain players of diagnostic centers. That includes some very popular names, and now among them Vijaya Diagnostic Center is one of them. Now the question arises, why would you choose Vijaya Diagnostic Center as your center for all your diagnostic needs? That includes both laboratory as well as radiologists. Now, for this I have just one word, that is the trust that we have earned from all our patients and clients over the years. Now, this trust has come as a commitment to our clients, which we have done with integrity, with competent staff, and we have delivered this consistently with sincerity, which ultimately led to a reliability of Vijaya Diagnostic Center as a brand itself. Now I'd like to emphasize on the quality at Vijaya. Our commitment to quality is uncompromising and is achieved through a robust quality management system which focuses on ensuring timely, reliable and accurate results. Now we have a plethora of different accreditation and certification. Of course, we have the NABL certification not only at Himayatnagar but also at Karimnagar Center itself. Now besides that, we have the ISO certification, NABL accreditation, and most importantly, the country or consulates of USA, Australia and Canada, they trust us with the medical testing for the immigration. Now, Vijaya had a fairly successful presence, especially in South India, where I can very confidently say that we are the largest chain in the whole of South India, surpassing most of our competitors. And this success has come over time, and the trust has been earned because we have followed certain things or certain process flows within our centers. Now the pillars of our success mainly depends on our quality of reporting, the faster turnaround time, clinician interactions, good infrastructure, customer services, and client loyalty programs. Now I'll explain a little bit in the forthcoming slides regarding all of these. Regarding the quality of reporting, we ensure that you get the correct, accurate and timely report. For one thing is that we have a plethora of doctors, technicians and paramedical staff who are experts in their field. Whether it's pathology, biochemistry, microbiology, radiology and also cytology, molecular diagnostic, we have all under one roof. Secondly, to fulfill all these testing, we have high-end and state-of-the-art equipment planning. And nowadays, any institute or diagnostic center cannot be put away without the IT infrastructure. We have the state-of-the-art laboratory information management system. And at this point, I would just like to add that just recently, as recent as 1st of November, we have upgraded ourselves to a very, very advanced LIMS. And of course, NABL, ISO and the ISO 15009 accreditation, these make sure that our centers, no matter which part of the country, are giving you the correct and accurate results always. So this is just another slide to let you know how many different PT providers that we are taking for Okay. Sorry for the brief interruption. So as I was saying, we have a list of different PT providers or proficiency testing third-party providers who we are using to test ourselves to make sure that we are giving you the accurate results. Now, second thing is that any good result is useless unless it's also given at the correct time. So there it is, including the one that we have in Karimnagar. Now, one other thing that VDC or Vijaya Diagnostic Center is proud is a culture of fostering interaction with our clinicians and our clients. Now, particularly for the clinicians, first of all, any critical in result, we are informing on time even without waiting for the reports to go to the patients. Now, this will help in faster decisions in treatment or prognosis, whichever way. Then, of course, there are case discussions, differential diagnosis, and if required, we also suggest any further testing for that patient. Now, besides this, not only just reporting, we ensure that all our staff, whether it's a doctor or any other technicians, there's a culture of continuously improving ourselves through medical education. Even during COVID, when the whole world was locked down, we did not stop. We continued through the internet, through webinars. These are some of the examples of the webinars that we had conducted. And all this was to ensure that we develop a more fruitful and a symbiotic relationship, especially with all our doctors and clients. Of course, all these commitments we had to do with a state-of-the-art and a very good high-end infrastructure, and we are improving on this on a day-by-day, not only with high-end infrastructure, but also to reach out even at the remotest areas of AP and Telangana and other states. Now, I'll just give an example. There are certain small cities where maybe a big lab is not possible, but we still have recently introduced mini labs in places like Shadnagar, Vanapati, so that people do not have to wait for their reports. It can be processed there and then, and we get a faster result. Another hallmark of Vijay Diagnostic is the customer services. Now, here Vijay Diagnostics, we have that vision of a complete range of diagnostic services under one roof. And of course, for all our clients, we have call centers for the ease of access for any queries. So ultimately, this all offers one-stop solution for laboratory and radiology under one roof. Besides that, if there are any queries from our customers or whether they're from clients or doctors, we ensure that it is resolved within 24 hours of receiving it. And all these have led to a lot of satisfied customers over the years, which can be seen as testimonials in most of the in videos in YouTube and other places. We also have customer loyalty programs for returning customers. Now this helps in for the customers, our clients or the patients. Is first of all, it's faster support for them. Second, all the digital health records can be accessed immediately. Whether you've done a test 2 years back or 3 years back, it still can be accessed. And of course, there are privilege cards which help you get additional benefits such as discounts for you as well as your family members. So over the years, we have got a lot of awards and recognitions. I won't go into the details, but we have proved ourselves time and again. And at this point, I would like this privilege to introduce two people who are the core of Vijay Diagnostic Center. The first is Dr. Surinder Reddy, a chairman who had the vision to start this way back in 1981, that is all 41 years ago. And secondly, his daughter Ms. Suprita Reddy, who is carrying on with his mission and vision for Vijay Diagnostic Center. Now, to summarize and encapsulate Vijay Diagnostic Center, it is a one-stop solution for all diagnostic requirements, and we have added a lot of additional services, whether it's home collection, online reporting. Besides that, we ensure there's a personalized attention and care to all our clients for an enhanced customer experience. Now, Vijay Diagnostic is also your best bet for your value for the money or the services that you have paid for. And of course, the service environment. Each center is clean, hygienic, and also COVID compliant ambience is there, so that you do not feel that you've walked into any other place. And all these are of course backed by the reliability of our reports, which is the founding thing of our center or the organization. Now, just to encapsulate everything, it is a short video that should we? Okay, so although I was planning for a short video, but because of I believe that we are short of time, so I'll enclose it. I'll just shut it off. Anyway, from Vijay Diagnostic Center, I'd like to thank you for your continued support, and we have a short feedback form, and we'll be very happy to know your suggestions and feedback as to how we can help further improve Vijay Diagnostic Center. Thank you so much.
Thank you. And moving on to the next session, I invite Dr. Pujari Ramana, Senior Consultant ENT Surgeon from Mancherial. I invite Dr. Rahul Narayan Mati from Warangal. Dr. Rahul did his MD from KMC Manipal and DM Oncology from NIMS Hyderabad. He is a medical oncologist who served Karimnagar and in Shalmira Anandrao Institute of Medical Sciences and Raksha Cancer Center for more than 9 years. And presently he is Director and Chief Medical Oncologist at Pratima Cancer Center, Warangal. I invite Dr. Anup Rao Garu, Senior General Surgeon from Korutla. Sir is past President of IMA Korutla, and Sir has also served as President of Thana of Karimnagar District. I invite Dr. P.S. Dattatreya Garu, speaker for the next session.
Good afternoon and a warm welcome for everybody. I hope everybody is done with their lunch. because we have a very famous and renowned speaker, Dr. Satya Tattraya Garu. He has been giving his talks for the last 15 years in India and abroad, and I've been a huge fan of his for his talks and for his teaching skills. Dr. Dattatreya Garu has done his DM and DNB in medical oncology from Gujarat Cancer Institute, Ahmedabad. Presently, he is working as the Director and Chief Medical Oncologist at Renova Saumya Cancer Center, Hyderabad. Formerly, he was Consultant and Medical Oncologist at Omega Cancer Hospital and also Indo-American Cancer Hospital. Sir, we request you to start the talk.
Thank you so much, Rahul. And a very warm welcome to all of you. Thank you so much, the organizing team, for making me a part of this August gathering of the entire Telangana State IMA members. So I'm going to talk about precision medicine and targeting HER2 positive breast cancer. What I plan to do is that provide you about the base, the basis and the basics of cancer treatment as we see it today. So in fact, it's a crusade, it's a fight, it's a battle to cancel cancer. I'll take you through few fundamentals, some elementals and the essentials of clinical oncology practice. And so, let me first let you all know what I'm not going to talk today. No emphasis and no focus on data, analysis, meta-analysis, literature reviews, no high funda stuff. In short, no scientific jargon. So please sit back, relax and enjoy the ride. I'll divide my talk into few sections. Section 1, since morning all of you have listened through various lectures which are an eminent part of all such IMA meetings. So such CMEs at some point of time all of us have delivered or will deliver some lectures, talks, demonstrations and sometimes orations, and a good lecture should have 4 V's. Let me start with the 4 V's of a good lecture. The first V is Vidya, which means adequate and thorough knowledge about the topic or subject on which you need to talk or elaborate or deliberate. The second, if you have to or if you want to teach, you first need to learn. And therefore the best way to learn is to teach it to somebody. The second V is Vaku. You need to articulate eloquently and communicate optimally so that the audience gets the right take-home messages. Sometimes you have wealth of knowledge but you might not be able to communicate properly. So therefore you also need to know how to communicate to your audience, and that should never make us arrogant. You have knowledge, you can communicate that, but that should not make you arrogant. It's a lot more better to be ignorant and be honest about it, and that becomes the third V, Vinayam. So be humble and never think you are better than anyone else, because humility is the greatest virtue. The fourth V, the last, I believe, the least important one, is to be dressed properly for the occasion, and that's Vastra Dharana. So these are the 4 V's of a good lecture: Vidya, Vaku, Vinayam and Vastra Dharana. Well, is that all? The picture becomes complete and perfect if you could also incorporate some satire and infuse some humor in your talk, and so that becomes some Vyangyam and some Vikatam. There should be a purpose served through your talk, and you could dedicate the lecture to the reason or the person behind the same. I dedicate my lecture today to the Telangana State IMA members, and especially Dr. Rao sir, who called me here for making me a part of this August gathering, and that becomes a Vandanam. My Vandanam to all the doctors assembled here. At the end of your talk, you need to answer the questions what the audience wants to know. Sometimes an odd person may ask a question, the answer he knows already. You need to answer that tactfully and make sure that you don't hurt anybody, and therefore answering with Vivekam. So that's the 8th V of your talk. And once that's done, you aim to ultimately end up in a successful lecture. And success can never be an accident. It's about the difference you make in people's life. If your lecture can make a difference in what I practice tomorrow for my patients, your lecture has been successful. That great work which you do is to love what you do, and then you attain the 9th V Vijayam, which means you win over the hearts of the audience. So these are the 9 V's of a good lecture. William Francis Sutton, he was wanted by the FBI for various armed robberies and bank robberies. There's a book by name I, Willie Sutton by Quentin Reynolds. The author is Quentin Reynolds. When finally he was caught by the police, the judge asked him, "Why do you rob banks?" And he answered, "Because that's where the money is." So he did not really say that. What he said was he enjoyed it, he loved it. He was more alive when inside a bank robbing it than at any other point of time. A passion to the opposite extreme. But be passionate about your profession. So that were the 9 V's, my first section for all of you of an ideal and a good lecture. Section 2 of my talk. Yes, I'm here to talk about cancer, but first things first. Cancer also, like COVID-19, is reaching epidemic proportions. Fortunately, we have won over COVID-19 to a large extent. But first things first, 2017 March, Dr. Ruhan gets brutally beaten. That was 2017. Very recently, we know Archana Sharma went on to commit suicide for a known complication after pregnancy or delivery. If death after operation is murder, then every operation should be labeled as attempt to murder. Latest research in India has shown a startling fact. All Indians are immortal till a doctor kills them. I protest the attacks on doctors. I take this platform and try to give you some solutions to see how we can stop violence against doctors. One is to form Federation of Medical Associations. Second, when a patient expires, these days wrong treatments, faulty treatments, wrong diagnosis, doctor came late, and you can employ a black magician who may make the family understand no doctor willfully wants to harm any patient. And therefore, it's God's will, fate, karma and destiny. Employ a black magician who can do that. Third, change your profession. Apply for the post of constables. It's better to beat public than get beaten by them. Fourthly, a painting by Mark Rothko got sold for millions of dollars. And this is how the painting looks like. Yellow and blue is the painting name. Upper half is yellow, lower half is blue. It gets sold for millions of dollars. I am telling you, we all are in the wrong profession. Choose a profession like this. Be a bad doctor. In the last 2 months, I've been able to persuade 7 young people to stop preparing for a career as a doctor. After all, as a doctor, it's my job to save lives. Some of us don't want our children to enter medical profession. That's because they believe in this beautiful line written by doctor. There is no happiness in medicine, and there's no medicine like happiness. I think it's important to be an ideal and a good doctor, and for that you require 9 qualities. Number 1, see all your patients immediately. Nobody wants to wait these days. Number 2, give the right diagnosis on clinical grounds. Look at the pulse, diagnose leukemia. The patient walks in, diagnose cervical cancer. So which means no lab tests, no blood works, no CT scans, no MRIs. Much like what Dr. Jeetu and Dr. Raju. Do you know them? This is the way they did ultrasound in 1980s. This is what patients want. No scans, no MRIs, no investigations, diagnose just by your ears and your pulse. The treatment should give quick relief in minutes, in hours. By the end of the day, the problem should be solved. You should attend to all phone calls, reply to WhatsApp, and also respond to emails. Answer all the doubts to the family innumerable times. At least in Hyderabad, every 3rd patient has somebody in US and UK. You need to also talk to them as well. And sometimes they know some doctor there and he'll tell you how to treat the patient right now in front of you.
but you need to satisfy them and they're treating doctors who are treating. So ultimately you are the medium for that US doctor treating through you. All this with a smiling face and a never say die attitude. I told you 9 qualities, but these are 8. The last, above all, should not charge. If you have these 9 qualities, violence against medical doctors and hospitals can never happen. So that ends the section 2. I dressed the wound, the doctor. I healed it, the God. I paid for it, the patient. And then I will tax the Modi. So I don't care what people think about me. I'm a doctor and I'm proud of it. Section 3 of my talk. Our cell phones these days talk about the camera that they have, the music that they provide. They don't talk about the basic purpose, which is communication. We are clinicians first, MBBS doctors first, then specialists, and then super specialists. A cardiologist doing a 2D echo straight away is not accepted by us. An oncologist getting a PET CT scan straight away is not appropriate. We are MBBS doctors first. Take a history, thorough examination, look at all the reports, spend time with the patient, and then write further investigations. So we are always MBBS doctors first. We are physician clinicians first, and then you may choose the organ of your choice. I am not concerned about the increase in AI. What concerns me is the decrease in real intelligence. Touching the patient is getting lost these days. We all read, the eyes do not see what the mind does not know, which means the eyes are useless when the mind is blind. MBBS, when you join, you are under the society scream. And then the best thing for MBBS therefore is not brain. It's the ischial tuberosity. Between the age of 18 to 25 years, your friends are enjoying their prime youth of life and you are studying 18 hours a day sitting in one place. That is hard work. So the best thing for MBBS is not the brain, it's the ischial tuberosity. In today's age of various telephones, computers, laptops, iPads, WhatsApp universities and Dr. Googles, the habit of reading books is rapidly dwindling and withering away. I therefore am here to serve a purpose of trying to again regenerate the dying art of reading books. One book example I gave you, I, Willie Sutton by Quentin Reynolds. One best book is equal to 100 good friends. Why do you come for these conferences? To gain knowledge, but also to meet your friends. And so one good friend is equal to a library. So don't miss a chance to make sure you meet your friends at the same time gaining knowledge. Cancer, how do you treat it? Snare it, burn it, poison it, which means respectively surgical oncology, radiation oncology, and medical oncology. Patients who fight cancer are cancer warriors. They are not cancer warriors. It's like climbing the Mount Everest. Inclement weather, less oxygen, no water, less food. Book number 2, Into Thin Air by John Krakauer. It ranks among the great adventure books of all times. Unlike cardiology, unlike nephrology, where 90% of problems can be tackled. In oncology, like climbing the Mount Everest, as happened in this disaster, a third of the patients conquer the Mount Everest. 1/3 get injured because of treatments. And only and 1/3 of them are not able to succeed and they succumb to the disease. So there's a long way to go in conquering cancer. But this is what we have come a long way since 1950s, but still a lot in oncology needs to be achieved. The very first medical cure of a liquid cancer, ALL, happened in 1946. In 1956, we cured choriocarcinoma by using a simple drug, a drug by name methotrexate. That day and today, methotrexate still remains the most important drug to tackle gestational trophoblastic neoplasms. Globocon 2012 data, 32.6 million 5-year cancer survivors. 2 years back, we now have more than 50 million 5-year cancer survivors. This is the Globocon data of 2020. So progress depends on collaboration. A medical oncologist alone cannot cure cancer. You require a collaboration of the radiologist, the pathologist, the PET/CT department, the surgical, the radiation oncologist also. So to go fast, go alone. But if you want to go far, go together. So chemotherapy is one way to tackle cancer, which is one part of medical oncology. This man is Siddhartha Mukherjee, an Indian-born American physician who wrote this book by name The Emperor of All Maladies. My third book for all of you. This book won the Pulitzer Prize. Time magazine, one of the 100 most influential books of the last 100 years. New York Times, among the 100 best works of non-fiction. RRR and Bahubali are movies of fiction. Now this is a work based on non-fiction, based on facts regarding cancer, discoveries and developments, inventions, innovations, researches, advances, breakthroughs, shortcomings and pitfalls regarding the cancer patients, their family members, their treating doctors, the medical staff around, highs and lows, ups and downs, some people who shot to fame, some who went into oblivion, the famous, the not so famous and the unheard are all elegantly described in this book by Siddhartha Mukherjee. The book is The Emperor of All Maladies. So 3 books for you. Section 4, Rebecca Skloot. This lady is Rebecca Skloot. From her teenage till middle age, she worked and researched on this woman by name Henrietta Lacks. Henrietta Lacks spent her childhood here. Her parents are reading a book by name Medical Genetics. They never knew their daughter standing behind them, Henrietta Lacks, would be one day called as the mother of modern day genetics. The immortal black woman. Immortal. This is a death certificate. She died on 4th of October 1951, and this is the place where she lies buried. Born 1920, died 1951, 31 years of age. And no dead woman has done more for the living. Captured beautifully in a book by name, The Immortal Life of Henrietta Lacks. A New York Times bestseller, she died in 1951. What happened next changed the whole world. This is a fascinating, harrowing and necessary book. She died in 1951. The cancer that killed her, a pleomorphic adenocarcinoma of the cervix, has been alive and is growing to this day. Scientists have grown some 20 tons of her cells. That was when this slide was prepared. Now we have more than 55 tons of her cells. Let's learn more about the immortal life of Henrietta Lacks. Your microbiology days and pharmacology days, you read about the HeLa cell line? The HeLa is Henrietta Lacks, the first 2 letters of her name. Scientists know her as HeLa. Her name was Henrietta Lacks, a poor black tobacco farmer whose cells taken without her knowledge in 1951 became one of the most important tools in medicine, vital for developing the polio vaccine, for cloning, for gene mapping, for IVF, and of course, cancer research and cancer treatment. The reason these cells were so precious was because they allowed scientists to perform experiments that would have been impossible with a living human being. Till that date, you had never cultured human cells. By 2009, 60,000. Now, 1.2 lakh scientific publications, more than 11,000 drug patents. To repeat, more than 55 tons of our cells, more than 1.2 lakh scientific publications, and more than 11,000 drug patents. Can you beat that? These cells have been bought and sold by the billions, and yet she remains virtually unknown, and they, her family members, cannot even afford health insurance. Very bad. Very sad. HeLa continues to contribute to molecular science. Can anyone guess what HeLa has done to all of us in the recent past? The COVID-19 vaccines, such a huge proportion was possible only because of the HeLa cell line. The impact of HeLa cell line is there in all of us. Everyone who has taken the COVID-19 vaccine. Section 6, total 9 sections quickly. Targeted therapy avoids normal cells and goes directly to cancer cells. And therefore chemotherapy, atomic bomb. Target therapy, a missile, therefore no side effects. 2001, CML treatment before that was the toxic bone marrow transplantation. Now we don't talk of BMT. A simple oral pill controls and almost cures these patients. Now they almost have normal longevity. And that's the rise of targeted therapy in medical oncology practice. Toms River is a place near New Jersey. It's a Toms River township. And there's a book, my 5th book for you. Toms River is the name of the book. Dan Fagin wrote this book. The foreword is by Siddhartha Mukherjee. Even this book won the Pulitzer Prize. A story of a town, Toms River, plagued by pollution from surrounding industries. Almost for 3 decades, the surrounding industries were polluting the land, the soil, the air and the water. And therefore, so you can take an audience poll. It's going well. We just ask him this. 5 minutes. 7 minutes more. So Toms River was getting polluted, and therefore for 3 decades you found more and more cancer patients coming from that area only. Salvation happened when they closed the industries permanently. So gastric maltomas, the treatment is not surgery or chemotherapy. You give antibiotic therapy, Pylokit, and the gastric maltomas can be tackled. Number 4, vaccines. The cause is known, human papilloma virus, cervical cancer vaccines are there. Section 7, dogs can diagnose cancer by sniffing at human excretions and secretions. There's a book by name Heal by Arlene Weintraub. She talks about the vital role dogs can play in the search for cancer causation and cancer cures. So that's about dogs. The other extreme is elephants. 1 in 4 dogs develops cancer. The same medicine used to treat human cancer can also work against canine cancers. Elephants do not get cancer. They rarely get cancer, unlike dogs, and therefore they may hold the cure for cancer. Scientists think they know why it happens. Because age is the same, weight 60 kilos, 5,000 kilograms, numbers of cells trillions and quadrillions. One difference, we humans have 2 copies of a gene P53. Elephants have 40 copies of the gene P53. P53 is a cancer suppressor protein, and that's why elephants don't get cancer. So therefore there's a book by name P53 which should be read by all of you. Quickly moving forward to the last few slides of my talk. Clifton Leaf writes this book, The Truth in Small Doses, How to Win the War on Cancer. One size does not fit all. And therefore comes HER2 new positive breast cancer. You use drugs like pertuzumab and trastuzumab, which will target the HER2 protein on the HER2 positive breast cancer cells. And therefore you have a study by name Neosphere and one more study by name Trifina, which talks about using both these antibodies for HER2 positive breast cancer. So that's how you can use hormone therapy and antibodies to treat cancer. Finally, as a physician, what is my last sentence for all of you? How do you prevent cancer? Number 1, eat a healthy, hygienic, balanced diet. That's not a balanced diet. Number 2, bath at least twice a day, avoid tobacco, avoid alcohol, go to gym 5 days a week, do yoga, pranayam, have sufficient sleep, eat seasonal fruits after each meal, avoid stress, strain, fatigue, including from your spouse, stop using addictive drugs, and get master health checkups every year. Again, 9 points. You do all this, you may be the Pope or Sai Baba or the CM or the President. You'll still die when your time comes. So be happy, make merry. God has given you one life. Live to the fullest. Never ever miss a chance to attend the CMEs by your Karimnagar doctors.
Thank you, sir. I request the chairpersons to present a memento to the wonderful speaker. I request the speaker to present mementos to both the chairpersons. Dr. Anup Rao, sir, and our young and dynamic medical oncologist, Dr. Rahul Narayan, sir. Thank you. Moving on to the next session.
We'll move to the next session. Now I invite the chairpersons, Dr. Sanjay Kalabanda, Professor and HOD, Medicine at Chelmeda Medical College, Vice Chairman of API Karimnagar, Examiner of undergraduate and postgraduate over 15 years, and published many articles under various index journals. Now I invite Dr. Kali Prasad Rao, sir, Senior Orthopedic Surgeon from Warangal, President-elect IMA Telangana, and Director RY Medical College and Hospital. So now I invite Dr. Mohan Rao, sir, Senior Physicians from Karimnagar. So now I invite the chairperson. So now I invite the speaker, Dr. M.V. Rao, sir, renowned physician. Sir, please come on to the dais.
I welcome to the Dr. M.V. Rao, sir, who is a physician from last 30 years in Yashoda. He is treating all types of fever. I learned D for dengue from sir, because you will get a recognition in your life when you are not able to treat your wife's fever. I took to the M.V. Rao, sir. He treated nicely. So he is not a physician, he is a magician in fever. Thank you.
Thank you. Good afternoon, ladies and gentlemen. Thank you for a nice introduction. Had I known that Datta is such a good speaker, I would ask them to put me in front of him, not now. What a wonderful speaker you are. I think I should learn from you. Congratulations, Dattatreya. And all of you, irrespective of specialty, oncology or cardiology or gynecology, all of us encounter fever in our day-to-day practice. Most of the times, fever is self-limiting and it usually subsides without much intervention from our side. But sometimes it can be challenging, frustrating, and sometimes it is really bothering from the family of the patient's family. So, before going to the main topic, let me present a case which I treated recently. This gentleman, who is a frequent traveler abroad, mostly goes to US and Europe, a big businessman, went to Turkey, spent some time with his friends, and also had lunches and dinners there, exposed to some animals, particularly cats, and came back to India. Within 1 week, he developed fever. The fever was moderate grade, chills, and he had some indolent rash over the lower limbs. And was investigated thoroughly in Guntur. All the topical profile was done, and they have done X-rays, ultrasounds, PET, CT scans, all those things. Nothing was found except some lymphadenopathy in the cervical region. And patient was referred to us because as the fever was not coming down, he was kept on broad-spectrum antibiotics. And when he came, I examined him again. I found bilateral cervical lymphadenitis and also axial lymph nodes, which were small in size, non-tender, discrete. Then we did FNAC of one of the lymph nodes from cervical region. It came negative. And as a protocol, we have done a PET scan, again, which showed the involvement of the lymph nodes. There was a significant lymphadenopathy all over the body. Then, as FNAC has not shown anything, Then we went for a lymph node biopsy, which has shown only necrosis. No viable tissue was found, and a TB expert and fungal specimens were negative, and it was negative for malignancy and IHC. Then we did a gram stain on the lymph node, and this was the slide which was showing intracellular bacteria. And we have taken multiple opinions from different microbiologists. They said it could be Bartonella, Rickettsia, or Burkholderia. So clinically, it's not fitting into Burkholderia. Then the patient was very keen on getting the final diagnosis. We took all the pains to send the sample to a reference laboratory for 16S ribosomal gene sequencing, which turned out to be Bartonellosis. So this case shows us that fever can sometimes be very simple. Sometimes we have to involve everything, PET scan, biopsies, and gene sequencing. So sometimes really it's challenging to most of our physicians. Fever is defined in different textbooks are different. For the last 200 years, there is no clear-cut definition of fever. But our textbook, Harrison, says fever is defined as morning temperature of more than 98.9 degrees Fahrenheit and evening temperature of 99.9. So the classical 98.4 or 98.6 temperature is no longer defined as fever. And as the time advances, for reasons as our metabolic rate is coming down, as there are no infections or reduction in infections abroad, particularly in the Western country, the temperature of human bodies is coming down. Maybe next century, it would become 97 or 98. And the problem is patient definition. A lot of patients come to me as prolonged fever, and these people do not really have fever. They perceive it as fever. Someone says that they have bitterness in the mouth. Someone says that they have low fever, which is not recorded by the thermometers. Some say they have the hot breath, hot stools, hot urine. Some people, they have the eyes are congested. So many differences are given by the patients. So in such patients, you have to tell them, you have to counsel them that there is no fever, and we have to look for most of these patients have some psychosomatic symptoms. If you look at the epidemics in India, most of the epidemics in the last century were because of either bacterial or viral. Mostly plague and other viruses have killed many thousands of people in our country. And from 2000 onwards, in 1986, HIV entered India. In 2000, it became peak. Now it's coming down. So after that, if you see, all the outbreaks are viral. In 2002 and 4, you have SARS, then dengue. Immediately, chikungunya followed dengue, swine flu outbreak, encephalitis here and there. Nipah virus, though cases are not many in Kerala. Now, 2019-20, you have seen the coronavirus outbreak. But what is going to happen in the future? Probably after bacteria, viruses, because we are now able to attack viral diseases by many treatments like vaccination, other antiviral drugs. But coming to fungal diseases, I think they are going to increase in our country because of various reasons, not in our country, all over the world, because we don't have diagnostic facilities so far. Even if you diagnose the armamentarium, the antifungals are limited. Even those are becoming resistant because of the adverse use of antifungals in the agricultural production. This is one of the papers published in the post-COVID season from our department. And why do you think these diseases are increasing? Of course, you all know there's the industrial revolution in the last 2 centuries. A lot of green gas are produced, like carbon dioxide, methane, nitrous oxide, which are accumulating in our atmosphere, not allowing the earth to become cool. So because of rising temperatures, there is more extreme weather. Because of this weather, the shift of the vectors from one country to other country, from one region to other region. So we're seeing new diseases each year. And after some time, maybe after a few decades or centuries, malaria, dengue probably will be seen even in the Western world. And another thing for the changing trend in the fevers is, or infections is, traveling. Now you see international travel. Everyone from villages, towns, they are going abroad, either for job or education or pleasure trips. So because of that, we are seeing a lot of diseases, zoonosis diseases, and diseases which were not earlier found in our country. Traditionally, we were taught how to examine the patient, and we used to remember during our student days as pickle. Even now, our juniors write this in the case sheet as pickle, pallor, icterus, clubbing, cyanosis, and so on, so forth. But the most important thing in present day scenario is looking for rash. Even if we are very dark colored, we should look for the rash, because rash is very, very important in the general examination, so that most of the patients can be diagnosed with rash. I'll give some examples. All these pictures, what I'm going to show, are from my patients only, except one. So this patient, of course, has dengue fever. If you see dengue rash, I'm sure all of you have seen this rash. The typical feature of dengue rash is that islands of normal skin, maculopapular rash with islands of normal skin. That is dengue characteristic rash. If you find this rash, it's almost 100% dengue. And another thing is that nowadays we are seeing lots of scrub typhus, particularly from Karimnagar area. Point please. So this is, I think most of you are now seeing this. Yeah. So this is seen. In fact, we are seeing it very frequently, though it's seen only 40 to 50% of patients. This is diagnostic of so-called scrub typhus. And this is, of course, you see many infections, particularly Staphylococcus aureus syndrome, other septicemias, and other vesicobular eruptions are seen in chickenpox. And now, of course, you should now looking for monkeypox in the coming years. And this patient, of course, Dr. Datta must be knowing about this case. This patient had fever for the last 2 years. Going around doctors, the eruption was increasing in size day by day. And I took over the patient and we did a biopsy of skin. And that has shown rare cancer of skin called mycosis fungoides. Now she is under chemotherapy and recovering. And SL is not very uncommon. We see lots of patients coming to us with PUOs. Ultimately, the diagnosis would be SLE. Because of the dark skin, most of us miss the rash. And these patients sometimes go to dermatologists, they go on doing this pilation, that pilation. But unfortunately, by the time they come to us, they develop complications like nephropathy. So any patient who is coming with fever, not responding to the routine treatment, please look for autoimmune disease, particularly SLE in females. And this patient came to my US. He went to his son's graduation, stayed there for some time, and came back with abdominal pain and fever. When examined, I found something in the umbilicus. I thought it is omphalitis. And when I throw this phosphate on his umbilicus, I found this. So there is a tick coming out of. If you see, there is a tick coming out of his umbilicus, which was harboring there for more than a week. So this patient diagnosed have Lyme, and he responded to antibiotic course. And another patient who came to me with prolonged fever, went to dermatologist, diagnosed lichen planus, and was given some ointments. Later she developed some problem in the eye, went to ophthalmologist, gave refresh eye drops, then went to another doctor where they have done chest X and CT scan, found to have this lesion and started an antituberculous treatment. And patient was not responding, then they came to me. Then we did investigations and biopsy, then also C-ANCA, P-ANCA, which was positive. The diagnosis was GPA, otherwise known as vaginal granulomatous. So after the rash, I would like to tell you what are the common changing trends in the fevers what we are seeing nowadays, particularly this season. No lecture is completed without me mentioning about dengue fever. Dengue is changing its presentation. This year, we have seen a lot of patients coming as expanded dengue syndrome. That is, only one organ involvement in the day 1 or day 2. Usually, classic dengue fever comes as fever. It lasts for 3 to 5 days. Patient will be restless, but nothing would happen to that during that time. After 2 or 3 days, patients start developing hypotension because of hemoconcentration. Subsequently, they recover. That is the classic course of the dengue fever. But this year, we have seen a lot of patients in the febrile period, that's day 2 or day 3, they come with either fits or coma. Some patients come with septicemia. Some patients coming with hepatitis. So this so-called expanded dengue syndrome is seen nowadays more commonly. This is one changing trend in the dengue fever. And secondary sepsis is very common. Unfortunately, a lot of patients are getting platelets without proper indication. Even if the platelet count is 50,000, they are giving SGPs, particularly small centers where platelets are prepared at some other blood bank, they transport. During that time or during preparation from the skin of the donor, the platelets may get infected, and that is causing the severe sepsis. And we lost 3 patients this year because sepsis secondary to the platelet transfusion. And this one patient who had underwent LSCS, threw a fit and became febrile on the day 1 of the surgery. And patient was investigated, found to have NS1 positive, and MRI showed encephalitic pictures, and she responded to the conservative management. This patient again came from Warangal, This patient had dengue, NS1 positive on day 1. After a week, IgM was positive. Patient was recovering, suddenly became again febrile and had chills. Total count was about 40,000. Then we examined, he had neurological deficits and neck stiffness. LP showed pyogenic meningitis, and we started treatment for pyogenic meningitis. Patient was not recovering. Then we did the MRI scan, and surprisingly we found subdural empyema, and he underwent surgery, and patient now recovering. And this patient again came from Karimnagar. This patient came in septic shock with the dengue positive, both IgM and also IgG. This patient, when we investigated, she had pyelonephritis. We did a bedside destenting. She was in shock actually. And we did a bilateral destenting on bedside, and she started recovering, and she has been discharged now. Another patient who had dengue recovered and had persistent cough after the recovery. When we investigated, he has pneumonia. Then when we separated sport from culture, it came as fungus, aspergillosis, and he responded to the antifungal treatment. And this is a very interesting slide. This patient, Mallaya, who has developed jaundice, someone told him to take leafy juice from the papaya leaves. He took a concentrated leafy juice twice in a day and developed pain abdomen and came to an acute abdomen. When we investigated, he has perforation of hollow viscus. When we did the endoscopy, he has this picture where there was a corrosive injury. So so-called papaya leaves are very, very dangerous. Please inform your patients, educate them not to take any of these products, including kiwi fruits. Kiwi fruits can cause anaphylaxis reaction. I have seen one patient who took kiwi fruit in the hospital, had a reaction. So please advise them not to take kiwi fruits, not to take papaya juices, not to take goat milk, all those things. They're all from the WhatsApp or from the social media. And this slide, all of you, I want to really read about this. I am saying 90% platelet transfusions are unnecessary. We are giving platelets out of anxiety, the pressure from the patient attendants. Tell them in dengue, platelet count is not important. The most important thing in the prognostication or the treatment is the packed cell volume, not the platelet count. I have not seen any patient in the last 15 years dying with thrombocytopenia. They die with hypotension, they die with coagulopathy, but not with the thrombocytopenia. So any patient who has platelet count less than 10,000, then you can think of giving platelets. In fact, I have not given platelet transfusion to a patient who has count 9,000. Another thing is that please ask your pathologist to check the count manually, because counters usually give spuriously low platelet counts. Don't depend on that and go on giving platelet transfusions. If the patient has bleeding, the count is less than 20,000. If APT is normal, then you can go for the SDB transfusion in these patients. Because there are some dangers with unnecessary platelet transfusions like hypersensitivity. Patient may have alloimmunization. And as I told you in the last slide, patients may go into secondary sepsis and die. And another thing is that some people go on giving FFPs, so-called random platelet transfusions and SDPs. They may develop so-called trolley or transfusion-related acute lung injury. And we had really no idea about flu till H1N1 came into our country. And after that, of course, it became seasonal flu. But we are seeing a sporadic case of flu, patients getting worse and going into ARDS and dying. This year we have lost a lot of patients because everyone thought it is COVID and they did not examine for the flu. They did not give antiviral drugs and some patients died. So please suspect flu. Any patient who comes to the season with cough, cold, body and malaise and fever of 101 degrees Fahrenheit or less than that, suspect flu and give anti-flu medicines, so-called Vaseltamavir, in the beginning, because the response will be excellent. And particularly in patients with diabetes, hypertension, and other immunocompromised conditions, please give them flu drugs, anti-flu drugs liberally. And all of you, educate your patients to take flu vaccine, which is available freely everywhere. And all of you also should take, because you get exposed to patients every day, all doctors should take flu vaccine annually. This is one of the patients who had flu, went down to ECMO, unfortunately died. And this is not my slide, but I took it from the internet. Chikungunya is one thing which has really shaken us in 2016-17. So many people came to us. But now it has become a sporadic case. But suspect chikungunya, any patient who comes with polyarthralgia, sudden onset of polyarthralgia, even without fever. Nowadays, we're not seeing fever in chikungunya patients. It just comes like a mild myalgia while mild low-grade fever, and subsequently patient develops severe polyarthralgias, and when you check for chikungunya IgM or chikungunya PCR, it comes positive. And these patients try to manage with either paracetamol or NSAIDs. Some patients with HLA-B27 become very symptomatic. Such patients do respond to steroids. Though no textbook says that you give steroids, but unless you give low dose steroid, these people do not respond. And enteric fever now is becoming urbanized. We are seeing it more frequently in urban areas than rural areas because of the street food, particularly pani puri. And in Hyderabad, I attend a lot of, they arrange wonderful dinners and lunches, but they never keep a soap and water there. And we shake hands with so many people and go and eat the food, and subsequently we'll end up in having enteric infections. And enteric fever unfortunately became multi-drug resistant. About 10 years ago, Cipro was a wonderful drug for typhoid. The moment you give ciprofloxacin single drug, they used to respond. Now Cipro or ofloxacin or no quinolone is working for typhoid because of the resistance to quinolones, because of the abuse and self-medication by the patients. And unfortunately, the typhoid is very difficult to diagnose. And I'll talk to you about viral tests later. And most abused test in our general practice is viral test. Every patient, even with one-day fever, before even doing dengue test or malaria test, you get the viral test done. That becomes positive because of the previous infections or vaccination. And you brand this patient as typhoid and give antibiotics and miss the very important treatable causes like dengue or falciparum malaria or scrub typhus, and they ultimately come with advanced condition, and they develop a lot of morbidity and mortality. So please suspect typhoid when other things are negative. Like patient doesn't have dengue, parasite F and V are negative, and doesn't have flu-like symptoms, then patient has mild neutropenia and no leukocytosis, then you can suspect typhoid in such patients. And false negative reports and false positive, WHO says that never depend upon the viral test to treat these patients. And this is a graph showing the quinolone resistance. This is a green line is quinolone resistance, which has peaked from 2000 onwards till 2018. Even it's worse even now. So now the treatment of choice for typhoid fever is give intravenous ceftriaxone 2 grams IV twice in adults for 7 to 10 days, and azithromycin, please give 1000 milligrams. I am saying a lot of our colleagues are getting 500 milligrams once daily, plus give 1000 milligrams once daily for at least 5 days. Never give single drug to treat typhoid to prevent drug resistance. Always give ceftriaxone and azithromycin. If the patient doesn't want to stay in the hospital, doesn't want to take IV antibiotics, you can give oral cefixime. And malaria is also changing trends. One thing which I have not mentioned here is that nowadays we are seeing plasmodium ovale and plasmodium malariae in our country. In Orissa, in hilly areas, about 40% of patients are now belongs to ovale and malariae. And please use always combination drugs to treat malaria. Don't treat empirically, because we have wonderful tests for the malaria, rapid diagnosis tests. They are very specific and sensitive. Check that, then only give anti-malarial treatment. There is nothing like clinical malaria. Please check if it's possible to give anti-malarial drugs. Otherwise, please refrain from giving anti-malarials, because you cannot afford to develop anti-malarial drug resistance in our country. And fortunately, according to WHO, the malaria case and deaths are coming down. Look at the Vivax and the falciparum, they are coming down. But unfortunately, in some state, as I told you, the malaria and ovale is increasing, and we have a danger of plasmodium, another fifth type of species, which is going to come to India probably soon, so-called Plasmodium novalaceae, which is already seen in Andaman Nicobar Islands. Though we don't have direct evidence, there are some genetic studies showing that we have Plasmodium novalaceae in Andaman Nicobar. It is as dangerous as falciparum malaria. So whenever a patient has malaria-like features, don't forget to investigate. You can ask the government authorities to investigate for the Plasmodium novalaceae. And scrub typhus, of course, is seen very frequently nowadays, particularly during the monsoon season. It's not very uncommon. seen both in urban and rural areas, because a lot of urban people now are having their farmhouse, they're going out frequently, and they're getting some type of disease. Delayed diagnosis results in very high morbidity and mortality. Please diagnose early. The treatment is very simple. The moment you start doxycycline, within 2 days, patients do recover. Give it for 1 week. But unfortunately, doxy is now developing resistance. Particularly, we have used a lot of doxycycline in COVID area, during COVID season. Now we have a community-wise, we have doxy resistance. So when the patient doesn't respond, please give azithromycin in place of doxycycline. And don't forget about HIV. Though it's coming to our country, somehow in prolonged fevers, a lot of are getting not prescribing for HIV test out of modesty, I don't know, or out of some other this thing. So any patient who is having fever, prolonged fever, whatever the social status is, please suggest them to get HIV test done. This patient was going around doctor for 2 years with fever. She was treated for malaria, she was treated for typhoid, she was treated for tuberculosis. And she came to us with SOB, and when investigated, she was HIV positive. She was never, the test was never done on her, and she had PCP pneumonia. And watch out for these new diseases which are going to come. Apart from these, you may probably develop so-called new malarial disease like Plasmodium novalis. And these are the change in diagnosis modalities. Fortunately, we have now rapid kits for many diseases. Let it be COVID, or flu, or malaria, or including typhoid, we have some dot tests. So all these are really helping us, though the negative and false negative, false positive high, but still they are going to help, they are helping us in day-to-day practice, because that many diseases are diagnosed early and patients are getting benefited. And don't misuse CT scan. We have seen a lot of misuse of abuse of CT scan chest during COVID season. CT scan really useful when the patient has fever. Sometimes we can find surprisingly the so-called mediastinal lymphadenitis or major tuberculosis on HRCT scan. Similarly, PET scan is very useful, particularly in patients with PUO. It can detect autoimmune diseases, malignancies, and tuberculosis. So it can definitely, we can use PET scan when other diagnostic modalities fail. Another important test is scintigraphy. When a patient comes with PUO, we do scintigraphy. Sometimes, surprisingly, we found thyroiditis. And also in patients with rheumatic diseases, where seronegativity is seen always, when you do scintigraphy, you may find inflammatory polyarthritis. So in these two conditions, scintigraphy is helpful. And of course, now we have multiplex so-called film arrays available in Hyderabad that can give you results within 6 hours, and it's really helping. It's really helping in treating complex fevers. Whole genome sequencing available in CCMB and some other laboratories in Hyderabad. And as I told you in the first patient index case, we can do 16S ribosomal gene sequencing in difficult bacterial cases. And Dr. Dattari already told you about this. We are facing a lot of difficulties, particularly from patients from high-tech city. They need everything about paracetamol, fever, self-investigate, self-diagnose, and spoil their health and come back to us at the end. And the mistakes we should avoid in general practice. During monsoon, when you suspect viral fever, or for any fever for that matter of fact, don't give NSAIDs, because NSAIDs will decrease the platelet function, can cause gastric ulcers, and patient can bleed to death. So please avoid NSAIDs. And don't give antibiotics routinely. See whether the patient has dengue or patient has flu. In such patients, refrain from giving antibiotics. And don't perform viral test on the day 1 of the fever. Wait for some time, because antibiotics take some time to rise, and you should repeat the viral test at least 3 or 4 days gap. If you find they are rising titers, then only that's important. Otherwise, don't give any importance to persistent positive viral test. So that's to be avoided completely, except if the patient has hypotension and sepsis. And as I told you in the last slide, don't ease platelet transfusions unnecessarily. That is killing many patients. So what is the take-home message? Management of fever can be challenging in changing times. History and physical examination are very important. Viral disease outbreaks are becoming more frequent. Do not ignore the possibility of life-threatening fungal infections. Autoimmune diseases are very common, not very uncommon in society, so look for them. Investigate judiciously and utilize newer modalities when required. Do not hesitate to take second opinion. Keep yourself updated. Now everything is at your fingertips. You can update yourself every day about every disease. Good communication is very important with the family and patient to avoid unnecessary litigations and problems. Thank you very much for patient hearing.
Thank you, sir. As usual, it was a lesson for all, not just physicians, for all the doctors over here. Thank you for your wonderful lecture. I request the chairpersons to present a memento to Dr. Ims Rao, sir. And I request Dr. Mallesham, sir, and Dr. L. Ram Reddy, sir, to join the session.
Felicitations to Lord Laddu and Shalu with Dr. M. Reddy.
Dr. Ims Rao, sir, will be felicitated with Vemulwada Laddu brought by Dr. Santosh from Vemulwada and a shawl from Vemulwada. I request Dr. Ims Rao, sir, to present mementos to Dr. Sanjay Kalbende, sir. Dr. Sanjay Kalbende, sir, Professor and HOD of Chelmada Institute of Medical Sciences, and Dr. Mohan Rao, sir, Senior Consultant Physician of Karimnagar. Thank you all for your wonderful participation. Thank you, sir. Now,
so thank you very much, all of you, for making the scientific sessions a grand success. With this last talk, we are coming to the end. I am sure and hopeful that the talks must have been very useful to you. Thank you very much, and at the same time I thank my scientific committee members. They worked very hard to make it success. Thank you all.
inauguration session will start in a few minutes, 2 minutes, and the minister and other dignitaries will be coming. I request all of you to stay seated.
Okay, sir.
I request all memento committee members kindly come onto the dais. We have to arrange mementos. The chief guest and other guests are arriving in 10 minutes. Please, the memento committee members, I request all of you to come onto the dais.
Welcome to the city of Shatava. Welcome to the city of Shatavahana dynasty. Ladies and gentlemen, this is the moment you waited for. Let's kickstart the light. Get ready on November 30. Welcome to the city of Shatavahana dynasty. Ladies and gentlemen, this is the moment you waited for. Welcome to the city of Shatavahana dynasty. Ladies and gentlemen, this is the moment you waited for. Welcome to the city of Shatavahana dynasty. Ladies and gentlemen, this is the moment you waited for. Let's kickstart the light. Get ready for November 30. Welcome to the city of Shatavahana dynasty. Ladies and gentlemen, this is the moment you waited for.
Good evening all. Welcome to Honorable Minister Sri Harish Rao Garu and Sri Kamalakar Garu onto the dais. Sanjay, Sri Vinod Kumar Garu and Sri Sanjay Kumar Garu. I request Dr. B.N. Rao, President-elect, to come on to the dais. Dr. Sahajanand Prasad Singh Garu, President, National IMA. Dr. Sharad Kumar Agarwal, President-elect, National IMA. Dr. E. Ravinder Reddy, Sir, Vice President, National IMA. Dr. Lav Kumar Reddy, Immediate Past President, Telangana State IMA. Dr. Kali Prasad Rao, President-elect, 2023-24. Dr. Dwaraknath Reddy, Sir, President-elect, 2024-25. Dr. B.N. Reddy, Secretary, Telangana State IMA. Dr. Gattu Srinivasulu, Finance Secretary, TSIMA. Dr. Sahajanand Prasad Singh Garu, please come on to the dais. Dr. J. Vijaya Rao, Incoming Secretary, Telangana State IMA. Incoming Finance Secretary, Dr.
Sahajan Singh Yadav.
Dr. Sahajanand Prasad Singh Garu, President, National IMA. Please come on to the dais. 5 minutes. Okay. Dr. V. Ashok, Outgoing President. Dr. Kavita Reddy, Outgoing President. Dr. Surendra Reddy, Outgoing President. Dr. C.H. Jaganmohan Rao, Incoming Vice President. Dr. G. Pulla Rao, Incoming Vice President. Dr. Sanjeev Singh Yadav, Outgoing Secretary, AMS. Dr. Srirang Abkari, Incoming Secretary, AMS. Dr. Pujari Ramna, Thana President. Dr. E. Ravinder Reddy, Sir, please come on to the dais. Dr. Lav Kumar Reddy, Sir. Dr. Kali Prasad, Sir. Dr. Dwaraknath Reddy, Sir. Dr. Sanjeev Singh Yadav, Outgoing Secretary, AMS. Dr. Srirang Abkari. Dr. Pujari Ramna. Dr. Surendra Nath, Outgoing Joint Secretary. Dr. Lingamurthy, outgoing State Joint Secretary. Dr. Yashowant Rao, incoming State Joint Secretary. Dr. Sandhya Rani, incoming State Joint Secretary. Dr. Sajanand Singh, Dr. Sajanand Singh. So please come on to the desk. Dr. Sharath Kumar Agarwal, President-elect National IMA, please come on to the dais, sir. Dr. Sandhya Rani, incoming State Joint Secretary. Dr. C.H. Lakshman Kumar, President, Host Branch, please come on to the dais. Dr. Krishna Reddy, Building Trust Chairman, please come on to the dais. Dr. K. Rajeshwar, FSS Chairman, please come on to the dais. Dr. G.N. Reddy, outgoing Joint Secretary, please come on to the dais. Dr. Pentachari, outgoing Joint Secretary, please come on to the dais. Dr. B. Srinivas Rao, outgoing Joint Secretary. Dr. Jagadishwar Reddy, incoming Joint Secretary, please come on to the dais. Dr. M.L.N. Reddy, incoming Joint Secretary, please come on to the dais. Dr. Anand Bokare, incoming Joint Secretary, please come on to the dais. Dr. Balraj, Vice President-elect, please come on to the dais. Dr. Ganga Sagar, Vice President-elect. Dr. Ashok Reddy, Vice President-elect. Dr. Ratnam, Joint Secretary-elect, please come on to the dais. Dr. Guruva Reddy, Joint Secretary-elect, please come on to the dais. Dr. M. Chennaya, Joint Secretary-elect, please come on to the dais. Dr. S. Jagan Mohan Rao, sir, FBS Chairman, please come on to the dais. Dr. Bandila Mohan Rao, Health Scheme Chairman, please come on to the dais. Dr. Vijay Simha Reddy, Director CBP, please come on to the dais. Dr. Surendranath, sir, outgoing Joint Secretary, please come on to the dais. Dr. B. Jansi, Organizing Committee Treasurer, please come on to the dais. Now I request Dr. B. N. Reddy, sir.
బాబు దయచేసి అందరూ కూర్చోండి నాన్న. లెట్స్ ఎవ్రీవన్ సిట్ డౌన్ ప్లీజ్.
Good evening. May I request all of you to stand for IMA prayer. Please repeat after me. May everybody be happy. May everybody be healthy. May everybody be free from pain. May everybody be free from sorrow. May we be the healing cure beyond every greed and lure. Flag salutation, don't repeat. We, the members of Indian Medical Association, stand here to salute our national flag. Its honor and glory shall be our light and strength, and its course shall be our course. We pledge our allegiance to it, and realizing our responsibilities as the accredited members of this national organization, we swear we will dedicate everything in our power to see it fly in the Committee of Nations. Jai Hind, long live IMA. Now I request presiding officer to take over. Thank you.
Good evening and welcome all. Now I request Rajani and Alim go for the lighting of the lamp. Lighting of the lamp, followed by prayer song. Please make it fast. Lighting of the lamp. Yeah. With the chief guest. With the chief. Dr. Adisri Devi, please go for prayer song.
देवदेवं भजे दिव्यप्रभावं देवदेवं भजे दिव्यप्रभावं रावणासुरवैरिरणपुङ्गवं रामं देवदेवं भजे दिव्यप्रभावं रावणासुरवैरिरणपुङ्गवं रामं देवदेवं भजे दिव्यप्रभावम् राजवरशेखरं रविकुलसुधाकरं राजवरशेखरं रविकुलसुधाकरम् आजानुबाहुं नीलाब्रकायं राजारिकोदण्ड राजदीक्षागुरुं राजारिकोदण्ड राजदीक्षागुरुं राजीवलोचनं रामचन्द्रं रामं देवदेवं भजे दिव्यप्रभावम् पङ्कजासनविनुता परमनारायणं पङ्कजासनविनुता परमनारायणं शङ्करार्चितजनक चापदलनं लङ्काविशोषणं लालितविभीषणं लङ्काविशोषणं लालितविभीषणं वेङ्कटेशं साधुविबुधविनुतं रामं देवदेवं भजे दिव्यप्रभावं रावणासुरवैरिरणपुङ्गवं రామం దేవదేవం భజే దివ్య ప్రభావం.
Now I request our State President Rao sir to medal our incoming President Dr. B.N. Rao garu. I request Dr. Vijay Rao garu to come to take a medal from me. I request Dr. Gattu Srinivaslu to medal our incoming Finance Secretary, Dr. Rajendra Kumar Yadav.
Competition, who will say more?
Thank you.
నేను మీరు మాట్లాడతారా నేను మాట్లాడుతున్నా మరి నా దగ్గర మీరు అనౌన్స్ చేయండి నా ఇన్స్టాల్ ద న్యూ మోడల్ చెప్పండి.
చెప్తాను అక్కడికి వెళ్తాను. Now it is my pleasure to install the new body. All the elected members, I think you are having all the paper to take the oath. Please repeat after me. At two places. After stand. What sheet is it? What sheet on that? What sheet? At the two places you have to read your name one and your post. I do solemnly affirm that I will bear the true faith and allegiance to the Constitution of IMA as by law established, that I will uphold the sovereignty and integrity of India, that I will faithfully and conscientiously discharge my duties as that I will do right to all IMA members in accordance with the Constitution and the law, without fear or favor, affection or ill will, that I will not indulge in any unethical medical practice. Thank you. Respected Honorable Health Minister and Finance Minister Sri Harish Rao garu, Sri Kamalakar garu, and Vinod Kumar garu, Sanjay garu, our National President Shahjahan Singh Ji and the President-elect, National President-elect Agarwal Ji. All my colleagues, all the dignitaries on the dais. So good afternoon to everyone. I welcome all of you to this meeting. So this state annual conference, as I put it, some of the issues to be brought to the health minister. One is that the public health interest is the most important thing. For that, both the government and the private sector, which is IMA and others, should try to extend the healthy medical care without compromising with any quality medicine to the poorest of the poor. That is our constitutional obligation. So that is one thing. In this regard, I would appeal to the health minister. Sir, we have taken up an anti-quackery issue in the interest of not only the interest of our members, but in the interest of the public health. Kindly consider. This is one. The third thing is, sir, we are having a lot of problems in the implementation of the Clinical Establishment Act, which we have already brought it to you. Various draconian measures and the laws in regard to that. Kindly look into it, which is under your consideration. Then, coming to the Usmania issue, kindly the government is on the positive side of the Usmania building issue. Please take up that. And many other problems are there. Are so many. My other colleagues, and we will represent it to you in proper time. Thank you for giving me this opportunity. Thank you, all the organizers.
Now I request our branch president and the organizing secretary of the conference, Dr. Ram Kiran, just to give a opening remarks. Sharp.
Good evening. I welcome you all to the TS Con 2022 at Karimnagar. Thank you.
Okay, sound waves. Good evening, one and all. Please, doctors who are outside, come in. I request all the doctors who are outside, please come in. I can resist anything but not temptation. My temptation is to speak the fact and truth. But before speak the truth, we should also laugh. Some people causes happiness wherever they go, others whenever they go. Who are the people of first category? People like our Dr. Sampatrao Garu, Lavakumar Reddy Sir, Surendra Reddy, Dr. Rajani, Dr. Harita, like that. A person who asks a question is a fool for that minute, who doesn't remain fool forever. I certainly belong to the first category. Knowledge is power but limited. Vision is important, but the world is governed by imagination. Our beloved CM KCR is combination of all the three. In this meaning is a combination of Harish Rao Garu, Ganguly Kamlakar and Vinod Rao Garu and then KTR, something like that. Now coming to the truth. most of the people don't know that our beloved guest of honor Vinod Garu is the victim of me, because he is always flooded with my messages, telephone conversation, discussion, analysis. But that is the only way to get the things done in Indian setup. Now coming to the more truth, rather absolute truth is, I was never keen about IMA, but now I am more keen forever. Thanks to when actually I was forced to become a vice president because of all, like Dr. Sampatrao Garu and Ravindra Anna. But when I was contesting for president, everybody opposed me except Ravindra Anna. So that is a life. Respected Chief Guest, Honorable Minister for Health and Finance, Sri Taniru Harashrav Garu, a man of action, dynamic leader, one of the pillars of the TRS movement, by which the dream of Telangana became the reality and the true. Respected special guest of honor, our national president, Dr. Sajanand Singh Yadav ji, our president, Dr. Sampatrao Garu, guest of honor, Sri Honorable Minister Gangala Kamlakar Garu, guest of honor, Sri Vinod Kumar Garu, President-elect National IMA, Sharat Kumar Agarwal Garu, Dr. Sanjay Garu, immediate past President Dr. Lakumar Reddy Garu, President-elect Dr. Kali Prasad Rao Garu, elect Dr. Dwarkanath Reddy Garu, outgoing Secretary Dr. B.N. Reddy, Finance Secretary Dr. Gattu, all elected members for 22, 23, 24 on the dais, ladies and gentlemen, distinguished members, stalwarts, colleagues, friends. A warm welcome to our chief guest. Sincere welcome to the guest of honor and all the stalwarts of IMA. Esteemed members, colleagues, friends, ladies and gentlemen. I deem it my pleasure to address this August gathering of the State IMA 6th IMA Conference in Karimnagar. At outset, let me convey my thanks to all of you for being here to grace this occasion. I also feel more proud to be a member of Karimnagar IMA, where I ascended from branch president to become the state president step by step. Indian Medical Association is the only representative voluntary organization of the doctors of the modern medicine, which looks after the interest of the doctors as well as the well-being of the community at large. This association was started in 1928 on the occasion of the 5th All India Medical Conference at Calcutta with the objectives. So what are the objectives? First being promotion and advancement of the medical and allied sciences in all their different branches, the improvement of the public health and medical education in India, the maintenance of the honor and dignity of the medical profession, and to look after the welfare of the primary member. Today, IMA is a well-established organization with the headquarters in Delhi, with 1950 branches all over spread across the country, with a 390,000 doctors, approximately 4 lakhs. Well, coming to our Telangana IMA, our state has 74 branches with around approximately 20,000 doctors as members of our Telangana IMA. Well, we appreciate the outstanding performance of Dr. Sampatrao Garu during his tenure as the president, and also thank him for keeping up the dignity of the Telangana IMA with his time and talent. Chief guest, sir, IMA commended the Telangana government efforts in controlling the COVID pandemic. It's a record that 28,000 beds have been created with the oxygen facilities in the span of 1 year. Sir, under your leadership, Telangana has been ranked third in the country in latest Niti Aayog Health Index for overall health performance and stands first in the country in the national quantity assurance standards. The state government really deserves a big applause for establishing government medical colleges in all 33 districts in Telangana. And we we Karimnagar people are greatly indebted, particularly for allotting one of the medical colleges to the Karimnagar, in spite of having 2 private medical colleges. So let us give him a big applause. I request all the... Well, on this occasion, I felt it imperative to put forward the important issue of the IMA. The first and serious most is the assault on the doctors, attacks on the hospitals, which is actually becoming a routine, becoming so common that a practicing doctor is really scared of practicing. Sir, there is a law of the land in the country and it has to be respected. It is the responsibility of the government, whether it is state or center, to see that the law is respected. We doctors diagnose the disease, cure the disease, give the life, and yet we are disturbed and attacked and assaulted. It's really very serious, alarming situation. During late Dr. Rajshekar Reddy period, an act has come, 2007-98, under the leadership of our Dr. Ravindra Reddy, then the state president, and Dr. Ravindra Rao, Thana president. I don't know what happened, lately it was diluted. Sir, this is why I insist that IMA need to be more strong and effective. See, when we get into trouble, nobody will come at a rescue, whether it is the bureaucracy, the press, judiciary, even the government. IMA being the political front, this is the only way that we can fight. That is the reason, all the more thereby, we need to become more united so that we can solve the problems through IMA. Getting the fire permission, then pollution control, municipal permit. Sir, on behalf of the IMA, I request as a president to make it a single window. Then the third important thing is the problems faced by small and medium-sized hospitals. Most of them, particularly after the COVID, it is very difficult for them to continue, even to maintain. Particularly during the COVID period, they had hell of problem in even maintaining, giving a salary to the staff. So the only way and the best way is to make or relax the ROGC rules, so that small and medium scale hospitals get the ROGC. Sir, the very purpose of the ROGC is to see to make the specialty care to the common man. Sir, this argosy is very sorry to say, but this argosy is being exploited only by corporate hospitals, which we have to definitely look into the. I mean, we request the government, meaning the health minister, sir, to look into the matter and see that relax the rules and regulations of the argosy. Just see whether the hospital has got the theatre and minimum whatever the minimum requirements is enough to be given a argosy permission, so that a common man will have obtained the bear the fruit of the argosy. The purpose will be served. Now coming to the quackery, Minister sir, Chief Guest sir, Kamlagar garu, I think he is very aware of this. Today, the private medical practice is dictated, dominated by quacks. Not going into the details and the origin as to who started, whether we are the responsible, they are responsible. But it's a big subject, not to be discussed here. But it has to be tackled at any cost by all means. By adopting multi-pronged strategies. But before that, I request all our members to regulate first ourselves. Very sorry to say that, but let us first regulate ourselves. We expect the commission from our own colleagues. So with what face we can tell the quacks? No, we can't. Of course, during Sampadarao period, the quackery, anti-quackery movement in IMA started even right from our Dr. Lavkumar Reddy sir. And during the Sampath Kumar sir period, it has been well discussed. It became a subject of discussion every time. But ultimately, this quackery system has to go. Minister garu, మేము ప్రైవేట్ ప్రాక్టీస్లో కొంత ఎక్స్పర్ట్ చేస్తామే కానీ క్వాక్స్ ఏం చేస్తారంటే దే ఫోర్స్ ద డాక్టర్స్ ఫర్ అన్నెసరీ సర్జరీస్ ఓన్లీ ఫర్ దర్ కమిషన్ ఇన్ ద మనీ. సో ఇట్స్ ఎ వెరీ సీరియస్ మ్యాటర్ టు బి ట్యాకిల్డ్. బట్ బిఫోర్ దట్, బిఫోర్ వి అపీల్, బిఫోర్ వి టేక్ యాక్షన్ అగైన్స్ దెమ్, let us regulate, let us correct ourselves so that the system gets corrected automatically. Perhaps now, since there are so many medical government colleges have come, in a few years many doctors will be coming, and then I think that is the only solution when they will be going to the mandals and then major villages. That is the only natural way to subside, minimize the quackery. Let us be so. But as of now, it is a very serious matter. Now, public health system, sir, Chief Guest sir, first time we are thinking, IMA is seriously thinking to introduce the public concept in the IMA. The public concept means it involves hygiene, drinking water, nutrition. Apart from that, giving a free medical care facilities through camps, medical camps. Medical camps ante ido just normal kaadu, we have to go it very seriously. One decade, the health is becoming so costly. In the last one decade, more than 7 crores in India gone below the poverty line. So it is definitely a very alarming situation. On this occasion, I request, on behalf of the IMA, I request the government, I request the health minister, sir, please try to involve our IMA in your policy making, so that we know much better than non-medicals like your IAS officers and other non-medical officers. We also request appoint whoever is the president of the state has to be a de facto member in the MCI. So now, before I conclude, we have IMA has 3-4 important issues. One, the schemes are the backbone of the IMA, and only the way is to sustain them is to increase the membership. Increase the primary membership. I have been requesting the National IMA, sir, please reduce the membership fee. For that alone, me and Dr. Sampatrao we tried to go to Delhi, we missed the flight, but then I went to the Shirdi, and then from there, by evening I reached, and luckily by the time the turn of Telangana IMA came and I spoke. Yeah, but till now nothing happened. Since our national president is here, came as a guest of honor, sir, some of the issues we should take seriously. I made a request, and so far no result. Again I request, sir, as soon as you reach back, go back to the Delhi, you discuss with all the office bearers of the National IMA and see that the membership fee is reduced. At least keep that period for at least 6 months to make a special drive of a membership. For any organization, the number is important. Then comes the unity. Unless we are united, nothing can happen. Most important thing is the discipline. Pay any price, bear any burden, hamper any hurdles. But at any cost, we will try to restore the discipline. I promise, the day I fail to restore the democracy, discipline in our IMA, I will quit my post. It's not a big issue for me. It's not I am warning, but I am telling you with having seen so many incidents. Membership, we have to increase unity and the discipline. If we are not united, then there is no discipline. Nobody will respect, nobody will care for us. As it is, the government has an idea that there are a lot of issues in the IMA and in other organizations of the doctors. I once again thank all of you in person by name for having come and making this event memorable. I thank from my bottom of the heart the entire organizing committee who has been working for the past maybe around 1 month, day and night, to make it success. Long live IMA. Thank you.
I request AMS Chairman Dr. Sandakumari Madam kindly come out to the dais. We regret we forgot your name to call. Please come out to the dais. Dr. Ratnam Garu, Dr. MLN Reddy Garu, Joint Secretary elect, please come out to the dais. Dr. Ratnam Garu.
Actually, very important point I forgot. I thought outgoing President Dr. Sampatrao Garu, being very practical, he would talk about land development. He didn't. Anyway, we'll make it. Now I request National Vice President-elect Dr. Sharat Kumar Agarwal. National President, sorry. President-elect. National President-elect. Sorry, sir.
respected Dr. Sajanand Prasad Singh, National President, IMA Headquarters, Shri Harish Rao Ji, Health and Finance Minister, Telangana Government, Shri Kamlakar Ji, Minister for Civil Supplies, Shri Vinod Kumar Ji, Deputy of Planning Commission, Government of Telangana, Dr. Sanjay Ji, Member of Legislative Assembly, Dr. Ravinder Reddy, National Vice President, Dr. B.N. Rao, the newly elected President of Telangana State, Dr. Sampath Rao Ji, outgoing President of Telangana, Dr. Kali Prasad, State President-elect for 22-23, Dr. Dwarika Nath Ji, President-elect 23-24, dignitary on the dais and off the dais. First of all, I congratulate the new team and give my best wishes for their good work. And I also appreciate the work done by the last team. So please give them big hand for their doing the wonderful work. Friends, I am the chairman of Hospital Board of India also at present. And we have lot of issues in front of us. And see, issues are very common. If you go any state, any branch across the country, the main issues are very common. Like there is a biggest issue of the violence on the doctors and the establishment. Though the states has made the act against the violence, but still we are fighting for having a central act for that. Because most of the time what is happening, the state has passed, made the ordinance, and they have given the punishment for 3 years, and which is bailable. And most of the time the police station in charge, they are not aware of this act. And invariably they fix up in 304A, which is wrong. So I request, because we have with us Minister Saab, so please they should please make sure that all the police station of the state and the officer, they should be aware of the act for against the violence on the doctors or the establishment. Yes, we are fighting, and we are now after me, when our national president will speak, he will tell the progress on what the IMA headquarters has done on this to make it a central act. Other issue which I came to know is regarding the biomedical waste charges, the fire NOC. See, these all issues has to be handled by the IMA headquarters, at the level of IMA headquarters, because these all are the policy matter which has to be whatever concession we expect, whatever we want, they only be handled by the central government. And for that I request all the member of Thana to please join the HBI, IMA HBI, because at state level our powers are limited, our representation is limited, and without having the help. And see, why IMA has created the HBI. Nowadays the canvas and the working of IMA is huge. It is not limited to the doing the CMEs and all. So IMA, our leadership, our leader of leaders, Dr. Ketan Desai sir, he is the visionary. He thought that there has to be some wing which should be only and only focus on the issues of the establishment of the hospital and the clinics. Because IMA cannot see and give the comment and fight for each and every issue. That is why IMA created so many wings. Like for the specialist, IMA has created the AMS. For the general practitioner, there is a CGP. Likewise, for the taking care of the interest of the establishment, IMA has created the HBI. Unless until every state become the member, numbers of member, so HBI cannot do. IMA cannot do each and everything at its headquarter level. In the government or in the administration, please mark my word, it is the only IMA which is recognized. Any association you go in any other platform, they are hardly listen. So our parent body is IMA. We should respect IMA and we should become maximum member under the IMA. So that is why my humble request to the new coming president that he should motivate and should try to convert Thana into the HBI. That is my request, so that most of the problems will be solved automatically. That is my request. As I was discussing with Minister Sir, clinical establishment which is not till now applicable in Telangana, and that is a very great news, because see, clinical establishment is an act which has been copy paste without understanding the limitation of our country, without understanding the economical status of our country. Some visionary and some brain, they went to Europe and UK, copy paste something what is happening there and put it here. After clinical, if we have to go for the clinical establishment, we have to do lot of things which is not practical for a small clinic or for a couple running nursing home. And the ultimately suffer is the common man, the society. If we have to put all these things, all the water tank, all the fire safety measures, which is not required for a small nursing home, then the ultimately cost who will bear? It has to be bear by the patient. Sir, I will take your attention, Minister Sir. The one surgery which is being done by a surgeon on his nursing home, in 10,000 rupee, if you go to a good hospital or a corporate hospital or a big hospital, who can afford all the requirement of clinical establishment? The charges are, you see, 30,000, 35,000. 3 times what the patient is benefited at the nursing home, at the single running surgeon clinic and the small nursing home. So please, my request, as I'll salute the government of Telangana, their vision that they have not implemented till now. We have recently implemented, our government implemented in UP, but we had exempted hospital up to 50 beds. So I am thankful to the Minister, sir. I will request, see, we should make more and more members of the IMA. And IMA membership should be by heart. We should not bargain for the IMA membership. What is like Dr. B.N. Roy sir was asking to the national president to reduce the rate. Why? It is a single lifetime membership. How much money we take? The headquarter share is, Dr. Sampath Roy sir is in our finance committee, he can tell that what is the share of IMA headquarter. Just few thousands, less than 10,000. We spend when we go on a movie, watching movie with the family. We spend when we go in some tour. So rather than cribbing for reducing the money, we should focusing on making more and more qualitative member. Once we have the members in our kitty, then only our voice will be listened. And we do at headquarter level, we do open the schemes whenever it comes. But we cannot, because without money, nothing can be run. And IMA, the state branch, the local branch, and the same is the headquarter. They don't have any source of income. So to running the expenses, we have to contribute. This is not the fees, this is the contribution from the member. The IMA is by the member, for the member, of the members. So we should be joining IMA by heart. We should be not joining IMA by compulsion. It should be our passion. You did the flag salutation. It is our passion to join the IMA. So my humble request to join IMA, make maximum number of under IMA, and we have to realize IMA is the biggest NGO of the world. We should feel proud when we say we are the IMA member. We should feel proud that we are serving the IMA on some or other kind of position, whether in branch level or state level or the national level. It is our proud to serve the biggest association of the world. IMA has proved his mettle in the pandemic. The world has seen the value of Indian Medical Association of India. WHO has appraised the Indian government management. Why? Just because of our doctors. COVID management was done by the doctors, none other than by the doctors. Minister sir, we have lost 2,000 doctors for serving the COVID patients. You tell me any profession in the world which work 24/7 and during this pandemic, when the husband is not touching the wife, when the wife is not touching the husband, it was the doctor and the healthcare workers who were serving the patient. But we should not forget the doctor, sir. When there is a need, we were welcome with the flowers. And when we are in the need, then we were not giving the time. So please remember, we are the one who will always come to help. We are for the society. Doctors are doing every day, every doctor is doing charity. But the problem is, we are not like businessmen who promote, who market our charity. Every doctor see 2 or 3 or 4 patients free of cost every day. But we never market it. If you count entire India, you see how many crores rupees charity we do. But we never market, sir, because we did it by heart. We have been taught this during our curriculum, during our study. So, I request everyone to please make an issue that every member will add another 10 member to the IMA, and every office bearer at least convince the Thana pupil to become under the HBI. Otherwise, see, the issues of the establishment will not get that speed which will HBI can give you. I am telling you, I am requesting you. I once again congratulate the IMA Telangana branch for wonderful organization. I congratulate you once again. Thank you very much for inviting me. Long live IMA. Jai Hind, Jai Bharat.
Sir, National President-elect, sir, I have a request. I made one request, you made another one. The best solution is either make either you make a law, a rule that each member should make one more, or you reduce the price. There is no compromise in that. Anyway, thank you, sir. Now I request, except the chief guest, ఎవరు కూడా అందరి పేర్లు చెప్పడం అవసరం లేదు. జస్ట్ అడ్రస్ చీఫ్ గెస్ట్ ఈజ్ ఎనఫ్ బికాస్ దట్ టేకింగ్ లాట్ ఆఫ్ టైమ్. నౌ ఐ రిక్వెస్ట్ అవర్ బిలవ్డ్ లీడర్ శ్రీ వినోద్ కుమార్ గారు.
సభాధ్యక్షులు డాక్టర్ పిఎన్ రావు గారు, నేటి ముఖ్య అతిథి హరీష్ గారు, రాష్ట్ర ఆరోగ్య శాఖ మంత్రి గారు, అదేవిధంగా గంగుల కమలాకర్ గారు, రాష్ట్ర బీసీ సంక్షేమ శాఖ మంత్రివర్యులు, డాక్టర్ సంజయ్ గారు, అదేవిధంగా పాస్ట్ ప్రెసిడెంట్ డాక్టర్ సంపత్రావు గారు, ఇంకా మిగతా మిత్రులకు అందరికీ పేరు పేరున, అదేవిధంగా ఐఎంఏ ఆల్ ఇండియా ప్రెసిడెంట్ సదానంద్ ప్రసాద్ సింగ్ గారు, అదేవిధంగా నేషనల్ ఐఎంఏ ప్రెసిడెంట్ ఎలెక్ట్ శరత్ కుమార్ అగర్వాల్ గారు, మిత్రులారా మీకు అందరికీ తెలిసి ఈరోజు రాష్ట్ర కాన్ఫరెన్స్ ఇండియన్ మెడికల్ అసోసియేషన్ 6th కాన్ఫరెన్స్. After formation of the state of Telangana, this is 6th conference. Because of COVID, I hope that you could not conduct those 2 years. Probably that might be the reason. Otherwise, it should have been 8th conference. చాలా విషయాలు బిఎన్ రావు గారు చెప్పారు. దాంట్లో మా మంత్రివర్యులు హరీష్ గారు వారి ఉపన్యాసం లోపల దాన్ని ప్రస్తావిస్తారు. మీకు అందరికీ తెలుసు, ప్రపంచం లోపల ఈరోజు ఆరోగ్యం అనేది చాలా ముఖ్యమైన అంశం, ముఖ్యంగా పరిపాలకులకి, ప్రభుత్వానికి. మన తెలంగాణ రాష్ట్రానికి వచ్చేసరికి మీకు అందరికీ తెలుసు, విద్యుత్ సమస్య పైన, నీటి సమస్య పైన గత 8 సంవత్సరాల్లో గౌరవ ముఖ్యమంత్రి గారు, అదేవిధంగా రాష్ట్ర మంత్రివర్యులు అందరూ కూడా దానిపైన ఒక టాస్క్ తీసుకుని ఆ 2 సమస్యలు పరిష్కరించుకున్నాం. ఈరోజు తెలంగాణ రాష్ట్రం ఏర్పడే రోజు కరెంటు ఉండదు, తెలంగాణలో రైతులు ఆత్మహత్యలు చేసుకుంటారు, కరెంటు తీగల పైన బట్టలు ఆరేసుకోవాల్సి వస్తుందని చెప్పి ఆనాటి చివరి ముఖ్యమంత్రి, సమైక్య ఆంధ్రప్రదేశ్ చివరి ముఖ్యమంత్రి కిరణ్ కుమార్ రెడ్డి గారు శాసనసభలో చెప్పారు. ఈరోజు 24 గంటల కరెంటు గ్రామీణ ప్రాంతాల పట ఏ మారుమూల గ్రామానికి వెళ్ళినా కూడా అలా 24 గంటల కరెంటు. దేశంలో పర్ క్యాపిటా కన్జంప్షన్ ఆఫ్ ఎలక్ట్రిసిటీ Telangana is number 1 per capita consumption of electricity unit wise. So this is the progress which we achieved in the power sector and also in the agricultural sector, particularly with regard to the irrigation system. Earlier Honorable Minister Harish Garu, he was irrigation minister. So in the first 5 years under the leadership of our Honorable Chief Minister K. Chandrasekhar Rao Garu, Harish Garu took initiative in launching all the irrigation projects in the state of Telangana, and we have achieved in constructing the major irrigation projects on river Godavari and Krishna as well. And today it is a success story, nobody can deny. Even our bitter critics in the state of Telangana and also at the national level, they can't make any comment on the irrigation system and power sector in the state of Telangana. Now our priority is education and health. And immediately after we got a second chance to be in party in power in the state of Telangana, our Honorable Chief Minister and also Mr. Harish Garu, who is now the Health Minister, as mentioned by one of the speakers just now, we have bifurcated the 10 districts into 30 Telangana, and in all the districts we have already sanctioned 33 government medical colleges. Of course, in addition to that, not in addition, we were having 5 medical colleges, government medical colleges earlier, and in all the remaining districts, in the remote areas, nobody expected a medical college in Asifabad. Nobody expected a medical college in Bhupalapalli. Nobody expected a medical in Narayanpet. And our Honorable Health Minister Harish Rao will speak some aspects on those, how our state government took initiative on that aspect. And coming to the issue raised by Dr. B.N. Rao Garu with regard to the issues of quacks. My good friend Mr. Vijay Chandra Reddy is here very much present. He is my intermediate classmate. In early 80s, in Kakatiya Medical College, we conducted a seminar on how to how to deal with the issue of quackery in those days. And it's very unfortunate, even after a span of 40 years, once again we are discussing on the same subject of quackery still. It's most important. In those days when we were students, we raised many issues and we conducted seminars inviting very senior doctors in those days on the issue of quackery. And it's very unfortunate that who is encouraging those quacks? That is a big question which you people should answer. It is not we. It is you people you should answer. Who is encouraging the quacks? I can say definitely few among yourselves. Few among yourselves. You are encouraging that quackery. So what law can prevent? Nothing. So it is you people, you have to conduct, you have to educate the common man as well as the doctors, fraternity among yourselves. How to control the quackery system. I know how much money is being spent by patient, a poor patient. Unnecessary. Unnecessary they have to spend. So I think as government, we can help you to some extent, but it is a social evil, frankly speaking. It is a social evil. It is you who have to take initiative. And I think in this conference, at least if not today, in the coming days, you should conduct exclusive meetings on such subjects so that you can try to how to avoid the quackery in the system. So the other issue which you raised, that is with regard to the Act. So when the Consumer Protection Act, I'm a lawyer by profession before I entered into politics, serious politics of electoral politics. Of course, even during my students, I was in active politics, but in electoral politics when I entered, I would not practice law. But I know in the year 1986, when the first time Consumer Protection Act was brought into force, medical profession was also included. And even then, many associations, more particularly the Indian Medical Association, protested. But still, the highest court, the Supreme Court, gave a verdict that definitely you are rendering your services for what? Money. It is service. So you will be under the purview of Consumer Protection Act. That is a judgment given by the highest court of our country, that is Supreme Court, and it's a law. So now you are under the purview of such acts. You can't escape, even if you make hue and cry, Dr. Garu. So it is on the other way, how to overcome such acts if there are any stringent, judgments, or if those judgments which are pronounced against the medical fraternity by and large, without going into those details, you can make an appeal to the next court. But what I mean to say, it is you people who have to control the, when you are rendering your services, definitely you have to be up to the mark. Every patient expects definitely a good service from the medical fraternity. So I think if there are some lacunas in the Act, yes, we can, on behalf of the state government of Telangana, definitely we will hear your views, if any. Lastly, Dr. Sampath Rao Garu and Dr. Vijay Chandra Reddy and also Dr. Vijayender, they're my friends. They brought to my notice that government should allot some land for construction of an IMA, not only a building, but just like I don't want to mention it as a clubhouse, but a center like India International Center in Delhi. So you can make a request with our Honorable Minister, who is very much present. So హరీష్ గారు వాళ్ళకు ఒక 2-3 ఎకరాల భూమి హైదరాబాద్లో కావాలని కోరుతున్నారు. అండ్ ఇప్పుడే నేను గంగుల కమలాకర్ గారిని అడిగిన, ఈ మధ్య గంగుల కమలాకర్ గారు అన్ని సామాజిక వర్గాలకి ల్యాండ్ ముఖ్యమంత్రి గారు అలాట్ చేస్తే వారి సారథ్యంలో పెట్టే అలాట్మెంట్స్ జరుగుతున్నాయి. సో ఇక్కడ ల్యాండ్ ఉందా గంగుల గారు అని ఇప్పుడు ఇక్కడ కూర్చొని అడిగిన, ఎందుకంటే మా ఐఎంఏ మిత్రులు అంటే పాస్ట్ ప్రెసిడెంట్స్ అడగడం జరిగింది. మొన్న సంపత్ రావు గారు అడిగారు, బిఎన్ రావు గారు కూడా తెలుసు. కాబట్టి హరీష్ గారు ఉన్నారు, డెఫినెట్గా మీ అందరి రిక్వెస్ట్ చేయాలని చెప్పి నేను కోరుతున్నాను మీ తరఫున. ఎందుకంటే ఒక 30-40 రూమ్లతో ఉన్నటువంటి ఒక హాస్టల్ ఫెసిలిటీ, సమ్ క్లబ్ హౌస్ హైదరాబాద్లో ఉన్నట్టయితే దూర ప్రాంతాల్లో ఉన్నటువంటి డాక్టర్స్ ఇన్ జగిత్యాల, డాక్టర్స్ ఇన్ ఆసిఫాబాద్, డాక్టర్స్ ఇన్ remote places in the state of Telangana, at least for in a fortnight they may come up, they may visit Hyderabad along with their family members. They can have a very good environment. Delhi lo unnayandi. During my tenure as MP in Delhi, I have seen many such centers like India International Center, which is exclusively for the professors, lecturers, intelligentsia. Atle Indian Habitat Center undi. Constitution Club for we the politicians, we do have a very good Constitutional Club in Delhi. So why can't we have some IMA center? Let us call this IMA center at Hyderabad. So Doctors Fraternity, you please make a request with our Honorable Health Minister. Definitely we will pursue it with our Honorable Chief Minister, and definitely I think you can construct a very big clubhouse for the doctors across the state. Thank you one and all.
Thank you, Vinod Kumar Garu. It is for the information of all the audience that it is Sri Vinod Kumar Garu. He could see that 5 acres of the prime land near the bypass here only, just opposite to that our venue, has been allotted to develop Haritaharam. And we are doing it best to develop it. I think government is afraid of lawyers than doctors. So I suggest that advocate laku maaku iddaru kuda kalpiste santosham. And you are being an advocate yourself. It's a good proposal. Sorry, sir. Now, I request our Honorable Minister, Sri Gangula Kamlakar Garu, to give a message.
Andariki namaskaram. Telangana State Conference for the State Medical Conference ku ముఖ్య అతిథులు విచ్చేసిన గౌరవనీయులు మంత్రివర్యులు కరీంనగర్ జిల్లా బిడ్డ శ్రీ హరీష్ రావు గారికి జిల్లా పక్షాన వారికి స్వాగతం. ముఖ్యంగా 2 మెడికల్ కాలేజ్, గవర్నమెంట్ మెడికల్ కాలేజ్ ఉండి కూడా మళ్ళీ 2 ప్రైవేట్ కాలేజీలు ఉండి కూడా గవర్నమెంట్ మెడికల్ కాలేజ్ ప్రతిపాదించి మా ముఖ్యమంత్రి గారు ఒప్పించి గవర్నమెంట్ కాలేజీకు మనకు శాంక్షన్ చేసిన ముఖ్యమంత్రి గారికి మనస్ఫూర్తిగా జిల్లా పక్షాన కృతజ్ఞతలు. దానికి ప్రతిపాదించిన మన హరీష్ రావు గారికి మనస్ఫూర్తిగా జిల్లా పక్షాన కృతజ్ఞతలు. గౌరవనీయులు వినోద్ కుమార్ గారు, ఎక్స్ఎంపీ గారు, గౌరవనీయులు ఎమ్మెల్యే గారు సంజయ్ గారు, సభాధ్యక్షులు మరియు నూతనంగా ఎన్నుకోబడిన ఐఎం అధ్యక్షులు బిఎన్ రావు గారికి, మరియు నిన్నటి వరకు ఐఎంఏ ప్రెసిడెంట్ ఉన్న సంపదరావు గారికి, వేగించిన పవిత్ర వృత్తులున్న డాక్టర్లందరికీ, ఇక్కడ వచ్చేసిన మా యొక్క కరీంనగర్ జిల్లా మరియు తెలంగాణ స్టేట్ పవిత్ర వృత్తులున్న డాక్టర్స్ అందరికీ, మా జిల్లాకు, మా కరీంనగర్ నగరానికి వచ్చినందుకు మీ అందరికీ స్వాగతం, సుస్వాగతం తెలియజేసుకుంటూ, చాలా సంతోషం. మర్చిపోని సంఘటన, దేశంలో 2 సంవత్సరాల క్రితం ఒక్క కరోనా పేషెంట్ ఉంటేనే భయభ్రాంతులకు గురైన నగరాలుండే. కానీ దేశంలో ఎక్కడ లేని విధంగా ఒకటేసారి 10 కరోనా పాజిటివ్ కేసులు కనబడ్డది ఒక కరీంనగర్ నగరంలోనే. దేశం మొత్తం కూడా కరీంనగర్ నగరంలో చూసినప్పుడు ఏదో అవుతుంది కరీంనగర్ నగరంలో అనుకున్నాం. కానీ సమర్థవంతంగా తన ప్రాణాలు కూడా లెక్క చేయకుండా పవిత్రమైన డాక్టర్ అందరూ కూడా మా ప్రాణాలు కాపాడినందుకు మీకు డాక్టర్లందరికీ కూడా ప్రైవేట్ మరియు గవర్నమెంట్ డాక్టర్ అందరూ కూడా దాన్ని తొందరనే మనం కంట్రోల్ చేసినాం. ఫస్ట్ టైం కరీంనగర్ నుండే ఈ దేశానికి కంటైన్మెంట్ ఏంటో కూడా చేసి, ట్రీట్మెంటే కాదు మన సోషల్లో కూడా కంటైన్మెంట్ చేసి తొందరనే కంట్రోల్ చేసినాం కాబట్టి దానికి ప్రత్యక్షంగా పరోక్షంగా సహకరించిన డాక్టర్లందరికీ కూడా మనస్ఫూర్తిగా అభినందనలు. అప్పుడు ప్రభుత్వ పరంగా కూడా ఆక్సిజన్ కొరత ఉన్నా కూడా వైజాగ్కు మాట్లాడి ఆక్సిజన్తో పాటు ప్రైవేట్ హాస్పిటల్ కూడా హాస్పిటల్లో ఎక్కడ కూడా ఇబ్బంది లేకుండా సరఫరా చేయించిన ప్రభుత్వ పక్షాన. రెమెడీసివిర్ కొరత ఉంటే కూడా ప్రభుత్వంతో మాట్లాడి కరీంనగర్కి ఇక్కడ ఇబ్బంది లేకుండా ప్రైవేట్ హాస్పిటల్ కూడా ఈ ప్రభుత్వం చేతులు అందించింది. అందుకే తొందరగా మన అన్ని కరోనాను కంట్రోల్ చేసింది. దానికి మీ అందరికీ కూడా మరొకసారి అభినందనలు తెలియజేసుకుంటున్నాను. చాలా శుభ పరిణామం. ఈరోజు తెలంగాణ రాష్ట్రంలోనే హైదరాబాద్ తర్వాత ఎక్కువ ప్రైవేట్ నర్సింగ్ ఉన్నది నగరం కరీంనగర్ నగరం. ఈ జిల్లాలో సుమారు 400 వరకు ప్రైవేట్ హాస్పిటల్స్ ఉన్నాయి. అందులో కరీంనగర్ నగరంలోనే సుమారు 350 ప్రైవేట్ హాస్పిటల్స్ ఉన్నాయి. ఇంకా కూడా ఒక 80 వరకు మళ్ళీ అప్లికేషన్ కొత్త నర్సింగ్ హోమ్ కోసం అప్లికేషన్ వచ్చినాయి. అంటే ఎందుకోసం చెప్తున్నామంటే ఈరోజు ఆ 350 హాస్పిటళ్ళు, అందులో ఒక్కొక్క హాస్పిటల్లో నలుగురున్న కూడా సుమారు 1000 మంది డాక్టర్లు మా ప్రజలకు మీరు సేవలు అందిస్తున్నారు. భగవంతుడు అందరికీ అవకాశాలు ఇవ్వడు, మీకు ఒక గొప్ప అవకాశం కలిగించిండు. పేదలకు ఈ యొక్క సేవలు అందించే భాగ్యం మీకు కల్పించిండు. భగవంతుడు అందరికీ అవకాశాలు కల్పాడు. కానీ మీరు అంత మంచి అవకాశం మీకు కల్పించారు కాబట్టి మీరు ప్రజల భద్రత, ప్రజల ఆరోగ్య భద్రత చూడండి, మీ హాస్పిటల్ భద్రత మేము చూసుకుంటామని చెప్పి చాలా. అందుకే మాకు నేషనల్ లెవెల్లో చాలామంది మాట్లాడుతున్నారు హాస్పిటల్స్ మీద అటాక్ అవుతుందని. తెలంగాణ రాష్ట్రంలో అటువంటి అవకాశం లేదు. దట్టు కరీంనగర్లో ఇంతవరకు అలాంటి యాంటీ సోషల్ ఎలిమెంట్స్ను ఎక్కడ కూడా అలా కనబడకుండా నిర్బంధం చేస్తాం. ఒకవేళ ఎవరైనా ప్రమాదవశాత్తు ఏ డాక్టర్లో ఒక పేషెంట్ కావాల్సుకొని చంపడు, ప్రమాదవశాత్తు చనిపోయినా కూడా ఏదో యాంటీ సోషల్ ఎలిమెంట్స్ రాగానే డాక్టర్లే వాళ్ళతోటి కాంప్రమైజ్ చేయకుండా దయచేసి మనమే వాళ్ళకు ఒక అవకాశం కల్పిస్తున్నాం. కాబట్టి మాకు యూ బెటర్ టు ఇన్ఫార్మ్ మీ, మాకు ఇన్ఫార్మ్ చేస్తే అటువంటి యాంటీ సోషల్ ఎలిమెంట్స్ను డెఫినెట్గా మేము కట్టడి చేస్తాం. మనమే ఒకసారి ఎందుకు ఈ గొడవలు, ఎందుకు ఈ కేసులు అని మధ్యవర్తిగా మనం ఒకటి కాంప్రమైజ్ చేస్తే అది ఒక అలవాటుగా హ్యాబిట్గా మారి ఒక యాంటీ సోషల్ గ్రూప్గా తగ్గిపోతుంది. కాబట్టి దయచేసి మీరు ఇవ్వడం కానీ ఎంకరేజ్ చేయకూడదని చెప్తున్నాం. డెఫినెట్గా ఈ కరీంనగర్ నగరం, ఈ కరీంనగర్ జిల్లాలో అద్భుతమైన వైద్యం అందుతుంది. అందుకే మన లైఫ్ స్పాన్ పెరుగుతుంది. కాబట్టి మీకు ఈ ప్రభుత్వ పక్షాన ఈ లోకల్ ఎమ్మెల్యేగా డెఫినెట్గా మా పూర్తి సహకారం ఉంటుంది. ఇంతవరకు కూడా బ్రహ్మాండమైన సహకారం అందించినాం. ఎక్కడ చిన్న సంఘటన జరగకుండా మీ హాస్పిటల్ భద్రత, మీ డాక్టర్ల భద్రత చూసే బాధ్యత ఈ ప్రభుత్వం తీసుకుని చెప్పి వన్స్ అగైన్ మళ్ళొక్కసారి మా ఐఎంఏ ప్రెసిడెంట్ గారికి, నూతన ఐఎంఏ ప్రెసిడెంట్ బిఎన్ రావు గారు చాలా అద్భుతంగా మేము ఎక్స్పెక్ట్ చేస్తున్నాం సార్ మిమ్మల్ని. మరి బిఎన్ రావు గారు మన కరీంనగర్ జిల్లా బిడ్డ. దీంతో పాటు గతంలో ఉన్న విజేందర్ రెడ్డి గారు కానివ్వండి, ఎంతోమంది ఐఎంఏ ప్రెసిడెంట్ పనిచేశారు. మా యొక్క జైతల్లిమల సంజయ్ కుమార్ గారు, వీళ్ళందరి సేవలకు వినియోగించుకొని అల్టిమేట్గా ఈ కరీంనగర్ నగరం ఒక కరీంనగర్ జిల్లాయే కాదు, పక్కన ఛత్తీస్గఢ్ లాంటి మహారాష్ట్ర నుంచి కూడా పేషెంట్లు వస్తారు. కాబట్టి ఒక మంచి ట్రీట్మెంట్ ఇవ్వాలని చెప్పి భగవంతుడు మీకు మంచి అవకాశం కల్పించడానికి పేదలకు మంచి వైద్యాన్ని అందించాలని చెప్పి మనస్ఫూర్తిగా తెలుసుకుంటూ నూతన పాలకవర్గ బాడ్లీకు ఐ విష్ యూ ఆల్ ద బెస్ట్ సార్. మే గాడ్ బ్లెస్ యూ ఫర్ ఎ గుడ్ సక్సెస్. థ్యాంక్ యూ వెరీ మచ్. జై హింద్.
మా మంత్రి గారు, ఐ థింక్ టు మేక్ ద నేషనల్ లీడర్స్ టు అండర్స్టాండ్ ఐ వుడ్ స్పీక్ ఇన్ ఇంగ్లీష్, దో ఐ వుడ్ లైక్ టు లవ్ టు స్పీక్ ఇన్ తెలుగు గివెన్ ఎ ఛాన్స్. Sajan Singh, our minister who spoke just now, Dr. Gangula Kamlakar Garu, is always friendly to the doctors, unlike few politicians. Anyway, now before our national president addresses, I request release of the journal of the Telangana IMA. And I also request Dr. Ramana Pujari, Thana President, to give a memorandum to. Yeah.
Good evening. Telangana Journal of IMA. Currently, we are releasing Volume 2, Issue 2. Our honorary editor, Dr. Porunla Kishan sir,
So we
is
are
out of
releasing
station.
both Savanir and Journal. रिलीज करो भाई। अभी सामने रहेगा।
Is it a regular feature, sir?
Yeah. Now I request our National President to address. Sir, Thana President.
Om Namo Bhagavate Vasudevaya. In the morning, you should all remember Lord Krishna for a minute. First, I salute those who lost his life during COVID period. So, we should remember always, more than 2,000 doctors has lost his life. My dear respected Sri T. Harish Rao ji, he is well-behaved minister, health minister. I have not seen like that. He has got so good health. I have just told how you are maintaining this health. You are so easy, and he has told me that I have to do daily 1.5 hours exercise. So doctors should follow our health minister's routine. Sri G. Kamlakar ji, Sri Dr. Vinod Kumar ji, Mr. Dr. Sanjay ji, my younger brother, Dr. Sarat Kumar Agarwal, the dashing would be president very soon, and Mrs. Reshma Agarwal would be first lady of IMA very soon. Dr. E. Ravindra Reddy ji is a vice president of All India IMA. Respected Dr. B. N. Rao ji is a president here. Other is Dr. Dwarkanath Reddy ji, and third is the Kali Prasad Reddy ji, Kali Prasad Rao. And Secretary Dr. Vijay Rao. I congratulate you all for the new office bearer. First, I congratulate Dr. Sampath Rao team. His work was so satisfactory. We have come here at that time. Sir, Andhra Pradesh and Telangana is a second home of ours. We used to come frequently. That is due to Dr. Ennappa Rao. Sir, Dr. Ennappa Rao is the father of IMA. He was very close to Dr. A.K. Sinha, was president of Medical Council of India, was president of World Medical Association and Commonwealth Association. At that time, IMA was governed by the two personalities, Dr. A.K. Sinha and Dr. N. Apparao. These days, we are working in the umbrella of Dr. Ketan Desai. So, Dr. Gutta Suresh, Dr. Vijay Chandra Reddy, Dr. Shekhar Reddy, Dr. Pramila, Dr. Phula Rao ji, Dr. Shyam Sundar ji, Dr. Mohan Rao ji, Dr. Kiran, the president of Ram Kiran, president of this branch, and Dr. Venkatesh Reddy. So, sir, this type of gathering, which is a rare gathering in the country, like a national conference, we have gathered here, like a national conference. Your state is so strong, I am saying since long. Your branch is strong, your branch is very strong, that's why we are strong. That is due to you people. So, we have to improve our membership, as our President-elect has told us, and we will consider Dr. B.N. Rai has told us regarding the fees of the membership. We will think over, we will discuss with all the office bearers. So many things has told our President-elect. So we are thinking about 3-4 things that are very important for the doctors. One, as a mixopathy is a great problem. At Gujarat, there was a huge conference. Perhaps our minister has not gone there, but the 28 minister has gone, and they have all supported that we have discussed about the committee which should be formed by the central government. In that committee, 2 members from the Ayurveda, 2 from the homeopath, 2 from the IMA, and 1 from the Ims, and 1 doctor from the PGI Chandigarh. All government has supported us, all part of the state supported us. The second problem is violence against the doctors, which is very, very much problematic these days. We want central law, central rule. In that, our minister has told that we will do at the time of pandemic, that will be in endemic time. Those provision in the pandemic time, this provision will go to endemic. सब दिन के लिए होगा. All minister of the state was supported us, and they have make a rule there, resolution there, and pass the resolution, and they have sent to Home Minister and Prime Minister. Other problem is CPA. In CPA, at the time of Ram Vilas Paswan, he has exempted the doctors from the CPA. But there is some confused and done by the IS officers. They have not done it. So we are trying that in CPA doctors should be exempted. And last, the Clinical Establishment Act. You are lucky enough, our minister is so good. He has told us कि नहीं ये तो बहुत ज़रूरी है. He is speaking in Hindi, very good Hindi. He is speaking. कहा कि हम तो क्लिनिकल एस्टेब्लिशमेंट यहाँ लागू करेंगे, 50 बेड तक हॉस्पिटल को यहाँ से ही करेंगे. एग्जाम्प्ट करेंगे। यदि 50 बेड तक का हॉस्पिटल को एग्जाम्प्ट यदि करेंगे सर, तो आपका हमारा स्टेट तेलंगाना all small hospital will be furnished. So, we have come here with Dr. Narasimha Rao. Narasimha Rao is so nice gentleman. He is very active. He was vice president of All India, and he has taken from this Tirupati to here. One thing I have to assure you, $10 lakhs we have to give Dr. Kirpal Singh from Benevolent Fund. His wife, Leela Rani, has lost her life during this corona period. So after going to Delhi, we'll have to give 10 lakhs from the Benevolent Fund. So sir, Telangana is so progressive a state. You are showing data. In everything, this stage is the first. Lastly, I congratulate the officer of Karim Nagar branch and Telangana state branch for having very good conference. Thank you very much. Jai Hind, Jai IMA, Jai Bharat.
Now I request our chief guest to address.
గౌరవనీయులు, బహుశా మీ అందరు మూడు చూస్తూ ఉంటే ఎప్పుడు ఇంటికి వెళ్దాం అన్నట్టుగా ఉన్నది. శ్మశాన వైరాగ్యము అని ఒక పదం ఉంటుంది తెలుగులో. అట్లాంటి పరిస్థితి కనబడుతుంది నాకు. ఇట్స్ వెరీ హార్డ్ టు టాక్ ఇన్ దిస్ టైమ్. మీ అందరిని చూస్తూ ఉంటే అందరూ మాట్లాడుకుంటున్నారు, ఇంకా 5 అయింది, ఎప్పుడు కారెక్కుదామా అనే మూడు కనబడుతుంది మీ అందరిలో. ఇట్లాంటి టైంలో మేము మాట్లాడాలంటే స్పీకర్కు కొంచెం కష్టమే. ఇట్స్ వెరీ హార్డ్ టు స్పీక్. మీ అందరు కూడా వాచ్ చూస్తున్నారు, టైం చూస్తున్నారు. అందుకే ఇప్పుడే అడుగుతున్న బిఎన్ రావు గారిని, మమ్మల్ని ఇప్పుడెందుకు పిలిచినావు, మార్నింగ్ సెషన్ పిలిస్తే పొద్దున ఫ్రెష్గా ఉంటుండే కదా అంటే, నువ్వు ముందు మాట్లాడిపోతే ఎవరు ఉండరేమో అని లాస్ట్కి పిలిచిన అంటుండు. సరే, ఎనీహౌ, గౌరవనీయులు, కొత్తగా ఇప్పుడే ఐఎంఏ అధ్యక్షుడిగా బాధ్యతలు చేపట్టిన డాక్టర్ బిఎన్ రావు గారు, పదవీ బాధ్యతల్ని హ్యాండ్ ఓవర్ చేసినటువంటి సంపత్రావు గారు, గౌరవనీయులు మిత్రులు రాష్ట్ర బీసీ సంక్షేమ శాఖ మంత్రివర్యులు గంగుల కమలాకర్ గారు, మా అన్న రాష్ట్ర ప్లానింగ్ బోర్డు వైస్ చైర్మన్ గౌరవనీయులు వినోద్ కుమార్ గారు, డాక్టర్ సంజయ్ గారు, మా మాజీ శాసన మండలి సభ్యులు నారదాస్ లక్ష్మణరావు గారు, అండ్ ద నేషనల్ ఐఎంఏ ప్రెసిడెంట్ ఎస్ఎస్ ప్రసాద్ గారు, అండ్ ఇన్కమింగ్ ప్రెసిడెంట్ శరత్ కుమార్ అగర్వాల్ గారు, అండ్ ఆల్ ద డిస్టింగ్విష్డ్ డాక్టర్స్, ఐఎంఏ మెంబర్స్, మీడియా ఫ్రెండ్స్, అందరికీ పేరు పేరున నమస్కారం. ముందుగా ఐఎంఏ బాధ్యతలు చేపట్టినటువంటి కార్యవర్గ సభ్యులందరికీ శుభాకాంక్షలు, అండ్ ఐ విష్ యూ ఆల్ ద బెస్ట్. Certain issues are raised by the state new IMA president and also national present president and the coming president. First I address those issues and then I'll go to the regular subject. So naturally, any organization, any government or private or a organization like IMA will be having issues. सो आप बात करते रहना पड़ता, आप पूछने पड़ता, कोई फोरम पे आप उठाना ही पड़ेगा. गवर्नमेंट्स आर सपोज टू रिजॉल्व एंड इट विल बी ए नेवर एंडिंग. अगर से आप जो 4-5 पूछे हैं मैं कर दिए, फिर 4-5 आएगा. ये तो कभी बंद होने वाला नहीं है. इट्स ए कंटिन्यूअस प्रोसेस. इन डेमोक्रेसी इट इज़ ए कंटिन्यूअस प्रोसेस. सो ऑलरेडी हमारा IMA भी हमें आके मिल रहा था. दे वर आस्किंग फॉर ए सिंगल विंडो सिस्टम. कोई नर्सिंग होम डालना है तो डॉक्टर म्यूनसिपालिटी के पास जाना पड़ रहा है, फायर सर्विसेज के पास जाना पड़ रहा है, और DMNHO हेल्थ डिपार्टमेंट से परमिशन लेना है. ऐसा बहुत सारे परमिशंस लेने के लिए पैसे भी खर्च हो रहा, समय भी जा रहा है. इसके लिए कोई सिंगल विंडो सिस्टम ला सकते क्या बोल के मुझे दे हैव गिवन ए प्रपोजल. एक्चुअली इन तेलंगाना वी स्टार्टेड इट कॉल्ड TS IPAS. कोई इंडस्ट्री डालना है तेलंगाना में, राइट टू गेट द परमिशन. वी ब्रॉट ए एक्ट इन द गवर्नमेंट स्टेट ऑफ तेलंगाना. आप अगर से एप्लीकेशन इंडस्ट्री के लिए डाल दिए तो सिंगल विंडो सिस्टम में पोल्यूशन कंट्रोल बोर्ड, इंडस्ट्रीज डिपार्टमेंट, रेवेन्यू डिपार्टमेंट पूरे परमिशंस 30 दिन के अंदर दे देते हैं. नहीं दिए तो यू कैन स्टार्ट डूइंग द कंस्ट्रक्टिंग द फैक्ट्री. सो राइट टू गेट द परमिशन फॉर एन इंडस्ट्री, दैट इज कॉल्ड TS IPAS. अभी इन इंडस्ट्रीज में तेलंगाना इज द रोल मॉडल फॉर होल कंट्री. लेटर ऑन ऑल स्टेट स्टार्टेड इंप्लीमेंटिंग द सेम पॉलिसी. ऐसे ही कोई हेल्थ डिपार्टमेंट में भी कोई नर्सिंग होम डालने के लिए, डॉक्टर्स के लिए भी कोई सिंगल विंडो सिस्टम आए तो अच्छा रहेंगे बोल के एक हफ्ते 1 महीने पहले हमारे पूरे टीम आके मुझे बता रहे थे. दे हैव गिवन ए रिप्रेजेंटेशन. In fact, I discussed with my health secretary and chief secretary. We are working out a methodology. We will try to bring a single window system to give permission for any nursing home. And secondly, they also requested for fire services. ये बहुत तरीके से important है. I think before month, there was a fire accident in Tirupati. Our doctor was died. See, इसमें ऐसे है, fire रहने में अच्छा भी है, थोड़ा प्रॉब्लम भी है. So if it is not there, few patients were died, including our doctor. In Tirupati, a children specialist died in a fire accident happened in nursing home. So the government, during COVID also, there was a big fire accident in Vijayawada and in many other states also. So governments is only trying to protect the doctor and as well as the patients. So इसमें क्या समझ में आया, अगर से नया नर्सिंग होम डाल रहे ठीक है, we can strictly implement the fire service rules. जो पुराना पिछले 20 साल से 30 साल से जहां पर नर्सिंग होम चल रहा, अभी उनको फायर गाइडलाइंस फॉलो करो बोले तो पूरा तोड़ के फिर बनाना पड़ता है, which is practically not possible. उसके लिए मैं थोड़ा फायर सर्विसेज ऑफिसर से भी बात करके थोड़ा देख के चलो, इन लोगों को थोड़ा मदद करिए. अब 30-40 साल से चला रहा, आज के दिन फिर तोड़ फोड़ के तो नया नहीं बना सकते हैं. वो गवर्नमेंट के तरफ से भी जितना सपोर्ट हो सके करने के लिए मैं बताया. विद इन द सिस्टम what are all the measures to be taken, they will definitely follow बोल के I instructed the fire DG and the other officers. About this clinical establishment act, आपका तो प्रेसिडेंट साहब बाजू बैठते बैठते पहले मेरे से वही शुरू कर दिया. 50 बेड के अंदर जो दवाखाना है, जरा भाई साहब उसको छोड़ दो. इधर इन्हें बोलते रह रहा, वो तो कमिंग प्रेसिडेंट जाके वहां माइक में बोलना शुरू कर दिया. अरे दोनों में इतना आपके लिए तड़प रहे हैं, इतना आपके डॉक्टर्स के लिए. बहुत प्रेसिडेंट्स, द प्रेसिडेंट एंड द कमिंग प्रेसिडेंट आर वेरी एंथुजियास्टिक एंड पॉजिटिव टू प्रोटेक्ट द डॉक्टर्स एंड द नर्सिंग होम्स. मैं आपको अप्रिशिएट भी करना चाहता हूँ, आपका जिम्मेदारी है. आप तो आपका जिम्मेदारी इतना प्रेशर ला रहे हैं. फिर भी तेलंगाना में भी हम सोच रहे थे, एक्चुअली क्लिनिकल एस्टेब्लिशमेंट में एज यू सेड, राइटली सेड, देयर आर सम फ्लॉस. वो स्ट्रिक्टली एक्ट के तमाम उसको इंप्लीमेंट करने गए तो बहुत सारे इश्यूज आने वाले हैं. प्रैक्टिकली इट इज नॉट फीजिबल. इस वास्ते वीवर एक्चुअली एक्ट तो हम पास करें, बट अभी तक उसको इम्प्लीमेंटेशन में पूरी तरीके से नहीं लाया है. फिर भी कभी भी हम लाना है, वो हम जरूर, जो 50 बेड के अंदर जो हॉस्पिटल है वो हमारा मन में लग रहते हैं. हम CM साहब से बात करेंगे, पूरा तरीके से आपसे हम मदद करते जाएंगे. बस और कुछ इश्यूज भी हैं. Our IMA is always welcome. हमारा ताना and other organizations. जमीन तो दे चुके हैं सर हमारा मिनिस्टर साहब. आपके पास ही बहुत पैसे है ना भाई. कहाँ है? ठीक है, मैं क्या बोलता हूँ, थोड़े बहुत नहीं बोलने में अच्छा है. सर, आपके प्रेसिडेंट साहब बोल रहे बिल्डिंग के जमीन के बारे में. करीमनगर में तो कमलाकर साहब दे चुके हैं. हैदराबाद के लिए भी विनोद कुमार साहब आपके तरफ से एज एन एडवोकेट ही एडवोकेटेड. IMA पूछने से पहले विनोद कुमार साहब पूछे. बाय प्रोफेशन इज एन एडवोकेट, बट ही इज ऑल्सो वेरी क्लोज टू अवर चीफ मिनिस्टर. हम दोनों, उनके घर में भी डॉक्टर है, आधा डॉक्टर भी है उनके विनोद साहब के घर में. सो विनोद साहब इज वेरी पॉजिटिव. मैं और विनोद साहब दोनों मिलकर जरूर हम CM साहब से बात करेंगे. हैदराबाद में भी आपके लिए थोड़ा जमीन देने के लिए पूरा हम मदद करेंगे. सो अभी नेशनल प्रेसिडेंट है यहाँ पर, थोड़ा मैं भी लाइक टू, आप भी तेलंगाना का मंत्री है बोल के आप मेरे ये मीटिंग का फायदा उठाने के लिए कोशिश करें. अब मैं भी आपसे थोड़ा फायदा उठाना चाहता हूँ. अरे 2 प्रेसिडेंट है, इनकमिंग एंड आउटगोइंग, आने वाले भी है, प्रेजेंट प्रेसिडेंट भी हैं. आप यहाँ पर मेरा रहने का फायदा आप उठाए, आपका रहने का मैं भी थोड़ा फायदा उठाना चाहता हूँ. बट नॉट इन द इंटरेस्ट ऑफ पर्सनल और नॉट इन द इंटरेस्ट ऑफ द स्टेट, बट फॉर द इंटरेस्ट ऑफ द कंट्री एंड फॉर द हेल्थ डिपार्टमेंट एंड फॉर द हेल्थ सेक्टर. 2 बात मैं आपके मन में लाना चाहता हूँ. इनफैक्ट आई एम ऑल्सो ट्राइंग in our national conference and in our ministers meeting, when we meet our union minister, I also started raising in the meetings in the various forums. So आप भी इसको मन में रखना चाहिए. देखिए, there are 2-3 issues. One is, अभी मेडिकल काउंसिल गया, NMC आ गया, नाम तो बदल गए, जॉब तो सेम ही है. अब NMC का ऐसा हाल है, मैं 2 बात आपको बोलना चाहता हूं, आप भी मन में रखिए. इनफैक्ट आई एम फेसिंग इन द स्टेट 2-3 इश्यूज. दिस मस्ट बी द प्रॉब्लम ऑफ एवरी स्टेट इन द कंट्री. अब NMC का 2-3 इश्यूज. एक हुआ तेलंगाना में, पूरा एडमिशन होने के बाद 3 मेडिकल कॉलेज का वो जो परमिशन दिए हैं उसको कैंसिल कर चुके हैं, एक्रीडेशन कैंसिल करें. अब बच्चों का हाल क्या होना चाहिए? बोथ ग्रेजुएट्स एंड पोस्ट ग्रेजुएट्स, बच्चों का एडमिशन होने से पहले आप परमिशन मत दो. परमिशन देते हैं NMC, कैंसिल करते हैं NMC. अब परमिशन देने के बाद हजारों बच्चे आके मेरे घर के सामने बैठते हैं, मिनिस्टर साहब कुछ करो. पावर्स है NMC के पास, बच्चे बैठते हैं मेरे घर के सामने, जितने भी चिट्ठी लिखो वो कुछ करता नहीं. आज भी हमारे पास 3 कॉलेज कैंसिल करें. आज भी एक महावीर मेडिकल कॉलेज में जो PG एडमिशन लिए, आज भी NMC ने कुछ डिसीजन नहीं लिया. आज भी हवा में है बच्चे, ना वो कॉलेज को परमिशन है, ना वो बच्चों को दूसरा कॉलेज में एडमिशन मिला है. सो दिस इज कंप्लीटली एक NMC का पूरी तरीके से एक डिसीजन ऐसा ले रहे हैं, कोई उसमें देख के करना ना. Before giving the accreditation, before giving the permission, you should have been stopped. आप परमिशन देते हैं, एडमिशन हो जाएगा. अब एडमिशन होने के बाद रोकने से बहुत सारे प्रॉब्लम हो रहा. MNR में ऐसे ही करे, महावीर में करे, और एक भी रंगारेड्डी जिले में और एक मेडिकल कॉलेज को भी ऐसे ही करने थे. सो TRR, you are right. So 3 colleges I face this problem. So we should fight. We should sit with NMC. We should tell them, if at all you want to stop, you stop while giving the permission, but don't do it after admissions. This is issue number 1. आप लोग भी बात करना चाहिए वेरियस फोरम्स में. एंड दूसरा इशू, देखो भाई NMC है, NMC शुड बी इक्वल फॉर एवरीवन. एम्स को एक तरीका का प्रोसीजर है, स्टेट गवर्नमेंट को एक तरीका का प्रोसीजर है, प्राइवेट मेडिकल कॉलेजेस को और एक तरीका का प्रोसीजर है. ये क्या का प्रोसीजर है? देखो, तेलंगाना में एक एम्स है, बीबी नगर में. There is an institute, All India Institute of Medical Sciences. मैं आउट ऑफ माई एकेडमिक इंटरेस्ट मैं एक बार गया, 6 महीने पहले मैं वहां गया था. एम्स में जाके देखे तो 4th year students are studying. 4th year students are studying. There is no blood bank. There is no operation theater. There is no labor room. Nothing is there. Even they have given permission for PG. पीजी को भी एडमिशन लेना शुरू करे, 4th ईयर स्टूडेंट्स हैं, ये ऐसा कैसे परमिशन मिल सकता है? एम्स को परमिशन का जरूरत नहीं है क्या? वो बच्चे फिर कल के दिन बाहर आके क्या करना चाहिए? दे आर स्टडिंग 4th ईयर, दे स्टार्टेड टेकिंग पीजी एडमिशंस, वहां पर कोई ब्लड बैंक नहीं है, लेबर रूम नहीं है, कोई ऑपरेशन थिएटर नहीं है, कोई एक प्रोसीजर हो रहा नहीं। जब मैं वहां गया, बच्चे पूरे मेरे पास आ गए, साहब कम से कम आपका स्टेट गवर्नमेंट हॉस्पिटल में तो हमें परमिशन दो, हम वहां तो भी लेके जरा प्रैक्टिकल्स देखते हैं, हम वहां तो जाके कोई सीखते हैं सर, या तो कोई हमें सुनने वाला नहीं है। देन आई गिव परमिशन इन द डिस्ट्रिक्ट हॉस्पिटल भुवनगिरी फॉर द प्रोसीजर्स एंड प्रैक्टिकल्स। सो दिस इज द कंप्लीटली, अब एक तरफ बोलते हैं वन नेशन वन पॉलिसी, वन टैक्स पॉलिसी, वन काइंड ऑफ पॉलिसी, ये मेडिकल कॉलेजेस परमिशन में 2 पॉलिसी कैसे हो सकते हैं? फॉर एग्जाम्पल, आवर चीफ मिनिस्टर wants to start a medical college for each and every district as told by Dr. our Vinod Kumar Garu. So when Telangana was formed, there were only 5 medical colleges in the state of Telangana, in government sector. In fact, that's why we fought for Telangana. Why we used to fought for Telangana is, before independence, we used to have 2 medical colleges, that is Usmania and Gandhi. Usmania was brought by Nizam and Gandhi Hospital was built by British government. Those 2 medical colleges are before independence. And the third, in fact, this Kakatiya Medical College, Warangal, that was started by farmers, later on government took over that. So in the combined state of Andhra Pradesh, Telangana was a separate state. We merged into AP, Andhra, and it became Andhra Pradesh. After merging into Andhra Pradesh, we got only 3 medical colleges, including KMC Warangal. One is Nizamabad and the other is Adilabad. So that means technically, truly speaking, are only 2. One is Nizamabad and Adilabad. In 70 years of combined Andhra Pradesh after independence, this region got only 2 medical colleges. One is Nizamabad and the other is Adilabad. Medical college is not just education. No, medical college is, there are 3 aspects. One is education and second is the health and third is some development in that area. So we used to fight. So kabhi hua nahi. Whereas in the other part of the state, they used to have a lot of Visakhapatnam, one Vijayawada, one Guntur, one Karnool, one Anantapur, one. They used to start many medical colleges. That's why for the disparity itself, we used to fight. We want a separate statehood, then only we'll get benefit. In fact, we got separate state and the fruit started giving. So we started. Hello. When the state was formed, we have only 5 new medical colleges. 5 medical colleges was there. 5 medical colleges, our seats were 850. Today, after 8 years, 8th year is running. After 8 years, today we have 17 government new medical colleges. 17 new government medical colleges, and our seats are 2,790. 800 to we have gone up to 2,790. So why I was trying to mention, this academic year we are starting 8 new medical colleges. 12, today is 12th and 13th. So day after tomorrow, 15th. Day after tomorrow, we are starting new 8 government medical colleges. So day after tomorrow, classes are going to start. So in this contest, I would like to mention one thing. So this year we applied for 8 government medical colleges, each 150 seats. So NMC came, they made an inspections, they raised certain queries, we addressed all the queries. Finally, we got 7 medical colleges, we got permission. For 1 medical college, Manchirial, they rejected. NMC has rejected. Then I went to appeal to the ministry. I checked up why NMC has rejected my Manchirial Medical College. We have posted professors, enough staff is there, we built the classrooms, we have a hospital of 330 bedded hospital for the first year, which is required. So hospital is there, professors were posted, teaching classrooms were made, and all the equipment and instruments as provided, everything is ready. But NMC has rejected. I checked up why they have rejected. The reason they say, the population of the district is less than 10 lakhs. I don't understand. Why? You are not giving a single rupee. What NMC wants? You want the teaching staff, you want the equipment, you want the hospital, you want certain standards which I have already provided. But the reason they show the population is less than 10 lakhs, that's why I rejected. I didn't understand. So the policies are not clear, not correct. In fact, you should welcome. NMC should encourage more and more government medical institutions to come. But whereas they have rejected. Then I appealed, I went to ministry, we pursued like anything. We have shown the building, we have shown the equipment. And I asked the district collector to send a report saying that this is a tribal area, most Singer inequalities are there, labor are there. Of course, 9,10,000 is the present population, this is the census of 2011. But today it crossed 11 lakhs. The census which you are seeing is 2011, but we are in the year 2022. Now the population is more than 11 lakhs. I made some justification and I made lot of representations. Finally, I got permission for 100. They cut 50 and they gave permission for 100 seats. So what is the reason? Why? So the National IMA Forum, I request to prevail upon and discuss in the forums. You discuss with the ministries, you discuss with the NMC. Why? What is the... आप कुछ बोलना है?
सर आपसे आग्रह है, आपके जिस तरह से आप हैं, हमारे मंसू भाई भी so nice and gentleman, as I've heard, I have seen many times. So आपका अपॉइंटमेंट मंसू भाई से हम करवाते हैं और राजेश भूषण जी सेक्रेटरी हेल्थ. This type of partiality should not be done, number one. I am a member of NMC. I was a member of Medical Council of India. This time I am a member of National Medical Commission also. But NMC is not working properly. Work is not satisfactory. So, मंसूब भाई से हम बात करेंगे आपके लिए और आपसे बात उनके ऑफिस से हम बात करवाएंगे और हम टाइम आप अपॉइंटमेंट करवाएंगे और अपॉइंटमेंट करवा करके जो चेयरमैन एनएमसी है उससे बात करवाएंगे. गवर्नमेंट मेडिकल कॉलेज में कोई ऐसा हार्ड एंड फास्ट रूल नहीं होना चाहिए. गवर्नमेंट मेडिकल कॉलेज आप खोल रहे हैं, ये बहुत बड़ी बात है. गवर्नमेंट मेडिकल कॉलेज फॉर द पुअर्स, फॉर द जनहित के लिए आपने काम किया, कर रहे हैं, यह बहुत बड़ी बात है. हम सर इसके लिए करेंगे कोशिश और आपको बुलाएंगे सर, प्लीज.
प्रेसिडेंट साहब बैठिए. ये गवर्नमेंट मेडिकल कॉलेज लाने के लिए सरकार को 500 करोड़ रुपए खर्च करना पड़ता. हम राज्य से 500 करोड़ रुपए खर्च करके दवाखाना लगाएंगे, प्रोफेसर्स को सैलरी देंगे बोले तो आप परमिशन देने के लिए इतना कैसा डाल सकते हैं? एंड अदर हैंड, फॉर एम्स यू डोंट इवन हैव ए लेबर रूम वेयर यू आर रनिंग ए मेडिकल कॉलेज. ये ऐसा कैसा हो सकता है? कोई ब्लड बैंक नहीं है, थिएटर नहीं है, आप पीजी एडमिशन देते हैं. दूसरा तरफ मेरे पास सब कुछ है, आप बोलते हैं योर पॉपुलेशन इज लेस देन 10 lakhs. व्हाट इज दिस? आप बोलते हैं वन नेशन वन पॉलिसी. ऐसे दो पॉलिसी, तीन पॉलिसी कैसे रह सकते हैं? गवर्नमेंट खुद 500 करोड़ रुपए खर्च करके हमारा जनता के लिए इन द इंटरेस्ट ऑफ द स्टेट, इन द इंटरेस्ट ऑफ स्टूडेंट, या क्या हो रहा? परसों बहुत बच्चे जाके यूक्रेन में परेशान हो गए. यहां से इतने बच्चे यूक्रेन, चाइना, फिलीपींस जाके क्यों एमबीबीएस पढ़ रहे? यहां पर सीट नहीं है, गवर्नमेंट इज नॉट एबल टू प्रोवाइड. देन बच्चे जाके वहां चाइना लैंग्वेज पढ़ के, वहां रशियन लैंग्वेज सीख के वहां पर वो एमबीबीएस पढ़ रहे, फिर वापस आके फिर 1 साल 2 साल यहाँ पढ़ना पड़ रहे हैं. सो आप फिलीपीन जाने का, चाइना जाने का, यूक्रेन जाने का जरूरत नहीं है. हमें खुद यहाँ कॉलेज खोलेंगे, हमें खुद यहाँ पर सीट्स बढ़ाएंगे बोल के हम एक तरफ ट्राई कर रहे, तो दूसरा तरफ हमारा को ये लोग बहुत सताते जा रहे हैं एनएमसी वाले. आई डोंट अंडरस्टैंड. यही स्टेट में एम्स स्कूल में तो ऐसा है, हम सब कुछ रखे तो हमारा को पॉपुलेशन का नाम देके सता रहे हैं लोग. सो यू प्लीज ट्राई टू अंडरस्टैंड. ऐसे इश्यूज आप भी उठाना चाहिए, हम भी जरूर उठाएंगे. मैं सेक्रेटरी साहब से बात करके, मिनिस्टर साहब से बात करने के बाद 50 काट के 100 को दिए मेरे को. एक 50 सीट तो गया, अब क्या करना है सर? मैं तो 100 तो ले लिया कम से कम. अब अगले साल मैं 9 कॉलेज शुरू करने वाला है. करीमनगर के लिए ट्राई कर रहा हूँ. नेक्स्ट ईयर करीमनगर विल हैव ए गवर्नमेंट मेडिकल कॉलेज. करीमनगर, खम्मम, कामारेड्डी, सिरसिल्ला, like another Nirmal. We are coming up with 9 new medical colleges for next academic year. So like 33 జిల్లాల్లో 33 ప్రభుత్వ మెడికల్ కాలేజీలు వచ్చే 2 సంవత్సరాల్లో తీసుకురాబోతా ఉన్నాం. తెలంగాణ వచ్చినప్పుడు 2950 ఎంబీబీఎస్ సీట్లుంటే ఈరోజు 6615 ఎంబీబీఎస్ సీట్లు మన రాష్ట్రంలో ఉన్నాయి. తెలంగాణ వస్తే ఏమొచ్చిందంటే 6615 ఎంబీబీఎస్ సీట్లు వచ్చినాయి. తెలంగాణ వస్తే ఇప్పుడు 8 సంవత్సరాల్లో మనము 12 కొత్త మెడికల్ కాలేజీలు యాడ్ చేయగలిగినాం. నిజంగా రాష్ట్రమే రాకపోతే 12 మెడికల్ కాలేజీలు వచ్చేదా? అప్పుడు మీరు ఎంత కష్టపడితే డాక్టర్లు అయినరో, సీట్లు వచ్చేది కాదు. సో ఈరోజు అన్ని సీట్లు మనం స్టార్ట్ చేసినాం. పిల్లలు ఉక్రెయిన్లు, చైనాలు, రష్యాలు పోవాల్సిన అవసరం లేదని. సో మిత్రులతో నా మనవి ఏంటంటే, మన గౌరవ ముఖ్యమంత్రి గారు ఈరోజు అన్ని జిల్లాల్లో తెచ్చాం. మీరు కూడా ఇలా ఆలోచించాల్సింది ఏంటంటే, మేము ఎస్ఆర్ స్టూడెంట్స్ను ఐ థింక్ మీరు అప్రిషియేట్ చేస్తారని అనుకుంటా. మన పీజీ పూర్తయిన తర్వాత 1 ఇయర్ కంపల్సరీ ఎస్ఆర్షిప్ ఇచ్చింది గవర్నమెంట్, ఎన్ఎంసీ ఇచ్చింది. ఈసారి ఒక్కరిని కూడా హైదరాబాద్లో ఇవ్వకుండా ఆల్ ద 850 ఎస్ఆర్స్ను మొత్తం తెలంగాణలో వేయడం జరిగింది. ఐ టుక్ ఎ స్ట్రాంగ్ పొలిటికల్ డెసిషన్ నాట్ టు గివ్ సింగిల్ పోస్ట్ ఇన్ హైదరాబాద్. అదర్వైజ్ అందరూ అక్కడే ఉంటారు, ఎవరు బోరు. మంచిర్యాలకు 30 మందిని ఇచ్చినా, జగిత్యాలకు 30 మందిని ఇచ్చినా, రామగుండంలో 30 మందిని ఇచ్చినా, కరీంనగర్లో 30 మందిని ఇచ్చినా, అట్లా నిర్మల్లో, సిరిసిల్లలో ప్రతి చోట కూడా 25-30 మంది ఎస్ఆర్స్ పోస్ట్ గ్రాడ్యుయేట్ డాక్టర్స్ని ఇవ్వడం ద్వారా పట్టణ ప్రాంతాల్లో, గ్రామీణ ప్రాంతాల్లో కూడా వైద్యాన్ని అందుబాటులోకి తెచ్చే ప్రయత్నం చేసినాం. ఒకప్పుడు ఆసిఫాబాద్లో ఒక్క డాక్టర్ ఉండేవాడు కాదు. నాకు గైనిక్ డాక్టర్ కావాలంటే ఆసిఫాబాద్లో దొరకరు, నాకు భద్రాచలంలో నాకు దొరకరు. ఈరోజు ఎస్ఆర్లందరినీ కంపల్సరీ వెళ్లాల్సిందే అంటే టుడే ఐ హ్యావ్ డాక్టర్స్ ఇన్ భద్రాచలం, టుడే ఐ హ్యావ్ డాక్టర్స్ ఇన్ ఆసిఫాబాద్, ఇన్ ద రిమోటెస్ట్ కార్నర్ ఆల్సో. అన్ని చోట్ల కూడా ఇవాళ డాక్టర్ని ఇవ్వగలిగినాం మనం. సో ఇట్లా మేము కొంత ఇబ్బంది అవుతుంది. అఫ్ కోర్స్ పొలిటికల్గా వీ ఫేస్ లాట్ ఆఫ్ ప్రెషర్స్, వీ గెట్ సమ్ బ్యాడ్ నేమ్, బట్ ఇన్ ద ఇంట్రెస్ట్ ఆఫ్ పబ్లిక్, ఇన్ ద ఇంట్రెస్ట్ ఆఫ్ పీపుల్ మేము గట్టిగా ఒక నిర్ణయం తీసుకొని ఇవాళ ఎస్ఆర్స్ అందరినీ కూడా జిల్లాల్లో పోస్ట్ చేసినాం. ఈ రకంగా అనేక విషయాల్లో. अच्छा साहब, एक और एक बात भी बोलना है. एक साहब यूपी से हैं, दूसरे बिहार से हैं, और एक भी मैं फ़ायदा उठाना चाहता हूँ. మా డాక్టర్లు కరీంనగర్ డాక్టర్లు కూడా ఉన్నారు. సో ये और एक मुद्दा है. मैं बहुत लड़ रहा हूँ, जब से हेल्थ मिनिस्टर बन रहा हूँ मेरा डॉक्टर्स थोड़ा गुस्सा भी करते मेरे ऊपर, फिर भी मैं तो लड़ते जा रहा हूँ. और वो मैडम है यहाँ पर पीछे निज़ामाबाद से. सो हम लड़ते रहते हैं. द अदर इशू इज़ सी सेक्शन रेट. देखो डॉक्टर्स, I praise, I have got a lot of affection and regards. అందుకే ఇవాళ आज बहुत सारे लोग रहते हैं सोसाइटी में, जो डिग्निटी आपको मिलता है सोसाइटी में, द रेस्पेक्ट यू गेट नोबडी एल्स गेट्स, दैट्स ओनली डॉक्टर गेट्स. देखिए, आप करोड़पति भी हो सकते हैं, या एक ब्यूरोक्रेट भी हो सकते हैं, या स्टेट लेवल में कोई बड़ा ऑफिसर भी हो सकते हैं, बट द सोशल रेस्पेक्ट एंजॉयड बाय द डॉक्टर नो अदर विल गेट. वो तो आपको मिल रहा है ना. द सोशल रेस्पेक्ट किसी को और मिलता है? వైద్యో నారాయణ హరి. ఇవాళ తల్లిదండ్రులు, తల్లి మనకు జన్మనిస్తే పునర్జన్మనిచ్చేది డాక్టర్. రీబర్త్ ఈజ్ గిवन बाय अ डॉक्टर. सो इतना रेस्पेक्ट आपको मिल रहा है. सो इसको आप रखना चाहिए, इसको बढ़ाना चाहिए. Everywhere, in every society, good is there, bad is there. We have to appreciate good, we have to control the bad. It's not that I'm saying every minister is good, every politician is good, every government is good, every officer is good. हमारा पॉलिटिशियन में भी कोई गुड होगा, कोई बैड होगा. हमारा मिनिस्टर्स में भी कोई गुड होगा, कोई बैड होगा. ऐसे ही डॉक्टर्स में भी होगा. सो वेर एवर IMA का ऐसा रोल होना चाहिए. IMA सिर्फ डॉक्टर्स के लिए लड़ना नहीं, डॉक्टर्स में भी कोई बैड है तो उनको सेटरेट करना चाहिए. क्यों सेटरेट करना? टुडे यू हैव द हाईएस्ट डिग्निटी among all professions a doctor is enjoying today. You have to keep it up, you have to protect that also. वो जो डिग्निटी आज मिल रहा है, वो डिग्निटी को आप आगे लेके जाने का जिम्मेदारी भी IMA का होता है. होता नहीं होता? रखना चाहिए. आप एक तरफ राज्य से भी लड़ो, गवर्नमेंट से पूछो. आप बोल रहे थे डॉक्टर्स के, नहीं बेटे साहब, डॉक्टर्स के आप बोल रहे हैं डॉक्टर्स के ऊपर अटैक हो रहे हैं. I seriously condemn. The government seriously condemn. We will take strict and stringent action against whoever do attacks on nursing homes or attacks on doctors. We arrest them, we'll put them in jail, we see that it is not repeated, we'll tell political parties, we'll tell the public representatives, we strictly try to control that. But at the same time, agar say doctor ka bhi galti hai, that medical council will take care. We'll refer it to medical council will examine. If at all any mistake is there, a technical committee will take a decision, accordingly government will take the necessary action. But not the individuals, but not the people, but not the political parties or the activists. We will never support that. We'll strictly take action. उसके तरफ से हम पूरे आपको मैं सपोर्ट करता हूं. बट एक मेरा अपील है, हमारा नॉर्थ तेलंगाना पर्टिकुलरली करीमनगर, वरंगल, निजामाबाद एंड आदिलाबाद के तरफ, यहां पर जो सी सेक्शन रेट हैं दुनिया में नहीं ग्लोबली ज्यादा है, हाईएस्ट इन द ग्लोब. ये WHO भी हमारा को आइडेंटिफाई करके बार बार बोलते आ रहा है. WHO भी बोल रहा है. अभी मैं नेट उठा के आप दोनों हैं बोल के आपका राज्य का भी निकाला. इंडिया में सी सेक्शन रेट कौन सा स्टेट में कैसा है, तेलंगाना में कैसा है बोल के अभी निकाला मैं. देखिए तेलंगाना का सी सेक्शन रेट है 60.7. हमारा प्रेसिडेंट साहब बिहार में है 9.7 एंड द कमिंग प्रेसिडेंट यूपी में है 13.7. एंड नेबरिंग स्टेट्स, तेलंगाना का जो नेबरिंग स्टेट्स हैं, कर्नाटका 31.5, महाराष्ट्र 25.4, आंध्र प्रदेश 40. सो नेबरिंग स्टेट से भी के ज्यादा है 60.2. आंध्र प्रदेश इज 40, कर्नाटका 31, महाराष्ट्र 25. ऑफ कोर्स बिहार यूपी में सुविधा नहीं रहने से भी नॉर्मल ज्यादा हो रहा होगा. यहाँ पर हमारा ज्यादा नर्सिंग होम रहने से, ज्यादा डॉक्टर अवेलेबिलिटी होने से ज्यादा हो रहा है. यूपी बिहार में तो नर्सिंग होम कम रहने से, डॉक्टर्स कम रहने से भी कुछ कम हो रहा है कि क्या है कि मुझे नहीं मालूम. आई एम नॉट श्योर, बट यू शुड करेक्ट मी. बट इवन इन द स्टेट ऑफ तेलंगाना स्टेट में आउट ऑफ द 60.7 गवर्नमेंट सेक्टर में देखे तो सी सेक्शन रेट इज 44, प्राइवेट सेक्टर में देखे तो 81. एंड थोड़े हॉस्पिटल्स है हमारा पास 100% सी सेक्शन होता है वहां पर. जो नर्सिंग होम है BN राव सर, जो नर्सिंग होम है, एंड आई रिव्यू एवरी मंथ आई रिव्यू एवरी डिपार्टमेंट. मेरा NHM क्या हो रहा है, प्राइमरी हेल्थ क्या हो रहा है, टर्शरी केयर में क्या हो रहा है, टीचिंग हॉस्पिटल में. देयर आर फिक्स्ड डेट होते हैं. आई टेक जूम कॉन्फ्रेंस ऑफ ईच एंड एवरी डिस्ट्रिक्ट एंड एवरी हॉस्पिटल. हर महीने मेरा रिव्यू होते हैं. सो थोड़े हॉस्पिटल्स है आज के दिन, एवरी डिस्ट्रिक्ट 15, 10, 8, करीमनगर का कल देखा था मैं, 8 दवाखाने 100% सी सेक्शन होते हैं वहां पर. 100%, एक भी नॉर्मल नहीं होता. विल यू IMA विल अग्री टू दिस? विल IMA एनकरेज दिस? वेदर IMA हैज एनी रेस्पॉन्सिबिलिटी? फिर ये भी आप डिस्कस करना चाहिए. सो माई सिंसियर अपील, आई एम नॉट सेइंग दैट भाई कर्नाटका में 22 है, 24 है, आप भी 24 करो बोल के नहीं बोल रहा हूं. आई एम नॉट ए डॉक्टर. I am not supposed to say to do C-section or to do normal. It is doctor to decide. You have to write the, before doing C-section, you have to write the indication, and you should take a decision. And it should be checked by a MHO or any other officer as to scrutiny it. But क्या होता है अगर से हम कुछ डिसीजन ले, मंत्री साहब अच्छा नहीं है, आप कुछ डिसीजन है, गवर्नमेंट अच्छा नहीं है, फिर ये किसके लिए अच्छा है? जरा मैं IMA से भी रिक्वेस्ट करता हूं, प्लीज ट्राई टू रिड्यूस. क्या बार बार WHO, यूनियन गवर्नमेंट से हमारे को अलर्ट आते हैं, आपके राज्य में ज्यादा, आपके पास थोड़े जिले में ज्यादा से ज्यादा हो रहा है, थोड़ा इसको कम करो बोल के हर मीटिंग में हमारे को बोलते रहते हैं. सो एज ए मिनिस्टर, एज ए स्टेट, आई सपोज टू आंसर देम. सो इसको मैं स्लोली आई स्टार्टेड. मैं गवर्नमेंट में क्या कर दिया, ये क्या हो गया, आयुष्मान भारत है ना एक स्कीम. आयुष्मान भारत में ऐसा है, आप सी सेक्शन करें तो 11,000 रुपए दे रहे हैं. अब मैं तेलंगाना में क्या कर दिया, सी सेक्शन करे तो 0 कर दिया, नॉर्मल डिलीवरी करे तो 3,000 देना शुरू कर दिया मैं. बट दिस आई एम गिविंग इट टू ओनली गवर्नमेंट. प्राइवेट में तो नहीं दे सकता हूं मैं. गवर्नमेंट में डिसइंसेंटिवाइज कर दिया। मैं आरोग्यश्री में जो सी सेक्शन में 11,000 दे रहे हैं उसको कंप्लीटली जीरो कर दे के सी सेक्शन नहीं करके नॉर्मल कर दिए तो 3,000 देना शुरू करा। हमारा सीएम साहब ये भी करते हैं, गवर्नमेंट इंस्टीट्यूशन में डिलीवरी करे तो यहाँ पर वी गिव देम KCR किट एंड वी गिव देम 12,000 रुपीज। पहले ANC चेकअप में आए तो 3,000, गवर्नमेंट इंस्टीट्यूशन में डिलीवरी हो गए तो 4,000, देन आप बच्चों को वैक्सीनेशन कराए तो बाकी पैसे देते हैं। सो टू एनकरेज इंस्टीट्यूशनल डिलीवरी, टू एनकरेज वैक्सीनेशन एंड टू गिव गुड फूड ड्यूरिंग प्रेगनेंसी, वी गिव देम सम मनी। Delivery is used to have 30%, but today it is 62%. Telangana mein government institutional deliveries is 62%. There are some districts, yesterday I was taking a review, Medak district 78% in government institutional delivery, and Sangareddy 82% government institutional deliveries. So इतना अच्छा हम compete करते करते बढ़ते जा रहे हैं। सर ठीक है, उसमें बहुत सारे issues हैं। So इस संदर्भंगा सो माई रिक्वेस्ट विथ IMAs, आप थोड़ा सोशल रिस्पॉन्सिबिलिटी भी लेना है। डॉक्टर्स का, नर्सिंग होम्स का, कैसा भी आपका जिम्मेदारी बनता है, उनका इंटरेस्ट प्रोटेक्ट करना है। हम भी प्रोटेक्ट करेंगे इन द इंटरेस्ट ऑफ। अननेसेसरी स्कैनिंग करते हैं, अननेसेसरीली थोड़े टेस्ट करवाते हैं, ज्यादा जहां पर सी सेक्शन हो रहा है उसका कंट्रोल करने में भी आप भी हमारा साथ दीजिए, हम भी आपका पूरा पूरा साथ दे देंगे। సో మిత్రులారా, సరే IMAకు మేము అన్ని రకాలుగా తప్పకుండా సహాయ సహకారాలు అందిస్తాం। మరి మా గౌరవ మంత్రులకు కూడా చెప్పి మీకు స్థలాలు ఇప్పించడానికి కానీ లోకల్గా వాటిని కట్టడి చేసే విషయంలో కూడా తప్పకుండా మేము సహకారం అందిస్తాం। అండ్ అదేవిధంగా ఐ ఆల్సో వెల్కమ్ మీరందరూ కూడా ఎవరైనా ప్రొఫెషన్లో ఇప్పుడు మేము ఇంకా కొత్తగా 9 మెడికల్ కాలేజ్ కూడా కావాల్సింది ఉంది। మీరు గవర్నమెంట్ సర్వీస్లో కూడా రండి, గవర్నమెంట్ సర్వీస్లో కూడా జాయిన్ కండి। మేము అవసరమైతే ఏజ్ రిలాక్సేషన్ చేసి కూడా వాక్-ఇన్ ఇంటర్వ్యూస్ ద్వారా కూడా మీకు అసిస్టెంట్ అంటే మేము బాగా పోటీ ఇస్తాం। మేము గవర్నమెంట్ నుంచి నౌ వీఆర్ ట్రయింగ్ టు కాంపిటీట్ విత్ द कॉर्पोरेट्स एंड प्राइवेट हॉस्पिटल्स। आजकल हमारे पास गवर्नमेंट हॉस्पिटल्स में हम पूरे आरोग्यश्री में 10 लाख रुपए देके किडनी ट्रांसप्लांट्स, लिवर ट्रांसप्लांट्स, हार्ट, अब गवर्नमेंट मेडिकल कॉलेजेस में पूरा सपोर्ट देके हम ट्रांसप्लांट भी करना शुरू कर दिए हैं तेलंगाना। ఐ వెల్కమ్ మీరందరూ కూడా ప్రభుత్వ సర్వీస్లో కూడా చేరండి। కలిసి పనిచేద్దాం। చాలా విషయాలు చెప్పాలనుకున్నా కానీ బహుశా మీకేమో టైం అయిపోయింది, ఇప్పటికే ఐ టుక్ 40-50 చెప్పమంటారా? ఒక 2-3 విషయాలు జస్ట్ టు షేర్। హెల్త్లో చెప్పాలంటే పెద్ద సబ్జెక్ట్, కానీ ఇంకా నేను హెల్త్లోకి పోకుండా కొంచెం అవుట్ ఆఫ్ ద బాక్స్ పోతా। ఒక 10 నిమిషాలు మీరు పర్మిషన్ ఇస్తే, మీకు ఓపుకుంటే। సో ఒకటేమో, సరే డిన్నర్ ఉందా? కాక్టైల్ డిన్నరా, ఉత్త డిన్నరా? బిఎన్ రావు సాబ్ ఏమిచ్చిండు? నేను వెళ్ళాలి, కామారెడ్డి పోవాలి ఇప్పుడు ఇంకా। సో ఇంకా 2-3 విషయాలు మీ ముందు పెట్టాలనుకుంటున్నాను. అఫ్కోర్స్ సరే వైద్య విద్యలో మంచి మార్పు వస్తుంది. మేము కూడా ఇంకా ఇప్పుడు పల్లె దవాఖానా అనే కొత్త కాన్సెప్ట్ కూడా తెచ్చాం. పల్లె దవాఖానా ఇప్పటి వరకు మనకు 3 టైర్ సిస్టమ్ ఉండేది. ప్రైమరీ హెల్త్ సెంటర్, దెన్ సెకండరీ వచ్చేసి ఏరియా హాస్పిటల్స్, డిస్ట్రిక్ట్ హాస్పిటల్స్, థర్డ్ వీ యూస్ టు హ్యావ్ టీచింగ్ హాస్పిటల్స్. ఇప్పుడు దాన్ని 5 లేయర్గా మార్చుకున్నాం. ప్రైమరీ హెల్త్ సెంటర్ కింద ఇంకొకటి పల్లె దవాఖానా, బస్తీ దవాఖానా అనే ఒక కాన్సెప్ట్ తెచ్చాం. వీ స్టార్టెడ్ ఇన్ హైదరాబాద్. హైదరాబాద్లో ఒక 350 బస్తీ దవాఖానాలు పెట్టినాక వీ గాట్ బస్తీ దవాఖానా గొప్పతనం ఏంటంటే ఇట్ ఈస్ నాట్ ఏ డాక్టర్. అన్ని టెస్టులు కూడా ఫ్రీగా చేస్తాం త్రూ టీ డయాగ్నోస్టిక్స్. 56 రకాల పరీక్షలు ఉచితంగా చేసి వాళ్ళకు మొబైల్ ఫోన్కు, డాక్టర్ మొబైల్కు, పేషెంట్ మొబైల్కు వితిన్ 24 అవర్స్ వీ స్టార్టెడ్ సెండింగ్ ద మెసేజ్. దాంతో మాకు గొప్ప అసలు ఐ వాజ్ షాక్ టు సీ గాంధీ ఓపీ హ్యాస్ కమ్ డౌన్ లైక్ ఎనీథింగ్. మన గాంధీ హాస్పిటల్ ఓపీ సంవత్సరానికి 12 లక్షలు ఉండేది. ఇట్ హ్యాస్ కమ్ డౌన్ టు 5 lakhs. ఉస్మానియా ఓపీ హ్యాస్ కమ్ డౌన్ బై 75%. ఫీవర్ హాస్పిటల్ ఓపీ హ్యాస్ కమ్ డౌన్ బై 70%. అంటే ఏమైంది? ప్రైమరీ కేర్ ఈజ్ టేకెన్ కేర్ బై దిస్ బస్తీ దవాఖానాస్. సో వాళ్ళు పోయి గాంధీ హాస్పిటల్ పొద్దున్నే లైన్ కట్టకుండా వాళ్ళ బస్తీలోనే దగ్గు, జలుబు, జ్వరం వచ్చింది, బయళ్ళు, వాంతులు అంటే ఇక్కడే టెస్ట్ అవుతుంది, ఇక్కడే డాక్టర్ చూస్తున్నాడు, ఇక్కడే మందులు ఇచ్చేస్తున్నాడు. సో దే ఆర్ హ్యాపీ. అక్కడ గాంధీ డాక్టర్ కూడా ఏమైంది? నౌ దే ఆర్ కాన్సన్ట్రేటింగ్ మోర్ ఆన్ టెర్షరీ కేర్, ఆన్ సీరియస్ కేసెస్. అక్కడ సర్జరీస్ పెరిగినాయి, ప్రొసీజర్స్ పెరిగినాయి. ఇట్లా అద్భుతమైనటువంటి ఫలితాలు బస్తీ దవాఖానాల్లో తెచ్చినాం. ఆ బస్తీ దవాఖానాల్లో వచ్చిన విజయంతో ఇప్పుడు పల్లె దవాఖానాలు కూడా స్టార్ట్ చేస్తున్నాం. నౌ దీస్ బస్తీ దవాఖానాస్ వీ హ్యావ్ ఎక్స్టెండెడ్ ఈవెన్ టు డిస్ట్రిక్ట్స్ లైక్ కరీంనగర్ కూడా ఇప్పుడు ఒక 5-6 బస్తీ దవాఖానాలు. లైక్ ఎవ్రీ మున్సిపాలిటీ వీఆర్ స్టార్టింగ్ బస్తీ దవాఖానాస్ అండ్ ఈవెన్ ఇన్ ద విలేజెస్ ఒక 2900 పల్లె దవాఖానాలు స్టార్ట్ చేస్తున్నాం. 2900 పల్లె దవాఖానాస్. ఇప్పటికే దెర్ ఆర్ 900 PHCs, అర్బన్ ప్రైమరీ హెల్త్ సెంటర్ అండ్ రూరల్. ఈ 900 విలేజెస్ వదిలిపెట్టి ఇంకో 2900 తీసుకున్నాం. దట్ మీన్స్ 2900 + 900 3800, 3800 గ్రామాల్లో డాక్టర్ అందుబాటులోకి రాబోతున్నాడు. సో MBBS దొరకనప్పుడు వీఆర్ టేకింగ్ ఆయుర్వేద, వీఆర్ టేకింగ్ ఆయుష్ డాక్టర్స్. సో అట్లా మేము ఎంకరేజ్ చేస్తూ ఈ పల్లె దవాఖానాల్లో, బస్తీ దవాఖానాల్లో పనిచేసే డాక్టర్లకు ఇంకో ఫెసిలిటీ ఇచ్చినాం. PG అడ్మిషన్స్లో విత్ శాలరీ 30% seats we have reserved in PG admissions to encourage to join these Pale Dawakhanas, to join rural area practice, to join the government service. We started giving 30% reservation in PG admissions. దాంతో చాలా మంది పిల్లలు జాయిన్ అవుతున్నారు. పల్లె దవాఖానాలు, బస్తీ దవాఖానాలు ఇంకొక లేయర్ కింద మేము స్టార్ట్ చేయడం వల్ల ఈ కొంత మీరు అన్నారు కదా మా వినోదన్న క్రాకరీ గురించి చెప్పినాడు. కర్రబట్టి కొట్టడం కంటే ఫెసిలిటీ తీసుకొస్తే అది ఆటోమేటిక్ మాయమైపోతుంది. When facility comes, automatically people will come there. Why they go to a non-qualified person? Definitely they will be, when a qualified person is available at government service at free of cost, why do he go to a non-qualified person and why should he pay? Here when you are getting a qualified person and a quality service at free of cost, then automatically they get eradicated. So adoka kotta prayatnam okati men chesta unnam. రెండవది మీ అందరు కూడా చూశారు, ఇప్పుడు మనకు నిమ్స్ ఒక MNJ తప్ప సూపర్ స్పెషాలిటీ గవర్నమెంట్ సెక్టార్లో లేదు. సో ఇప్పుడు మనం హైదరాబాద్లో ఒక 4 సూపర్ స్పెషాలిటీ, వరంగల్లో ఒక 2000 బెడెడ్ సూపర్ స్పెషాలిటీ హాస్పిటల్స్ కూడా గవర్నమెంట్ సెక్టార్లో దేబోతా ఉన్నాం. వరంగల్ వీఆర్ బిల్డింగ్ విత్ 1200 crores. హైదరాబాద్ వీఆర్ స్పెండింగ్ అనదర్ 4000 crores. నిమ్స్ ఆల్సో వీఆర్ యాడింగ్ అనదర్ 2000 beds ఇన్ నిమ్స్. నిమ్స్ ఇప్పుడు 1450 ఉన్నది. ఇప్పుడున్న 1450కి ఇంకో 2000 beds నిమ్స్లో కూడా యాడ్ చేసి అక్కడ కూడా ఒక సూపర్ స్పెషాలిటీ హాస్పిటల్ దేబోతా ఉన్నాం. సో ఇట్లా గవర్నమెంట్లో టెర్షరీ కేర్ని కూడా స్ట్రెంథెన్ చేస్తూ మన PG సీట్స్ తర్వాత సూపర్ స్పెషాలిటీ సీట్స్ కూడా స్టార్ట్ చేస్తున్నాం. ఇప్పుడు మన గవర్నమెంట్ వచ్చినాక PG సీట్స్ కూడా డబుల్ అయినాయి, సూపర్ స్పెషాలిటీ సీట్స్ కూడా డబుల్ అయినాయి. రాబోయే రోజుల్లో అక్కడ కూడా ఇంకా బాగా పెంచాలని, సూపర్ స్పెషాలిటీ సేవలు కూడా తేవాలనుకున్నాం. ప్రతి జిల్లాలో మెడికల్ కాలేజ్, ప్రతి జిల్లాలో నర్సింగ్ కాలేజ్, ఈవెన్ నర్సింగ్ కాలేజీలో మీ డాక్టర్లలో ఎట్లయితే స్పెషలైజేషన్ ఉందో నర్సింగ్లో కూడా వీఆర్ స్టార్టింగ్ స్పెషలైజ్డ్ నర్స్, ICU స్పెషలైజ్డ్ నర్స్, మన లేబర్ రూమ్ స్పెషలైజ్డ్ నర్స్, క్యాన్సర్లో స్పెషలైజ్డ్ నర్స్, కార్డియక్లో స్పెషలైజ్డ్ నర్స్. సో ఆ కోర్సును కూడా ఒక స్పెషలైజ్డ్ కోర్సెస్ తెస్తున్నాం. హెల్త్ యూనివర్సిటీ ఆఫ్ తెలంగాణ, we have taken a decision to bring specialized staff nurse courses so that they will be very acquainted with the subject. They will be very helpful to the doctor and to the theatres and to the patient. So we are thinking to start a specialized nursing course, specialized even technicians also. Not only nursing staff, in paramedical courses also, we started certain technician courses. Further also, new diseases are coming up, new kinds of courses are supposed to come. We are also thinking to start such courses. సో మిత్రులారా, ఇవి కాకుండా ఇంకా నేను ఒకటి అవుట్ ఆఫ్ ద బాక్స్ మీతో మాట్లాడాలనుకున్నది ఏంటంటే, మీరు సమాజంలో చాలా గౌరవమైనటువంటి స్థానంలో ఉన్నారు. ఐల్ టెల్ యూ, డెఫినెట్లీ ఐల్ టెల్ యూ. సో మీరందరూ కూడా కొంత గౌరవమైనటువంటి స్థానాల్లో ఉన్నారు. కొన్ని విషయాల్లో మీకు కూడా క్లారిటీ ఉండాలి. ఒక అబద్ధాన్ని 100 సార్లు చెప్తే నిజమైద్ది అన్నట్టు సమ్ టైమ్స్ వీ ఆల్సో క్యారీ అవే. అఫ్కోర్స్ అది మీరని కాదు, నేను ఎవరమైనా అంతే. కానీ కొన్ని విషయాలు ఏంటంటే మీకు తెలిసి ఉండాలి. యాజ్ ఐ గాట్ ఎన్ ఆపర్చునిటీ, ఒకసారి మీ దృష్టిలో కూడా పెట్టాలనేటువంటి ఒక ప్రయత్నం. చాలా విషయాలు ఉన్నాయి కానీ ఒక 2-3 పారామీటర్లు మీ దృష్టిలో పెట్టే ప్రయత్నం చేస్తాం. ఒకటి, నార్మల్గా ఏం చేస్తారు చాలామంది, ప్రభుత్వం ఎడ్యుకేషన్ మీద చాలా తక్కువ ఖర్చు పెడుతుందని, విద్యను నిర్లక్ష్యం చేస్తుందని కొంతమంది అంటూ ఉంటారు. అప్పుడప్పుడు ఆర్టికల్స్ వస్తూ ఉంటాయి. బట్ తెలియంది ఏంటంటే, వాళ్ళకి తెలియంది మీ దృష్టికి మేము తేవాల్సింది ఏంటంటే, ఎడ్యుకేషన్ మీన్స్ ద మనీ విచ్ వీఆర్ స్పెండింగ్ నాట్ ఓన్లీ బై ఎడ్యుకేషన్ డిపార్ట్మెంట్, దెర్ ఆర్ అదర్ ఫార్మ్స్ వేర్ వీఆర్ స్పెండింగ్. అది వాళ్ళు క్యాలిక్యులేట్ చేయట్లేదు. సపోజ్ మెడికల్ ఎడ్యుకేషన్, ఐ జస్ట్ టోల్డ్ యూ, ఇప్పుడే మీతో ఏమన్నాము, 5 మెడికల్ కాలేజీలను 17 మెడికల్ కాలేజీలు తీసుకుపోయినాం. ఒక్కొక్క మెడికల్ కాలేజ్ మీద వీఆర్ స్పెండింగ్ 500 crores. కానీ ఇది ఎడ్యుకేషన్ డిపార్ట్మెంట్ లెక్కలో కనబడదు. ఇది మెడికల్ అండ్ హెల్త్ డిపార్ట్మెంట్ నుంచి వైద్య విద్య మీద మేము ఖర్చు పెడతా ఉన్నాం. దిస్ ఈజ్ అగైన్ ఓన్లీ అన్ ఎడ్యుకేషన్, బట్ దే సీ ఓన్లీ ఎడ్యుకేషన్ డిపార్ట్మెంట్ అకౌంట్, వేర్ వీఆర్ స్పెండింగ్ మనీ త్రూ మెడికల్ అండ్ హెల్త్ డిపార్ట్మెంట్. లైక్ ఫారెస్ట్ యూనివర్సిటీ తెచ్చినాం మనం దేశంలో. ఫస్ట్ యూనివర్సిటీ ఇన్ ఫారెస్ట్. మనము ఫారెస్ట్ బిఎస్సి కోర్స్ తెచ్చి, ఫారెస్ట్లో పీజీ పోస్ట్ గ్రాడ్యుయేషన్ తెచ్చి, ఫారెస్ట్ డిపార్ట్మెంట్ ద్వారా కూడా తెలంగాణ ప్రభుత్వం ఒక యూనివర్సిటీ పెట్టింది. అగ్రికల్చర్ డిపార్ట్మెంట్ ద్వారా అగ్రికల్చర్ యూనివర్సిటీ, హార్టికల్చర్ యూనివర్సిటీ, మెనీ అగ్రికల్చర్ బిఎస్సి కాలేజెస్, మెనీ అగ్రికల్చర్ పాలిటెక్నిక్స్ we run. That money we spend through agriculture department. Like there is a veterinary department. Even through veterinary department, we have a veterinary university at Warangal. Through that veterinary university, ఎంతో మంది వెటనరీ డాక్టర్ చదివేటువంటి బీవీఎస్సీ కాలేజీలు రాష్ట్రంలో చాలా ఉన్నాయి. వెటనరీ పాలిటెక్నిక్ కాలేజీలు ఉన్నాయి. సో వెటనరీ ఎడ్యుకేషన్ మీద we spend money through animal husbandry department. Like residential schools, social welfare residential schools, minority welfare residential schools, tribal welfare, and also regular gurukulas. All together, రాష్ట్రం వచ్చినప్పుడు ఒక 350 గురుకులాలు ఉండే, ఈరోజు 900 గురుకులాలు పైగా ఉన్నాయి. తెలంగాణ రాష్ట్రం వచ్చినప్పుడు 1,24,000 మంది పిల్లలు ఈ గురుకుల పాఠశాలల్లో చదువుకునేవారు. ఈ గురుకులాలంటే మీకు తెలిసి ఉండాలి, మన రాష్ట్రంలో ఉండే మెనీ సీనియర్ బ్యూరోక్రాట్స్, ఐఏఎస్ ఐపీఎస్ ఆఫీసర్స్ ఎవరైతే ఉన్నారో, ద డీజీపీ మహేందర్ రెడ్డి, ఫైనాన్స్ సెక్రటరీ రామకృష్ణారావు అండ్ ఆయన నేను కూడా అక్కడే అంటున్నారు. ఆ గురుకులాల్లో చదువుకున్న వాళ్ళే ఈరోజు ఎంతోమంది బ్యూరోక్రాట్స్ ఉన్నారు. అంటే తెలంగాణ గురుకులాస్ ఆర్ మోడల్ ఫర్ ద కంట్రీ. వీ స్పెండ్ ఆల్మోస్ట్ 1 lakh on each and every student per annum. ఈరోజు రాష్ట్రం వచ్చినప్పుడు 1,24,000 మంది పిల్లలు గురుకులాల్లో చదివితే ఈరోజు 4,50,000 మంది పిల్లలను గురుకుల పాఠశాలలో చదివిస్తూ ఉన్నాం. రెసిడెన్షియల్ ఇంగ్లీష్ మీడియం ఫుల్ క్వాలిటీ ఎడ్యుకేషన్ ఇస్తున్నాం. 4.5 lakh students are studying. And this money we spend through SC, ST, BC minority departments, not by education departments. We spend around 3,300 crores on gurukulas. So the people doesn't know. They say only, they calculate that education department money and they say Telangana is spending only 5% on education. Telangana is spending only 6% on education. But the 3,300 crores which we are spending through these gurukulas, that is through various other departments. If you calculate agriculture education, medical education, forest education, veterinary education and these Gurukulas, all together we spend around 11% on education. కానీ అందరూ ఏమంటారు 5% ఖర్చు పెట్టినారు, విద్యను నిర్లక్ష్యం చేసినామంటారు. ఇంకా అది ఎన్నని చెప్పాలి మనం? అది చెప్పి మనం కూడా ఒక్కొక్కసారి కన్ఫ్యూజ్ చేసేటువంటి ప్రయత్నం చేస్తున్నారు. ఎడ్యుకేషన్ మీద ఎంత ఫోకస్గా ఈ గవర్నమెంట్ ఉంది. ఇన్వెస్టింగ్ ఆన్ చిల్డ్రన్ ఈజ్ ఇన్వెస్టింగ్ ఆన్ ద ఫ్యూచర్. అది ఒక క్యాపిటల్ ఎక్స్పెండిచర్గా ముఖ్యమంత్రి గారు చూస్తారు. చాలామంది నార్మల్గా గవర్నమెంట్లో ఒక సిస్టమ్ ఉంటుంది. మీకు తెలవాల్సింది ఏంటంటే గవర్నమెంట్లో ఏం చేస్తారంటే రెవెన్యూ ఎక్స్పెండిచర్, క్యాపిటల్ ఎక్స్పెండిచర్ అని 2 పద్ధతులు ఉంటాయి. ఫైనాన్స్ డిపార్ట్మెంట్లో మాకు చెప్తుంటారు. క్యాపిటల్ ఎక్స్పెండిచర్ ఎక్కువ పెట్టాలి, యూ షుడ్ క్రియేట్ అసెట్ అని చెప్తారు. రెవెన్యూ ఎక్స్పెండిచర్ అంటే ఏంటి? ఈ ఫ్రీ బీస్, బియ్యం ఇచ్చుడు, కళ్యాణ లక్ష్మి ఇచ్చుడు, దవాఖానకు ఆయుష్ ఆరోగ్యశ్రీ ఇచ్చుడు, లేకపోతే వృద్ధాప్య పెన్షన్ ఇచ్చుడు, ఈ పిల్లల చదువులు, ఎస్సీ ఎస్టీ బీసీ రెసిడెన్షియల్ స్కూల్లో పిల్లల్ని చదివించడం కూడా రెవెన్యూ ఎక్స్పెండిచర్ అంటారు. బట్ అవర్ సీఎం సేస్ పిల్లల్ని చదివించడం అనేది ఇది రెవెన్యూ ఎక్స్పెండిచర్ కాదు, ఇది భవిష్యత్ తరాల మీద పెట్టే పెట్టుబడి. వీ షుడ్ సీ ఇట్ యాజ్ ఎ క్యాపిటల్ ఎక్స్పెండిచర్ అని చెప్తాడు మా ముఖ్యమంత్రి కేసీఆర్ గారు. అందుకే ఈరోజు రాష్ట్రం ఏర్పడ్డప్పుడు రెసిడెన్షియల్ స్కూల్స్ మీద పెట్టే ఖర్చు ఇట్ ఈస్ యూస్ టు హ్యావ్ అరౌండ్ 350 crores, బట్ టుడే వీఆర్ స్పెండింగ్ 3,300 crores. ఆల్మోస్ట్ 10 times more వీఆర్ స్పెండింగ్ ఆన్ ఎడ్యుకేషన్ అండ్ ద ఫ్యూచర్ కిడ్స్. సో ఇట్లా మనం విద్య మీద కూడా చాలా ఫోకస్ చేసి తెలంగాణ ప్రభుత్వం పెద్ద ఎత్తున ఖర్చు పెడుతున్న విషయాన్ని ఒక్కసారి మీరు గమనించాలి. రెండో విషయం కూడా మా డాక్టర్స్కు, ఒకటేమో ఎడ్యుకేషన్లో ఐ వాంట్ జస్ట్ కొద్దిగా బ్రీఫ్గా క్లారిఫై చేద్దాం అనుకున్నా, మీ ముందు పెట్టే ప్రయత్నం చేశాను. ఇంకా రెండో విషయంలో మీకు చెప్పాల్సింది అగ్రికల్చర్. అందరూ ఏమంటారంటే ఒక రాష్ట్రం యొక్క జిఎస్డిపి పెరగాలి, పర్ క్యాపిటా ఇన్కమ్ పెరగాలి అంటే ఇండస్ట్రీ రావాలి, ఐటీ రావాలి, లేదా ఇంకా ఏదో రావాలని మాట్లాడతారు. ఇండస్ట్రీ, ఐటీ ఓకే, యువర్ పర్ క్యాపిటల్ ఇన్కమ్ మే గ్రో, బట్ లైవ్లీహుడ్. ఇవాళ తెలంగాణ ఈజ్ ద నంబర్ 1 స్టేట్ ఇన్ ద కంట్రీ. ఈ గ్రోత్ రేట్ చూసుకున్నప్పుడు పర్ క్యాపిటల్ ఇన్కమ్ గ్రోత్ రేట్లో కానీ, అగ్రికల్చర్ ప్రొడ్యూస్లో, అగ్రికల్చర్ ఫార్మర్ ఇన్కమ్లో పెంచడంలో వీఆర్ నంబర్ 1, వీఆర్ ఛాంపియన్, వీఆర్ రోల్ మోడల్ టు ద కంట్రీ. అసలు మీరు సర్ప్రైజ్ అవుతారు. మన రాష్ట్రం వచ్చినాడు, మన రాష్ట్రం యొక్క వరి ధాన్యం ఉత్పత్తి, వరి పంట ఉత్పత్తి 68 లక్షల మెట్రిక్ టన్నులు, 68 lakh మెట్రిక్ టన్ ఇన్ ద 2014-15. లాస్ట్ ఇయర్ ఎంతనో చెప్పగలుగుతారా మీరు ఎవరైనా? కెన్ ఎనీబడి? 2,49 lakh metric tons. 2,49 lakh metric tons. In a span of 7 years, 68 lakhs to 2,49 lakh metric tons. We have bypassed Punjab. Telangana stood number 1 in production of paddy. How come it possible? One fellow says, టీవీలో చూస్తారు మీరు, కాళేశ్వరం ప్రాజెక్ట్తో 1 ఎకరం బారలేదంటున్నాడు. మరి ఏం చేయాలి? నేను నెత్తి కొట్టుకోవాలని, నోరు కొట్టుకోవాలని. మరి ఎట్లొచ్చింది? ఒట్టిగానే మంత్రం వేస్తే వస్తుందా? ఏమన్నా మాయ చేస్తే పంట పండుతుందా? మన క్రాప్ స్వోన్ ఏరియా అంటే పంట సాగు భూమి ఆల్మోస్ట్ డబుల్ అయింది. ఎందుకయింది? వాటర్ అవైలబిలిటీ పెరిగింది. వీ హ్యావ్ కంప్లీటెడ్ మెనీ పెండింగ్ ప్రాజెక్ట్స్. వీ హ్యావ్ ఫినిష్డ్ ఎ బిగ్ ప్రాజెక్ట్ లైక్ కాళేశ్వరం ప్రాజెక్ట్. వీ హ్యావ్ రిస్టోర్డ్ our tanks through Mission Kakatiya program. We started giving 24/7 free power to farmer. We started giving investment input subsidy to farmer, 10,000 rupees per acre per annum. So like itla enno pro farmer activity తీసుకోవడం వల్ల వరి ధాన్యం ఉత్పత్తి పెరిగి దేశంలో పంజాబ్ 30-40 ఏళ్ల నుంచి పంజాబ్ నంబర్ 1లో ఉంటే ఒక కొత్త రాష్ట్రం, చిన్న రాష్ట్రం, ఇవాళ మనము పంజాబ్ను కూడా బైపాస్ చేసి 2,49,00,000 మెట్రిక్ టన్నుల ప్యాడీని ఉత్పత్తి చేసి ఇవాళ నంబర్ 1గా నిలిచినాం. మీరందరికీ కూడా వ్యవసాయ భూమి ఉండుంటుంది, డాక్టర్స్ కొంటాము ఎంతో కొంత, ఎక్కడో ల్యాండ్. ఈరోజు అప్పుడు ఆంధ్రాలో 1 ఎకరం అమ్మితే తెలంగాణలో 3 ఎకరాలు వస్తుంది అంటోళ్ళు. ఇప్పుడు తెలంగాణలో ఎకరం అమ్మితే ఆంధ్రాలో 3 ఎకరాలు వస్తుంది. ఇప్పుడు one of my colleague MLA, day before yesterday, he was mentioning with me, అన్నా నేను కర్ణాటకలో 150 ఎకరాలు కొన్నా అన్నాడు. ఏంద్ర తమ్మి అంటే, అన్న నాకు ఇక్కడ హైదరాబాద్ దగ్గర 2 ఎకరాలు ఉండే, 2 ఎకరాలు అమ్మితే 150 ఎకరాలు వచ్చిందన్న అంటుండు. 5 లక్షలకు ఎకరం ఉందటాడు ఇప్పుడు. 5 లక్షలకు ఎకరం పోయి కర్ణాటకలో కొనుడు స్టార్ట్ చేసిండు. అయితే ఇక్కడ ద పాయింట్ వాట్ ఐ వాంట్ టు మేక్, ఇక్కడ మీరు గమనించాల్సి, ఒటినే పెరుగుతాయి భూముల ధరలు. వై ఇట్ విల్ గ్రో జస్ట్ లైక్ దట్? దెర్ హ్యాస్ టు బి సమ్ థియరీ, దెర్ హ్యాస్ టు బి సమ్ మెకానిజం కదా. ఏంటి, కాలమైనా కాకపోయినా, వాన పడ్డా పడకపోయినా 2 పంటలు పక్కా పండుతాయి. 24 గంటలు ఉచిత కరెంట్ వస్తుంది. 10,000 రైతు బంధు పక్కా వస్తుంది. పండిన పంట అంతా గవర్నమెంట్ పక్కా కొంటుంది అన్నప్పుడు ఆటోమేటిక్గా భూమి విలువ పెరిగింది. ఒటికినే పెరగదు కదా. ప్రతి ఎకరానికి సాగునీరు, ప్రతి రైతుకు ఉచిత కరెంటు, ప్రతి ఎకరానికి 10,000 రూపాయలు, పండిన పంట అంతా గవర్నమెంట్ విత్ ఎంఎస్పి దే బై బ్యాక్ 100% crop produced by the farmer. Then value of respect of the farmer has gone up, value of land has gone up. సోషల్ డిగ్నిటీ పెరిగింది, రైతుకు భూమి యొక్క విలువ పెరిగింది, రైతులో ఆత్మవిశ్వాసం పెరిగింది. అంటే ఇంత గొప్ప విజయాన్ని ఇలా తెలంగాణ రాష్ట్రం రావడం వల్ల మాత్రమే సాధ్యమైంది తప్ప తెలంగాణ వచ్చుండకపోతే ఈ అవకాశం మనకు వచ్చి ఉండేది కాదు. అంటే దెర్ ఇస్ ఎ విజన్, దెర్ ఇస్ ఎ వర్క్, కమిట్మెంట్. ఇది కూడా దయచేసి డాక్టర్స్గా మీరు గమనించాలి. ఇట్లా మేము చెప్తే అద్భుతమైన విజయాలు. మీరు సింపుల్, నేను 100 విషయాలు చెప్పనే, మీ కాలేజీల గురించే మీరు ఆలోచించండి. 5 కాలేజీలు 17 కాలేజీలు అవుతుండేనా? తెలంగాణ రాకపోతే 17 ప్రభుత్వ మెడికల్ కాలేజీలు తెలంగాణలో వచ్చుంటుండేనా? మన మెడికల్ ఎంబీబీఎస్ సీట్లు 4 టైమ్స్ పెరిగి ఉండునా? పీజీ సీట్స్ డబుల్ అయ్యి ఉండేదా? ఇంత మన డెవలప్మెంట్ వచ్చి ఉండేదా? ఇది మీరు ఒక్కసారి ఆలోచించండి. ఇట్లా చెప్తూ పోతే మన జిఎస్డిపి గ్రోత్ రేట్లో, పర్ క్యాపిటా ఇన్కంలో, పర్ క్యాపిటా ఇన్కమ్ మన రాష్ట్రం వచ్చినాడు తలసరి ఆదాయం 1,24,000 రూపాయలు ఉండేది. ఆఫ్టర్ 7 years ఇట్ ఈస్ 2,78,000. లాస్ట్ 7 yearsలో ఎవ్రీ ఇయర్ వీఆర్ బైపాసింగ్ 1 స్టేట్. ఒక సంవత్సరం కర్ణాటకను బైపాస్ చేసినాం, ఒక సంవత్సరం తమిళనాడు బైపాస్ చేసినాం, ఒక సంవత్సరం ఆంధ్రప్రదేశ్ను బైపాస్ చేసినాం. లాస్ట్ 7 yearsలో ఒక్కొక్క రాష్ట్రాన్ని బైపాస్ చేస్తూ వీ స్టూడ్ నంబర్ 1 ఇన్ ద కంట్రీ ఎక్సెప్ట్ దో స్మాల్ యూనియన్ టెరిటరీస్. ఆ గోవా లాంటి చిన్న రాష్ట్రాన్ని వదిలిపెడితే అమాంగ్ ద బిగ్గర్ స్టేట్స్ వీ స్టూడ్ నంబర్ 1 ఇన్ ద కంట్రీ. 7 సంవత్సరాల్లో 7 రాష్ట్రాలను, తమిళనాడు, మహారాష్ట్ర, వేర్ ద ఫైనాన్షియల్ క్యాపిటల్ Mumbai is there, we have bypassed even Maharashtra, we have bypassed Karnataka, we have bypassed Andhra Pradesh, Tamil Nadu, and we stood number 1 in per capita income. అంటే ఇట్లా ఒక అద్భుతమైనటువంటి విజయాలను మన రాష్ట్రం సాధించగలిగింది. సో ఇవాళ మీరు డాక్టర్స్గా దయచేసి మీరు కూడా మంచిని, జరుగుతున్న దాన్ని మీరు కూడా గమనించాలి. మీరు కూడా వేరియస్ ఫోరమ్స్లో, ఇంటలెక్చువల్ ఫోరమ్స్లో మీ పేషెంట్స్తో ఎక్కడ అవకాశం వచ్చినా కూడా మంచినండి, జరుగుతున్నటువంటి గ్రోత్ను మీరు అందరూ కూడా గమనించాలి, గుర్తించాలి. మీ సహకారం కూడా అదే నా ఒక్క అపీల్, మీ అందరితో కూడా నా అపీల్. ఇట్లా చెప్తే ఇంకా చాలా ఇష్యూస్ ఉన్నాయి కానీ ఇంకా మీకు కూడా లేట్ అయిపోయింది. సో 1-2 అంశాల్లో ఎడ్యుకేషన్లో మేము ఏం చేస్తున్నాం, హెల్త్లో మేము ఏం చేస్తున్నాం, అదేవిధంగా అగ్రికల్చర్ సెక్టార్లో ఏమొచ్చింది, ఇరిగేషన్ సెక్టార్లో ఏమొచ్చింది, ఇవన్నీ కూడా మీరు చూస్తున్నారు. మీరు మన ఎల్ఎండిలో ఉన్నాం కరీంనగర్లో. ఒకప్పుడు ఎల్ఎండిలో చుక్క నీళ్ళు ఉండేది కాదు. కంటిన్యూస్ 2 years డ్రౌట్ యూ యూస్ టు సీ, 3 years డ్రౌట్ యూ యూస్ టు సీ. ఇంకా మీరు చరిత్రలో ఎల్ఎండి విల్ బి ఆల్వేస్ ఫుల్. యూ విల్ నెవర్ సీ అన్ ఎంప్టీ ఎల్ఎండి ఇన్ యువర్ లైఫ్ టైమ్. దట్ ఈస్ బికాస్ ఆఫ్ కాళేశ్వరం. కాళేశ్వరం కనెక్ట్ అయినాక ఎల్ఎండిగా మనం చూడమిగా, అది ఫుల్ 24 TMC ఎల్ఎండిఏ మీ కళ్ళ ముందు ఉంటుంది. మేబీ రైనీ సీజన్, మేబీ ఇట్ ఈస్ ఎ సమ్మర్ సీజన్, it will be 24 TMC full LMD reservoir you will be seeing. My తెలంగాణ వచ్చినాక ఇన్వర్టర్, కన్వర్టర్, జనరేటర్ అన్ని మాయమైపోయినాయి. इन्वर्टर गया, कन्वर्टर गया, जनरेटर गया. तेलंगाना आने से पहले क्या होता था, हमारे नर्सिंग होमों में 6-6 घंटे 7-7 घंटे पावर कट रहता था. के लिए डीजल पे बहुत पैसा खर्च करते थे ये लोग. डॉक्टर संजय हमारा एमएलए ने याद कर रहा, इन लोगों का जनरेटर पे डीजल पे बहुत खर्चा कम हो गए बोल के याद कर रहे हैं. ఆల్మోస్ట్ జీరో. సో అట్లా అద్భుతమైన పవర్ సెక్టార్లో కానీ ఇన్ వేరియస్ సెక్టర్స్ ఇవాళ మనము వీఆర్ ఎ పవర్ సర్ప్లస్ స్టేట్. వీఆర్ సెల్లింగ్ పవర్ టు అదర్ స్టేట్స్ సమ్ టైమ్స్. ఒకప్పుడు when the state was formed, we used to buy power from Chhattisgarh, we used to buy power in power exchange, we used to buy power from Andhra Pradesh. Today we are a power surplus state, we are selling power to other states. This is what we have achieved in the span of 7 years. మీకు గుర్తుంటుంది, ఒకసారి యాద్ చేసుకుంటే పోంగ కిరణ్ కుమార్ రెడ్డి కట్టబెట్టి చూపించిండు మనకు. అరే మీ కరెంట్ ఎట్లనే, మీ తెలంగాణలోకి ఎరవడతాం అంటుర్రు, కరెంట్ తయారయ్యేదంతా మా దగ్గరనే, మీరు ఎట్లా బతుకుతారా అని కట్టబట్టుకొని చూపించిండు. కట్టబట్టుకి చూపించిన వాళ్ళకేమో చీకటి అయిపోయింది, మనకు మాత్రం వెళ్తురు వచ్చింది. యాదుకుందో లేదో మీకు, జస్ట్ బిఫోర్ ఫార్మేషన్ ఆయన కట్టబట్టుకొని చూపించండి మనకు, మొత్తం మా దగ్గరనే ఉన్నాయి జనరేటింగ్ స్టేషన్స్ అన్ని మా దగ్గర ఉన్నాయి, హౌ డు యూ సర్వైవ్ అన్నాడు. బట్ వాట్ హ్యాపెండ్? ఇఫ్ దెర్ ఈస్ ఎ విల్, దెర్ ఈస్ ఎ గుడ్ లీడర్, డెఫినెట్లీ దెర్ ఈస్ ఎ వే, డెఫినెట్లీ యూ కెన్ అచీవ్ సర్టన్ థింగ్స్. ఇవాళ అంత అద్భుతమైనటువంటి విషయాలను మనం సాధించుకోగలిగినాం. సో మిత్రులారా, ఇంత ఓపికగా విన్నందుకు, అరే భై ఉస్మానియా का बोल तुम रहे भाई, छोड़ो मेरे को, ऑलरेडी मैं बोल चुका हूँ. यू नो, ఉస్మానియా ఆసుపత్రిని అన్నిటికంటే ముందు కేసీఆర్ వెంట్ టు ఉస్మానియా హాస్పిటల్. హీ అనౌన్స్డ్ టు కన్స్ట్రక్ట్ ఎ న్యూ హాస్పిటల్ ఉస్మానియా. బట్ వాట్ హ్యాపెండ్? సర్టన్ ఆర్గనైజేషన్స్ దే వెంట్ టు హై కోర్ట్ అండ్ దే गॉट स्टे. दे से यू डोंट डेमोलिश. बट दूसरा जगह बनाएंगे बोले तो नोबडी इज प्रिपेयर्ड, वहीं बनाना बोलते हैं. और कोई कोर्ट में डालते डेमोलिशन मत करो. సో రీసెంట్లీ ఒక హెరిటేజ్ కమిటీ వేసినాం. హెరిటేజ్ కమిటీ వేసి బై ప్రొటెక్టింగ్ ద ఓల్డ్ బిల్డింగ్, సర్టన్ బ్లాక్స్ విచ్ ఆర్ నాట్ ఇన్ హెరిటేజ్, వీ కెన్ డెమాలిష్ దోస్ బిల్డింగ్స్ ఇన్ ఎ ఫేజ్డ్ మేనర్. వీ విల్ కన్స్ట్రక్ట్ న్యూ బిల్డింగ్స్, న్యూ ఉస్మానియా హాస్పిటల్. ఫర్ దట్ వీ హ్యావ్ సబ్మిటెడ్ ద ప్రపోజల్ ఇన్ ద కోర్ట్ ఆఫ్ in the High Court. So we are awaiting for the permission from High Court. So we said we protect the heritage. The buildings which are not in heritage, we will demolish that. In that place, in a phased manner, by running the hospital, we will construct new Usmania hospital. So we have given a proposal to High Court. We are expecting for the judgment, a positive judgment. Once it comes, we will start constructing new Usmania hospital. Thank you.
So that is our chief guest, Honorable Health Minister Sri Harish Rao garu. Actually, chief guest మాట్లాడిన తర్వాత nobody should speak, but ఒక్కటి I want to tell. We have a minister garu, Vinod Kumar garu, మీరు వినాలి, మీకు interesting subject. A tiny country like Bhutan, they have a GNH that is called Gross National Health Happiness. Apart from GDP, is very important for health point of view. I request the government to study on that. Shortcut. Okay.
First, I salute you, sir. I haven't seen health minister like you. I have got all part of the state. So progressive. So I haven't seen such. So salute you on behalf of IMS. I request you, Dr. V.N. Rasha, please make a statue of Dr. A.K. Sinha in your IMA building, please, sir. Sir, what doctor is coming from Kanyakumari, Kashmir to Kanyakumari, please give him one. He is saying how to live, how to.
I request all honorable members, please be seated for another 2 minutes. We need to honor our guest. Please be seated. Please be seated. And I request our honorable guest, sir, please give us 2 minutes time to honor the guest. Please, all incoming and outgoing office bearers are also requested to be seated because we need to honor you people also. Now I request Dr. B.N. Rao sir to honor our today's chief guest. T. Harish Rao sir. B.N. Rao sir will honor our chief guest, Harish Rao sir. I request Dr. Ram Kiran, the organizing secretary, to honor our Minister for BC Welfare, Sri Gangula Kamlakar Garu. I request the host branch president, Dr. Lakshman Kumar, to please honor our Telangana State Board Vice Chairman, Sri Vinod Kumar Garu. I request the President-elect, Dr. Kali Prasad Rao sir, to honor Dr. Sanjay Kumar. Dr. Kali Prasad Rao sir. Reddy sir, to honor M. Sampath Rao sir. And I request the incoming team. No, Dr. Ram Kiran will honor BC Welfare Minister Gangula Kamlakar Garu. Dr. Lakshman Kumar will honor Vinod Rao sir, and Dr. Kali Prasad Rao sir will honor Sanjay Kumar MLA Jagtial, and Dwaraknath Reddy sir to honor Dr. Sampath Rao sir. I request the new elected team under B.N. Rao sir to honor our National President Sahajan Prasad Singh sir. And I request Dr. Vijay Rao, incoming secretary, to honor our mayor Y. Sunil Rao Garu. Fast. Sunil Rao. Fast. We need to honor the outgoing and incoming team also, and there is IMA annual award function will also be there, and it is customary to honor some of the senior members in the annual conference. So the program will take another 10-15 minutes. Once the chief guest and other guests leave, we will continue with award function. That's why I request all the honorable members to please cooperate with us for another 10 minutes.
Sajanand and Agarwal, national, they want to go.
Want to go? Okay.
Chief guest से दिला देंगे.
Already national ఇస్తున్నారు సార్. దీనికి ప్రెసిడెంట్ ఎలక్షన్ ఒక శాల్వా మేము ఉంటాయి. Now I request Chief Guest Harish Rao sir to honor our President-elect Dr. Sharat Kumar Agarwal Garu. Dr. Sharat Kumar Agarwal Garu will be honored by our Chief Guest T. Harish Rao sir, Honorable Minister for Health. మీరు అయిపోయింది మనం రాండి మీరందరూ రాండి ఓకే తీసుకోదేరా మీ నామనే పడా కోల్డ్ అవ్వదు మేడం ఓకే కమ్ ఫాస్ట్
Please, all the dignitaries, please be seated. All the dignitaries on the dais, please be seated. నెక్స్ట్ ఉంటుంది సార్. ఉన్నాయి సార్ అందరికీ సార్ అందరికీ.
మరి మళ్ళీ అవార్డ్స్ ఒకటి ఉన్నాయి
అవి తర్వాత సార్ నెక్స్ట్ ఇది తర్వాత ఇవి ఇచ్చేస్తాం తొందరగా. ఇవి తొందరగా వీళ్ళు వాళ్ళు సెటిల్ వాళ్ళు పోతే సెటిల్ అవుతారు.
వాళ్ళు జరుగుతూ ఉంటుంది.
అదే
మీరు అట్లా కాదు అనౌన్స్ చేసి అసలు ఒక్కొక్కరు మీరు ఇచ్చేసేయండి ఫస్ట్. కవర్ కొంచెం జరుగుతుంది.
Sir, once our chief guest leaves, I request all the incoming outgoing office bearer, please gather onto the dais. We need to honor you, sir. All outgoing and incoming office bearers, please come out to the dais.
అమ్మా రామ్ కిరణ్ సార్ రామ్ కిరణ్
I once again request all outgoing and incoming office bearer kindly gather onto the dais. Please, it will cooperate with us for another 10-15 minutes because we need to finish the award function.
कल सुबह 4 बजे दिल्ली का फ्लाइट है, मैं निकलता हूँ।
एक मिनट आप मोमेंट तो लेके जाइए। एक मिनट
दे देगा।
I request Dr. Ram Kiran, Organizing Secretary, and Venkat Reddy.
Momentos, madam, momentos.
I request Ram Kiran, Organizing Secretary.
Sir.
Please hand over the memento to Dr. E. Ravindra Reddy sir, National Vice President. I also request you to hand over the memento to immediate past President Dr. D. Lavakumar Reddy sir. The next memento is to outgoing Secretary Dr. B.N. Reddy sir. Dr. B.N. Reddy sir. Vijay Rao, you please hand it over. Dr. B.N. Reddy sir. Dr. R.K. Yadav. Dr. R.K. Yadav, if you are there, please hand over the memento to outgoing Finance Secretary Gattu Srinivasulu. Gattu Srinivasulu. I request our National Vice President Ravindra Reddy sir to hand over the memento to Organizing Secretary Dr. Ramkiran Polasa. Dr. Ramkiran Polasa. And Ravindra Reddy sir will also hand over the mementos to Dr. Kali Prasad Rao sir and Dr. Dwakanath Reddy sir, President-elect. Dr. Kali Prasad sir and Dr. Dwakanath Reddy sir, please receive the mementos from our National Vice President Dr. E. Ravindra Reddy sir. The next memento will be to Dr. J. Vijay Rao, Incoming Secretary. Dr. Vijay Rao, Incoming Secretary. ఒక 5-6 తీసుకుపోయి అక్కడ పెట్టుకోండి. 5-6 తీసుకుపోయి అక్కడ పెట్టుకోండి. డాక్టర్ రాజేంద్ర కుమార్ యాదవ్. డాక్టర్ రాజేంద్ర కుమార్ యాదవ్, please receive the memento from Ravindra Reddy sir. Then Dr. V. Ashok, Dr. Kavita Reddy, Dr. Nalla Surendra Reddy, outgoing Vice Presidents. Please receive the memento. Dr. Ashok, Dr. S. Kavita Reddy and Dr. Nalla Surendra Reddy.
మనదున్న సెక్రటరీ సిజిపి
సెక్రటరీ లేదు అట్లా ఉండదు సార్, ఉండండి. Then I request the incoming Vice President Dr. Jagan Mohan Rao sir and Dr. Pullarao garu. Dr. Jagan Mohan Rao sir and Dr. Pullarao garu. Then IMA AMS National Secretary Dr. Sanjeev Singh Yadav garu. Dr. Sanjeev Singh Yadav. Next. Award din tarvata. Then Dr. Srirang Abkari, Incoming Secretary AMS. Dr. Srirang Abkari garu. Dr. Pujari Ramana, President Thana. Dr. Surendra Nath sir and Dr. Lingamurti sir, Vice President, Joint Secretaries. Dr. Lingamurti garu and Dr. Surendra Nath garu. Then incoming Joint Secretaries Dr. Yashwant Rao garu and Sandhya Rani madam. Incoming Joint Secretaries Dr. Yashwant Rao and Dr. Hari Sandhya Rani madam. Then our host branch president Dr. Lakshman Kumar. Lakshman Kumar, please receive the memento from Ravindra Reddy sir. The next will be Building Trust Chairman Dr. Krishna Reddy sir and FSS Chairman Dr. K. Rajeshwar sir. Dr. Krishna Reddy sir and Dr. Rajeshwar sir. Outgoing Joint Secretaries Dr. G.N. Reddy, Dr. Pentachari garu, Dr. B. Srinivas Rao garu. Sir, Jagan sir, మీరు తీసుకోండి. వెంకట్ జగన్ సార్. Outgoing Joint Secretaries Dr. G.N. Reddy garu, Dr. Pentachari garu, Dr. B. Srinivas Rao garu. Next, incoming Joint Secretaries Dr. Jagdishwar Reddy garu, Dr. MLN Reddy garu and Dr. Anand Bokre. Sir, Vijay. Sir, akkadi. Next, Vice Presidents elect Dr. Balraj garu, Dr. Ganga Sagar garu and Dr. Ashok Reddy garu. Dr. Balraj garu, Dr. Ganga Sagar and Dr. Ashok Reddy. Then Joint Secretary select Dr. Ratnam garu. FVS Chairman Dr. Jagan Mohan Rao garu and Health Scheme Chairman Bandala Mohan Rao garu. FVS Chairman Jagan Mohan Rao garu and Health Scheme Chairman Bandala Mohan Rao garu, Director CGP Vijay Simha Reddy garu and Dr. Jhansi Organizing Committee Treasurer. Dr. Vasanta Kumari Chairman IMA AMS. ఇప్పుడు చెప్తా ఆర్గనైజింగ్ కమిటీ. Now it is the turn of organizing committee members to get the mementos. చెప్పినా సార్ అక్కడ వెళ్ళి తీసుకోండి, చెప్పినా అది తర్వాత దీని తర్వాత. Now I request the organizing committee of Ts Con 6/2022, Dr. GVS Tirupati Reddy, Dr. Arun Katari, Dr. Manasa, Dr. Poladi Srinivasarao sir, Dr. Vijay Lakshmi, Dr. G. Venkat Reddy, Dr. Praveen Manna. Please come over to the dais. సార్ తర్వాత ఒకటి మళ్ళీ అరే ఏమి దీని తర్వాత అయ్యే ఇప్పుడు మన బ్రాంచ్ చేసుకోవద్దా మనం? ఎవరు టైం అడుగుతున్నారు? అవుతుంది ఏముంది, అరగంట ఇటు అటు, అరగంట ఇటు అటు. అవును తీసుకోండి, ఇస్తున్నారు అవార్డు తర్వాత సార్. దిస్ ఈజ్ హోల్లీ కాన్ఫరెన్స్ ఫంక్షన్, తర్వాత అవార్డు ఫంక్షన్ ఉంటుంది. ప్లీజ్ బేర్ విత్ అస్. డాక్టర్ జీవీఎస్ తిరుపతి రెడ్డి, డాక్టర్ అరుణ్ కటారి, డాక్టర్ మానస, డాక్టర్ పోలాడి శ్రీనివాసరావు, డాక్టర్ విజయలక్ష్మి, డాక్టర్ వెంకట్ రెడ్డి, డాక్టర్ ప్రవీణ్ కుమార్ మన్నా. ఎందుకు తీసుకోలేదు? ఇచ్చేయండి సార్, తర్వాత ఇక నేను కూడా నాకు చదువుకోలేను, రావాల్సి వస్తుందండి. చదువుతా ఉన్నా కదా. నోటీస్ ఆల్ committee chairmans, venue committee Dr. Ramya, reception committee Dr. Srilata Reddy madam, registration committee Dr. Rajni Priyadarshani, scientific committee Dr. DC Tirupati Rao sir, Savanir committee P. Kishan, stall committee Chandramati, food committee Jhansi, and transport and accommodation Vasant Rao. I request all of you to receive the mementos. పెద్దగా అయిపోతే చిన్న ఇవ్వండి, పెద్దది అయిపోతే చిన్న. Now, అదే ఇచ్చేయండి, ఇక అదైపోతే ఇది, అదైపోతే ఇది ఇచ్చేయండి. Now we want to felicitate some of the past president, Dr. K. Sudhakar Reddy sir, Dr. Vijayendra Reddy sir, Dr. Kasturi Pramila madam, Dr. Narsingha Reddy sir, Dr. Pratap Reddy sir, Dr. Shyam Sundar, Dr. Vijayendra Reddy sir, and Dr. Gutta Suresh. Past presidents, vice chairman, sir. సార్ ఇప్పుడు సార్కి ఎఫ్బిఎస్ చైర్మన్ ఇవ్వండి. అట్లా కాదు సార్, పిలిచినప్పుడు లేరు, ఒక్కసారి వస్తుంది, మీరు వెళ్ళండి, తీసుకోండి. పిలిచినప్పుడు ఇక్కడ వస్తలేదు కదా సార్, ఇప్పుడు పేరు చదివిన ఎవరు లేరు.
ఇంకా 4 ఉన్నాయి, పెద్ద మనుషులు వస్తే
few of the advisors, हाँ देने का है, बुलाया ना भाई. Past presidents, Dr. K. Sudhakar Reddy sir, Dr. P. Vijaychandra Reddy sir, Dr. Kasturi Pramila madam, Dr. Narsingha Reddy sir, Dr. Pratap Reddy sir, Dr. Shyam Sundar, Dr. Vijayendra Reddy sir, and Dr. Gutta Suresh. Vijay, please cooperate first you. అయిపోయిందమ్మా, అయిపోయింది, ఉండండి, ఒక 2 నిమిషాలు ఉండండి, మాది లాస్ట్. Few of the advisors, Dr. Sai Kumar, Dilip Banushali sir, and Dr. Yakaya sir, Dr. Suryanarayan Reddy sir, Vivekanand sir. If they are present, kindly come over and get your award sir. Some of the senior members of IMA Karimnagar, Dr. Lakshmi Narayan sir, Dr. Sridhar Rao sir, Dr. Y. Narendra sir, Dr. Vijay Mohan Reddy sir, Dr. Mohan Rao sir. If any of you present, please come. And Dr. Balaji, Warangal president, Dr. M. Mallesham, Mansyar president, Dr. Rajesh Krotla president, Dr. Suresh, secretary Huzurabad, Dr. Ajay Reddy, president Jaktial, Dr. Jiveria madam, DMHO Karimnagar, Dr. B. Ratnamala madam, superintendent Karimnagar. These are the awardee list.
అది ఎన్నిసార్లు ఇప్పుడు పెద్దలు కట్టుకుపోయింది కదా ఇవ్వమని అక్కడ ఉండండి. మూమెంట్ వస్తుంది మీరు అనే రాజేష్ రాకుండా మీరు తీసుకోండి. అదే ఇస్తా అక్కడ వెళ్ళండి సార్. అమ్మ మీరు అక్కడ చూడండి ఎవరు తీసుకుంటారో ఎవరు తీసుకుంటలేరో. ఈ అవార్డ్ ఫంక్షన్ కాదు సార్, ఇది మా కాన్ఫరెన్స్. అవార్డు ఇంకా స్టార్ట్ కాలేదు. రాజేష్ది ఇప్పిస్తా సార్, ఇప్పిస్తా. అవును అవును రాజేష్ ఒకటే. డాక్టర్ బాలాజీ ప్రెసిడెంట్ వరంగల్, డాక్టర్ మల్లేష్ ప్రెసిడెంట్ మంచిర్యాల్, డాక్టర్ రాజేష్ ప్రెసిడెంట్ కొరట్ల, దిలీప్ రావు సార్ విల్ గెట్ ద మొమెంటో ఆన్ బిహాఫ్ ఆఫ్ మంచిర్యాల్, and Dr. Suresh from Korotla, you will be receiving. Dr. Juveria madam and Dr. Ratnamala madam. Idi Karimnagar Mohan. Okay, gada. Now what? Now we sincerely thank all of you for attending this IMA TS Con. We will hand over the mic to State IMA for conducting the award function. Thank you.
Before that, Sirsila IMA, from the state we are giving 1 lakh check for the renovation of their building construction.
आप चलेंगे?
లిస్ట్
ఇవ్వయ్యా.
ఒకటి ఏమైందంటే ఎయిర్పోర్ట్ బ్రాంచ్ ఇది చైతా దాంట్లో ఇప్పిస్తాను. ఎయిర్పోర్ట్ బ్రాంచ్ ఇది అది రాలే. అది ఎట్లా విషయం అంటే ఆ టైం బీయింగ్ అది ఇప్పించండి. టైం బీయింగ్ ఇప్పించేసి ఎయిర్పోర్ట్ సరే అయితే ఇదో అనౌన్స్ ఇదో అల్లి అల్లే
సార్. కంగ్రాచులేషన్ సార్ జగన్ సార్. ఇప్పుడే ఎవ్రీబడి టు నేను వస్తున్నా. ఎక్కడుంది?
Yeah. Can I request everybody to sit properly? We are going to give the state awards, and people on the dais also please sit down. All the people on the dais also please sit down. Please, the state awards will be announced. Please. Announcement too. BN ready. BN ready, please. BN ready, please. Come. State list ఇదేనా? ఈ అవార్డ్స్ లిస్ట్ చదువుతూ ఉండండి. స్టేట్ అవార్డ్స్ లిస్టు నేను ద్వారకు బిఎన్ కలిపి ఇచ్చేస్తాం. ఆరు నేను చదవనా మీరు ఇస్తారు? బిఎన్ రెడ్డి చదువుతూ ఉంటాడు. రైట్. చెక్స్ కూడా ఇచ్చేద్దాం. చెక్స్ మీరు అనౌన్స్ చేయండి.
బిఫోర్ ద స్మాల్ ఇంట్రడక్షన్. Good evening, everybody. We are going to announce the state awards now, and I would like to bring to notice of everybody. These awards are purely given on the reports that has been received in the state office. Please make a note of it. I am sure most of the people have done wonderful job. But the issue is that most of the people, they have not reported they have not sent any reports. Even the present awards, most of them, I personally called them. The very fact is that they are all in front of me. So I got some sort of information, and we have whatever the reports were received on that. On the basis of that, we are giving this report, awards. And me being the chairman of the awards committee, I have the members with me are Dr. Kali Prasad. Where is Kali? Yeah, Kali Prasad, and then Dr. Vijay Rao, and where is Shivraj. So we are the members of the awards committee, and the list has been given to the state office, and that will be announced by the secretary of the state, Dr. B.N. Reddy. I think before that, I think there is a small.
Yeah, before that, I would like to announce that we are going to give 1 lakh to Sirsila Medical Association, IMA. I also request IMA Warangal, Dr. Nallar Surendra Reddy to get his conference check.
రెడీ అమ్మా ఇది లిస్ట్ నీ దగ్గర ఉందా ఏం చేస్తారు చెక్కులు తీసుకుంటారా
సారు చదువుతాడు ఇస్తుంటారు పక్కకుంటాం
ఫోటోలు పడాలి
లేదు అట్టగా అవార్డు కమిటీ అని ఎవరో తెలియదు మరి
అట్లా
లాస్ట్ టైం మంచిగా ఇచ్చినాం
నిలబడండి మరి అవార్డ్స్ లిస్ట్ ఆల్ రౌండ్ బెస్ట్ బ్రాంచ్ large branch category IMA Warangal branch. President Dr. Balaji Bairam, Secretary Dr. K. Nagarjun Reddy. నేనేమో అనౌన్స్ చేస్తాను నాకు తెలుసు కదా
I request Dr. Ram Kiran, Dr. Lakshman from Karimnagar branch to come onto the stage.
Lakshman Kumar and Arun.
Dr. Arun and Dr. Lakshman Kumar from Karimnagar branch. ఇది చేసినాక
ఎంతున్నా అంటే 10 minutes Women Doctor Wing Service. Women Doctors Wing. చెక్ ఇస్తున్నాడు సార్ కరీంనగర్ చెక్ ఇస్తున్నాడు నాట్ అవార్డు కదా కరీంనగర్ చెక్ ఇస్తున్నాడు ఆయన బట్టి మధ్యలో కంటిన్యూ
సార్ ఇచ్చాను
ఉమెన్ డాక్టర్స్ వల్ల వచ్చారు పైకి వచ్చారు మేడం కసి పంపించారు Women Doctors Wing Service, Dr. Hari Sanjarani, IMA Warangal Branch, Dr. Mantri Vijayalakshmi, IMA Karimnagar Branch, Dr. P. Shobharani, IMA Sirisila Branch, Dr. Farida Begum, IMA Nizamabad Branch. వచ్చేసారా లేదు అంటే ఇప్పుడుండే సార్ వాళ్ళు వెళ్ళిపోవాలి ఫోటోలు ఎక్కువ
I request, I think once they take the award, I request them to clear the dais, please. Because let the people come who are only being awarded and then take the award and then go. Because everybody getting crowded over here, I think that it doesn't look nice. So those are the people who are taking the award, please get away from the stage, please. I request them to go down. Even other people also, I think you just go down to the dais, and when your name is being called, you please come out to receive the award. Thank you very much.
All round best branch, IMA Nizamabad branch, medium branch category, President Dr. K. Subhash, Secretary Dr. Jalagam Tirupati Rao. కరెక్ట్ అక్కడ కరీంనగర్ అయిపోయింది అది
అదే పని
బెస్ట్ బ్రాంచ్
కొంచెం అది వాళ్ళంతా వాళ్ళు కదులుతలేరు
నిజామాబాద్ అయిపోయింది
నిజామాబాద్ కాదు నెక్స్ట్
ఇప్పుడు అవార్డు నిజామాబాద్ తీసుకుంటున్నారు నిజామాబాద్ తీసుకుంటున్నారు అయిపోతుంది ఒకసారి వాళ్ళు వెళ్ళిపోయారంటే నిజామాబాద్ ఆల్రెడీ రెడీ
తొందరపడకండి
కొంచెం బాగుంది
వాళ్ళు దిగకముందే అది చూడండి క్రౌడ్ మొత్తం క్రౌడ్కి చేస్తే వెయిట్ చేయండి నువ్వు రా ఎక్కడున్నావు
అక్కడికి
ఒక ఫోటో
ఎవరుందా ఒకటి అంతే ఇక కానీ వాళ్ళు కానీ ఆగండి కానీ
All round best branch, IMA Nirmal branch, small category, President Dr. U. Ramakrishna, Secretary Dr. Polishetty Santosh. కొంచెం నేను టిక్ చేసుకో Best Activity Branch, medium category IMA Nilagiri branch. President Dr. PVN Murthy, Secretary Dr. G. Anita Rani. అందుకనే చెప్పాలనా
సార్ చెప్తూనే May I request once again, those are the people who have received the award to clear the dais, please. Thank you very much. Please, please.
President Appreciation Award for Dr. C. Surendranath, Honorary State Joint Secretary. President Appreciation Award for Dr. Gattu Srinivaslu, Honorary State Finance Secretary. Best ఈ వరుసగా ఇప్పటికే
ఖమ్మం ఎక్కడుంది
Best Activity Branch, IMA Karimnagar Branch, Large Branch Category. President Dr. C.H. Lakshman Kumar, Secretary Dr. Arun Katari.
కరీంనగర్ పక్క పెట్టి బయట
అది నేను అనౌన్స్ చేయనా నేను
నాదేమో లేదు Best Activity Branch, IMA Mahbubabad, Small Branch Category. President Dr. B. Veeranna, Secretary Dr. G. Balu Naik. Mahbubabad Branch, Dr. Ruplal. వాళ్ళు వచ్చి సేమ్
నెక్స్ట్ అన్ని రెడీ ఉండమని నెక్స్ట్ నుంచి ఇక్కడ రెడీగా ఉండమని అయిపోతుంది.
బెస్ట్ కమ్యూనిటీ సర్వీసెస్ డాక్టర్ ఏ సిహెచ్ పుల్లారావు, నీలగిరి బ్రాంచ్.
ఎక్కడ ఉన్నాడు సార్? అక్కడ స్టేజ్ మీద ఉన్నాడా? అది ఇంకోటి కూడా చూడండి. అలా అక్కడే ఉంది సార్, వచ్చేసి నెక్స్ట్ రెడీ అవుతుంది సార్. రెడీ అన్న
అందరు ఎట్లా ఫోటోలు దిగుతారు ఆల్రెడీ పుల్లారావు. బెస్ట్ కమ్యూనిటీ సర్వీస్ ఏసీహెచ్ పుల్లారావు, నీలగిరి. అక్కడ ఇవ్వలేదు. బెస్ట్ కమ్యూనిటీ సర్వీసెస్ డాక్టర్ ఏ మోహన్ రావు, నర్సంపేట్. మోహన్ రావు, డాక్టర్ మోహన్ రావు, నర్సంపేట్ బ్రాంచ్. Membership growth, IMA Khammam branch, President Dr. B. Kishan Rao, Secretary Dr. Tejavat Suresh. Khammam branch. Hyderabad branch, best CME program, IMA Hyderabad City branch. Dr. Lingam Gaud, Secretary, Dr. Wilfred D'Souza, President, Dr. Dayal Singh. Best CME branch.
City branch, adigo vastunar chudu.
Dr. Lingam Gaud, Secretary.
अच्छा वाले
Best CME program, IMA Armour branch, President Dr. O. Umameshwar Reddy, Secretary S. Parashuramul garu. IMA Armour branch. Best Community Services, Dr. K. Pramila, IMA Kodad Huzurnagar branch. Dr. D. Lavkumar Reddy, new branches formation. Dr. D. Lavkumar Reddy, sir. Dr. D. Lavkumar Reddy, sir, for new branch formation.
కోదాడమ్మాయికి ఇన్ఫర్మేషన్ లేనట్టుంది.
ప్రెసిడెంట్ అయిపోయింది, గట్టుది అయిపోయింది. బెస్ట్ కమ్యూనిటీ సర్వీసెస్ ఐఎంఏ హైదరాబాద్ ఈస్ట్ బ్రాంచ్, ప్రెసిడెంట్ డాక్టర్ జె విజయరావు, సెక్రటరీ డాక్టర్ కె నాగమోహన్ రావు. Best Membership Growth Award for IMA Hyderabad North Airport Branch, President Dr. K. Balraj, Secretary Dr. N. Ravikumar. మొదలు చెప్పమ్మా, చెప్పి పెట్టమ్మా. ఎక్సైజ్ ఏంటి అది? ఎక్సైజ్ సార్కి చెప్పండి. ఎక్సైజ్ ఎయిర్పోర్ట్ ఇక ప్రియాంక స్టాఫ్
దానికి చెప్పడానికి ఒక ఇంట్రడక్షన్ ప్రియాంకది ఇంట్రడక్షన్. వన్ సెకండ్. సే ఐ థింక్ దిస్ ఇయర్ ఐ థింక్ వీడ్
ప్రియాంకకి అవార్డు అనౌన్స్ చేయండి.
మరి చెప్పేది అదే, దట్స్ వాట్ ఐమ్ టెల్లింగ్. ఎనీవే, ఇంకొక ముఖ్యమైన విషయం ఏంటంటే ఈ సంవత్సరం May I request all the people who have received the award to clear the dais, please. ఓకే థ్యాంక్ యూ. అది అవార్డు తీసుకున్నారా? క్లియర్ చేయండి ప్లీజ్. క్లియర్ ఉందో ఎందుకుంటుంది? ఏం పంపించారు మీరు? మీరే పంపించలేదు, ఇప్పుడు కూడా రిపోర్ట్ రాలేదు. లాస్ట్ బట్ నాట్ ద లీస్ట్, వెరీ ఇంపార్టెంట్ థింగ్ నా ఈసారి ఏంటంటే టు ఎంకరేజ్ అవర్ స్టాఫ్, అవర్ ఓన్ స్టాఫ్ ఇన్ ద ఆఫీస్, ఈసారి కొత్తగా ఒక అవార్డు ఇన్స్టిట్యూట్ చేసాము. ఎందుకంటే దిస్ విల్ ఆల్సో ఎంకరేజ్ అదర్ పీపుల్ టు కంపీట్ నౌ ఫర్ దిస్ అవార్డ్ ఆల్సో. సో దిస్ అవార్డ్ గోస్ టు Priyanka for the wonderful work she has done. Please, Priyanka, please go and receive the award. నేను రావాలనా? I am sure this will encourage in future to compete, and then get each of them will work more vigorously and try to get this award also, because this is going to be a regular feature now from now on, apart from the 15 and odd awards what we are giving. Thank you very much.
తీసుకొని కొత్త తెచ్చి
ఇంకా మరి ఆర్గనైజింగ్ కమిటీ తరఫు నుంచి థ్యాంక్స్. అది ఎవరు లేరా?
రామ్ కిరణ్ వస్తుండు సార్.
రామ్ కిరణ్ ప్లీజ్.
అలీం. అలీం
అలీం ఆర్ రామ్ కిరణ్.
ఏ కాదు, రావాలి ముందుకెళ్ళి. वोट ऑफ थैंक्स नहीं बोलते अली.
या
On behalf of organizing committee IMA TS Con 6 2022, we sincerely thank all the esteemed members of IMA Telangana State coming from different districts and making the program a grand success. We thank you all from our bottom of heart, and we request all of you to join for the dinner and cultural program. Thank you once again.
చెక్ టెస్ట్.
ఓకే, సో మరి ఒక బ్యూటిఫుల్ ప్రేయర్ సాంగ్ పాడడానికి మన బ్యూటిఫుల్ చిల్డ్రన్స్ వస్తున్నారు. సాయి శరణ్య అండ్ సాయి శృతి.
చెక్ టెస్ట్.
కమ్ ఆన్.
సాయి శరణ్య అలాగే సాయి శృతి వస్తున్నారు కాబట్టి
ప్లీజ్ జాయిన్ అవర్ హ్యాండ్స్ టుగెదర్. ప్లీజ్ జాయిన్.
కాస్త మాకు కాంపిటీషన్ రెడీ అయిపోయింది. క్లాస్ అండి.
श्री सरस्वती नमोस्तुते. श्री सरस्वती नमोस्तुते. वरदे श्री सरस्वती नमोस्तुते. परदेवते श्रीपति गौरी पति गुरु गुह विनुते विधियुवते. श्री सरस्वती नमोस्तुते. वासनात्रय विवर्जित वरमुनिभावितमूर्ते. वासनात्रय विवर्जित वरमुनिभावितमूर्ते. हासयुत मुखाम्बुरु हे अद्भुत चरणाम्बुरु हे. संसार विद्यापहे सकल मंत्राक्षर गुहे. श्री सरस्वती नमोस्तुते. परदेवते श्रीपति गौरी पति गुरु गुह विनुते विधियुवते. श्री सरस्वती नमोस्तुते. हिमगिरि तनये हे मलते. हिमगिरि तनये हे मलते. अम्बईश्वरि श्रीललिते. मामवा हिमगिरि तनये रमावाणी संसेविते सकले. रमावाणी संसेविते सकले. राजराजेश्वरी राम सहोदरी. सासनि निन्नि पपाप मग गम गम पनि मप गम पनि सा. सग सनि सनि पनि नि पम गम मग पम नि पसानि पसानि नि सा. ni sa ga pa ni sa ga ma pa sa ga ma pa ni sa sa ni ga sa ni pa ni sa ga ma ma ga ga sa sa ni pa pa ni ma ma pa pa ga ma pa sa ga ma pa ni sa ni pa ga ma pa ni hi ma gi re ta na ye he malate पासां कुसेक्षु दंड करे अम्ब परात् परे निज भक्त वरे अम्ब भक्तवरे आशांबर हरिकेश नीलये आशांबर हरिकेश नीलये आनंद रूपे अमित प्रतापे मामवा हिमगिरि तनये हे मलते थैंक यू
సూపర్
చప్పట్లు సరిపో
गणेशाय गणदैवताय गणाध्यक्षाय धीमहि गुणशरीराय गुणमण्डिताय गुणेशानाय धीमहि गुणातीताय गुणाधीशाय गुणप्रविष्टाय धीमहि एकदन्ताय वक्रतुण्डाय गौरीतनयाय धीमहि गजेशानाय भालचन्द्राय श्रीगणेशाय धीमहि एकदन्ताय वक्रतुण्डाय गौरीतनयाय धीमहि गजेशानाय भालचन्द्राय श्रीगणेशाय धीमहि चतुराय गानप्राणाय गानान्तरात्मने गानोत्सुकाय गानमत्ताय गानोत्सुकमनसे गुरुपूजिताय गुरुदैवताय गुरुकुलस्थायिने गुरुविक्रमाय गुह्यप्रवराय गुरवे गुणगुरवे गुरुदैत्यगलक्षेत्रे गीतसाराय गीततत्त्वाय गीतगोत्राय धीमहि गूढगुल्फाय गन्धमत्ताय जयप्रदाय धीमहि गुणातीताय गुणाधीशाय गुणप्रविष्टाय धीमहि एकदन्ताय वक्रतुण्डाय गौरीतनयाय धीमहि गजेशानाय भालचन्द्राय श्रीगणेशाय धीमहि एकदन्ताय वक्रतुण्डाय गौरीतनयाय धीमहि गजेशानाय भालचन्द्राय श्रीगणेशाय धीमहि
Bakera re vare bakake bakera.
కృష్ణుడు వచ్చాడే యమునా తీరాన ఉన్న రాధను చూశాడే బృందావనం నుంచి కృష్ణుడు వచ్చాడే కళ్ళకి కాటుక ఎట్టుకొని కాళ్ళకి పట్టీలు కట్టుకొని చెవులకు కమ్మలు ఎట్టుకొని చేతికి గాజులు వేసుకొని సిలుకు చీర కట్టుకొని సెంటు గట్రా కొట్టుకొని కొత్తగా ముస్తాబయ్యా ఎప్పుడప్పుడు వస్తాబయ్యా నిన్ను చూడకుంటే గుండె కొట్టుకోదయ్యా
nice. Hope you're feeling all. Say hi. Say yo. Say yeah. That's great. Very good evening and welcome to the Cultural Festival. And our distinguished guests, seniors, colleagues, and all the spectators. Hope you would love this evening. As our team has made a handful of various programs, keep you thrilled and entertained. Okay? And on this occasion, as we are here to celebrate Dr. B.A. Ross's becoming president of TSI, I thank wholeheartedly each one who are working hard to make this event successful and colorful. Let us give a big round of applause to Dr. B.A. Ross.
Please, I hope about a couple of minutes, please.
It's not so easy to get into all the standards of medical fraternity and political field also to make them on the same stage. That's a big success for all of us. So please give a big round of applause to Dr. B.A. sir. And at the same time, I would like to thank Dr. Vijay Lakshmi Madam, who is the Cultural Committee Chairman, for giving me this opportunity. And I request all of you to give a big round of applause to Vijay Lakshmi Madam.
Nobody is in the mood.
Okay, ma'am, ladies and gentlemen, get ready to hold your break. Here comes some mesmerizing performance by our IMA and our family. Thank you, and I'd like to thank the cultural committee members, Dr. Priyanka, Dr. Tripur Reddy sir. He's one of the guys who's like behind the screen. He made me to push like, and thank you sir, thank you Tripur Reddy sir, Dr. Swami sir, Rajni madam, Dr. Vivek, Dr. Janvi, and all the cultural committee members. Thank you all, thank you once again.
Dear IMA families, this cultural event is for you by our own IMA doctors. Though they are doctors, they are performers too. In spite of professional hectic schedule, our cultural team could take time out for this event just to entertain you. I must thank Priyanka, Shiva, Vivek, GVS, last but not least Nikhil for designing this and coordinating the program. I thank our dance master, Mr. Ramakrishna, for his untiring efforts to train us. Please give them a huge round of applause. Dear family, now just sit back, hold your breath, enjoy the superb extravaganza and appreciate their scintillating performances. Thank you, one and all. Now I request Dr. Radha Madhuri Madam to give her performance. Radha
Last but not least, my buddy Nikhil, who has made this event so successful. Where is that guy? Nikhil, hi buddy, come on the stage. He's our Allu Arjun. He's like Dhanush to Tamil film industry and Allu Arjun to Telugu.
Yes, please welcome on today's Dr. Animal Naresh on Veputra of the Service. Welcome, sir. Thank you, sir. Your next performance for Dr. performance. Please welcome Dr. Radha. Please welcome. Welcome, madam. Music.
Thank you.
excellent performance, Dr. Radha Kundari garu. Super. ఒకసారి గట్టిగా చెప్పండి మేడంకి. ఎంత అందంగా perform చేస్తున్నారు.
సో ఇంతే అద్భుతంగా ఈ మధ్యకాలంలోనే ఒక మూవీ చాలా హిట్ అయిపోయింది, చాలా బ్లాక్ బస్టర్ మూవీ. ఏంటో అది
కాంతారా.
సో కాంతారాలో ఒక మంచి సాంగ్ చాలా సూపర్ హిట్ అయిపోయింది.
అయితే ఇది అలాంటి కూడా ఒక విషయం అవుతుంది. మేము డాక్టర్సే కాదు, మాలో కూడా అద్భుతమైనటువంటి టాలెంట్ ఉంది. మాలో కూడా మంచి ఆర్టిస్ట్ ఉన్నారు. మాలో మంచి టాలెంట్ ఉంది అని ఇప్పుడు ఉన్న వాళ్ళు అర్థం చేస్తే తెలుస్తూ ఉంది. నిజంగా
ఎప్పుడు ప్రూవ్ చేస్తూనే ఉంటారు, కానీ ఈ రోజు ఇంకాస్త స్పెషల్ ప్రూవ్ చేస్తూ ఉన్నారు.
కాంతారా సాంగ్ పైన పర్ఫామ్ చేయడానికి వచ్చేటువంటి డాక్టర్స్ కూడా వాళ్ళ టాలెంట్ కూడా ప్రూవ్ చేసుకోవడానికి వస్తున్నారు. మేము
సో చూడాలంటే ఇంత సైలెంట్గా ఉంటే రారండి.
లేదు, మేము ఒకటి నాడే కాదు, నాట్యం కూడా చేస్తామంటున్నాము.
నాని పట్టుకొని అంటే
నాటి పట్టుకోవడం కాదు, నాట్యం కూడా చేస్తాము. సూపర్ పర్ఫామ్ పైన వచ్చేస్తున్నారు. కాంతారా నుంచి ఒక సూపర్ సాంగ్ పైన పర్ఫామ్ చేయడానికి ప్లీజ్ వెల్కమ్. అందరూ వచ్చి గట్టిగా చెప్పండి everybody. ఈ పర్ఫార్మెన్స్ మాత్రం ఒక రేంజ్ లో అవుతుంది. సో అందరూ కాంతారా మూవీ అందరూ కూడా చూసారు, చాలా మంది చూస్తూ ఉంటారు. సో ఆ మూవీ ఎంతో అద్భుతంగా ఉందో, సో ఈ పర్ఫార్మెన్స్ కూడా అంతే అద్భుతంగా ఉండబోతుంది. ప్లీజ్ వెల్కమ్.
Good evening, ladies and gentlemen. On this occasion of 6th Annual Telangana State IMA Conference, I am really proud and honored in delivering the introductory words pertaining to one of the greatest incarnations of Lord Vishnu, the Varaha Avataram. This performance is based on a recent marvel, the movie Kantara, which is a part of dance performance of Bhutakona when Durga god possesses the body of a human and venerates Lord Vishnu, the third incarnation. He manifests himself as Varaha Avataram, who assumes the form of a wild Bhudevi, the earth who is abducted by Rakshasa Hiranyakshika and hid her in the waters. The mighty Lord Varahaswami slews the Asura and reprised Bhumaka from the restored ocean, lifting the earth on his tusks and restored Bhudevi. We present to you the marvelous dance performance in the exotic town of Karimnagar, which is Lord's own country, where he incarnated himself as Adi Varahaswami on the rock and Yajna Varahaswami in the temple at the center of our town. A very rare occurrence of the two most sacred temples in the Supreme Lord Varaha at one place. Please immerse yourself in the eternal bliss of the divine energy of Varahaswami. Here we come to celebrate with all our energy and exuberance on the divine dance. Sada ఆ దేవదేవుని ఆశీస్సులతో మీకందరికీ ఉండాలని కోరుకుంటూ
Welcome all of you. So నిజంగా పర్ఫార్మెన్స్ వస్తున్నారు. What a fantastic performance! అందరూ ఒకసారి వాయిస్కోండి. నిజంగా మాటలు లేవు, మాట్లాడుకోవడం లేవు. ఆ కాస్ట్యూమ్స్తో ఆ పర్ఫార్మ్ చేస్తుంది. ఆ సాంగ్ ఇంత బాగా చేయొచ్చు అనేది వీళ్ళు చూస్తే అర్థమవుతుంది. నిజంగా ఒక ప్రొఫెషనల్ డాన్సర్స్ కంటే ఒక రేంజ్ లో చేశారు. సో ఇంత మంచి డాన్స్ కొరియోగ్రఫీ చేసినటువంటి మాస్టర్ మీరు ఒకసారి ప్లీజ్. మాస్టర్ పెట్టుకున్నారు డాన్స్ మాస్టర్ వంశీ. సూపర్ కొరియోగ్రాఫర్ ఒకసారి వంశీ కూడా ఒకసారి గట్టిగా చెప్పండి అందరూ ప్లీజ్. వెళ్ళి సూపర్. థ్యాంక్ యూ వంశీ. ఎస్ ఎక్కడ కూడా వన్ డ్రాప్ కూడా ఎక్కడ కూడా ఏ మాత్రం తడబడకుండా సో ఒక ప్రొఫెషనల్ డాన్సింగ్ చేసినట్టుగా చేశారు. ఆసమ్ ఎక్స్ట్రాడినరీ పర్ఫార్మెన్స్ ఇది. సూపర్. ఒక్కసారి మళ్ళీ కొంచెం గట్టిగా వేసుకోండి. థ్యాంక్ యూ మ్యామ్. థ్యాంక్ యూ ఆల్ ఆఫ్ యూ. సచ్ ఎ బ్యూటిఫుల్ పర్ఫార్మెన్స్. థ్యాంక్ యూ ఎవ్రీబడి. థ్యాంక్ యూ సో మచ్. గ్రేట్ జాబ్. సూపర్. ఓకే సో మంచి డాన్స్ పర్ఫార్మెన్స్ చూసాం కదా. నిజంగా అన్ని కలిపి భోజనం చేస్తే ఎలా ఉంటుందో, మంచి బిర్యానీ తింటే మంచి అన్ని రకాలుగా కలుపుకొని తింటే ఎలా ఉంటుందో. సో ఈ కాంతార సాంగ్ వాళ్ళ పర్ఫార్మెన్స్ చేస్తే కూడా అలాగే ఉంది. ఒక మనలో ఒక మంచి ఎనర్జీ నింపారు.
చూడగానే అసలు డాక్టర్స్ నిజంగా డైలీ హాస్పిటల్కి వెళ్తున్నారా లేదంటే ప్రాక్టీస్కి వెళ్తున్నారా అర్థం కావట్లేదు.
నేను అసలు నేను కూడా నమ్మలేదు. కానీ పర్ఫార్మెన్స్ చూసిన తర్వాత నో వాట్స్ చింపి 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 చింపేశారు. అందరూ పెట్టేశారు.
ఇక్కడ కనిపిస్తుంది చెప్పేశారు.
థ్యాంక్ యూ సో మచ్. మరి ఈ పర్ఫార్మెన్స్ చూసిన తర్వాత ఇది మంచి పాట
బాగుంటుంది అనిపిస్తుంది కాబట్టి
ఇదే ఎనర్జీ కనిపించాం. పార్టీ అంతా కూడా ఇదే ఎనర్జీతో ఉండడానికి మేము కూడా
డాక్టర్ శ్రీ శ్రీనివాస్ గారు. సో వామ్ వెల్కమ్ టు యు సర్. డాక్టర్
శ్రీనివాస్ గారు ప్లీజ్ వెల్కమ్ ఆన్ దిస్ ఒక సూపర్ సాంగ్ పాడడానికి వచ్చేస్తున్నారు. శ్రీనివాస్ గారు ఇక్కడి నుంచి వచ్చేసరికి ఆయనకి శ్రీనివాస్ గారే మాట్లాడాలి. సార్ కొంచెం మీరు మాకు డిస్టెన్స్ మెయింటైన్ చేయండి సార్. ఎందుకంటే మా హైట్ బయట పడిపోతుంది మీరు పక్కన నుంచి ఉంటే. ఓకే థ్యాంక్ యూ డాక్టర్ శ్రీనివాస్ గారు. ఒక సూపర్ సాంగ్ మన కోసం రన్ చేస్తున్నారు. ఎస్ శ్రీనివాస్ సార్ ఏం పాడుతున్నారు? స్థిరమల్లి అద్భుతమైన ఓల్డ్ మెలోడీ చేశారు సార్. ఈ సాంగ్ ఎవరి కోసం పాడుతున్నారు? కరెక్ట్ చెప్పండి సార్. ఎందుకంటే ఈ వీడియో కనుక అక్కడికి వెళ్ళి దానికి ప్రాబ్లమ్స్ అవుతాయి. ఎవరి కోసం పాడుతున్నారు? ఓకే థ్యాంక్ యూ శ్రీనివాస్ గారు. థ్యాంక్ యూ సో మచ్. మెలోడీ సాంగ్ స్థిరమల్లి.
ఓకే టోటల్గా అడిగారు. ఇంతకీ సార్ శ్రీనివాస్ గారు ఓడితే లేదు అంటే కొంచెం హైట్ తక్కువ ఉంటుంది సార్. అందుకే ఎక్కడెక్కడ వెతుకోవాల్సి ఉంటుంది. ఓకే పెళ్ళిలోకి వచ్చేస్తారు. మేడం పేరేంటో చెప్పలేదు ఇంకా. మైక్లో చెప్పండి సార్. మనసుగా ఉన్నారు ఇక్కడ. ఓకే సో మానసి గారు స్పెషల్ సూపర్ చూసారా? ఓకే సో నాకు తెలిసి మానసి గారు నేర్పించారు ఈ పాట. ఒకసారి చెప్పట్లేదు మర్చిపోతున్నారు మధ్య మధ్యలో ఒకసారి గట్టిగా అందరూ చెప్పండి సో నవీన్ గారు చాలాసార్లు మీ వద్ద విన్నాము మేము అభివృద్ధి చేస్తున్నాము ఈరోజు కూడా మంచి
సో మంచి ఓల్డ్ మెలోడీ పాడుతున్నారు. నాగేశ్వర గారు సంగీతం.
Good morning, Alim bhai. Good evening, everyone. Congratulations to BM. Ravindra. Now there is a time for refreshment. May I have your attention, please? Janana, Ravindra, BM. Actually, I was not getting opportunity to sit here. So already I ate ice cream and everything.
పట్టుకోండి.
మేడం 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 కూర్చోండి కూర్చోండి.
So next performance,
డైలీ హాస్పిటల్స్ లోనే కనిపిస్తున్నారు. అయినా సరే ఎన్ని గంటలు ఎన్ని రోజులు ఎలా ఎప్పుడు మీ టైం తగ్గిందో అర్థం కావట్లేదు.
సో బ్యూటిఫుల్ కపుల్ వచ్చారు. డాక్టర్ విద్య గారు, డాక్టర్ నవీన్ గారు వచ్చారు. మరి వేసుకుంటారా క్లాస్? ఓకే సాంగ్ ప్లీజ్.
ఎక్సలెంట్ ఎక్సలెంట్. ఒకసారి గట్టిగా చెప్పండి ఒకసారి గట్టిగా.
కాదండి, ఓన్లీ డ్యాన్స్ మాత్రమే అన్నారు, వాళ్ళేంటి పూర్తిగా సినిమా చూపించారు.
అంటే సార్ అలా వచ్చేసింది అనమాట.
అలా వచ్చేసింది కానీ పవర్ స్టార్ ఏ పిల్ల సార్, ఆ సార్ స్టార్టింగ్ అసలు మామూలుగా లేదండి. ఏ పిల్ల అన్న తర్వాత ఆ బీట్ కంప్లీట్ గా ఎంత బాగా ప్లే చేశారు.
సూపర్, థ్యాంక్ యూ సో మచ్. నెక్స్ట్ ఎవరు వస్తారు? నిఖిల్ అండ్ ఆరాధ్య. సో ప్లీజ్ వెల్కమ్ ఆన్ దిస్. నిఖిల్ గారు అండ్ ఆరాధ్య గారు నెక్స్ట్ పర్ఫార్మెన్స్. ప్లీజ్ వెల్కమ్ ఆన్ దిస్.
పిల్లలు, చిన్నపిల్లలు పాప వాళ్ళు డ్యాన్స్ చేస్తున్నారు, మీరు మధ్య మధ్యలో అసలు మన ఊర్లో లేరు ఇక.
నేను వాళ్ళు ఏమనుకో, నేను ప్రపంచంలో ఎవరిని కంట్రోల్ చేసినా వాళ్ళని నేను కంట్రోల్ చేయలేరు.
స్టూడెంట్
వాళ్ళు ఎంజాయ్ చేస్తున్నారు, వాళ్ళ బాడీ ఎంజాయ్ చేస్తున్నారు.
Yes, please welcome. నిఖిల్ గారు అండ్ ఆరాధ్య. నిఖిల్ అండ్ ఆరాధ్య.
పేరెంట్స్ చిన్న రిక్వెస్ట్ అండి, దయచేసి అన్నితో భావించకండి. పిల్లలందరూ ఇక్కడ స్టేజ్ పైన వస్తున్నారు కాబట్టి మధ్య మధ్యలో కాస్త చూసుకోండి ప్లీజ్, రిక్వెస్ట్. ఆరాధ్య కాస్ట్యూమ్ చేంజ్ చేసింది కాబట్టి గుర్తుపడడం చాలా కష్టంగా ఉంది సార్.
ప్రీతి గారు, పిల్లలందరి కోసం మీరు లాస్ట్లో అయినా పర్వాలేదు, పిల్లలందరి కోసం ఒక సాంగ్ మీరు ఖచ్చితంగా ప్లే చేయాలి, వాళ్ళందరూ డాన్స్ చేస్తారు.
ఖచ్చితంగా ప్లే చేస్తున్నాం. ఇప్పుడు మళ్ళీ సాంగ్ ప్లే చేసి వాళ్ళ కోసం అక్కడ డ్యాన్స్ కూడా చూడండి, వాళ్ళ కోసం వెయిట్ చేస్తూ ఉంది.
ఆ ఫ్లోర్ పైన కాదండి, మీరు మెయిన్ స్టేజ్ పైన లాస్ట్లో చిల్డ్రన్ అందరి కోసం ఒక మంచి సాంగ్ డీజే టీవీ సాంగ్ ప్లే అవుతుంది. అందరూ డాన్స్ చేయడానికి రెడీగా ఉండండి కాసేపటి తర్వాత. సో నా నిఖిల్ అండ్ ఆరాధ్య.
డాక్టర్ నిఖిల్ గారు, ఆరాధ్య గారు, ఫాదర్ అండ్ డాటర్. లెట్స్ ప్రాక్టీస్.
పిల్లలందరూ కూర్చోవాలి ప్లీజ్. చిల్డ్రన్
వావ్.
Oh
heart-touching performance. The great
Really super.
Aradhya. Dr. Nikhil Garu and Bangatali Aradhya. Such a fantastic performance, heart-touching performance. చాలా 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 అద్భుతంగా అందంగా అమోఘంగా చేశారు. Really great. డాక్టర్ నిఖిల్ గారు అండ్ ఆరాధ్య. ఒక్కసారి గట్టిగా చెప్పడం ఇవ్వాల్సిందే. ప్లీజ్ ఎవ్రీబడి. వీళ్ళకి ఒక్కసారి గట్టిగా థ్యాంక్ యూ సార్ డాక్టర్ నిఖిల్ సార్. అండ్ నెక్స్ట్ వన్ ఫేమస్ బై 3 rollers ఆఫ్ కరీంనగర్. డాక్టర్ రజని గారు, డాక్టర్ ధరణి గారు, డాక్టర్ ప్రియాంక. ప్లీజ్ వెల్కమ్.
సార్ కొంచెం జరగండి సార్.
Children, please. Quiet sit there. All of you children. ఎవరు కూడా స్టేజ్ పైకి రావద్దు. ఓకేనా? పిల్లలందరూ కూర్చోండి ప్లీజ్.
కెమెరాలో కట్టుకుంటే తీసుకోవాలి.
Please welcome. Raise your hands, please. Come on to the stage. When you ask for the coincidence, raise your hands. Next to me, to be also about మీరు పర్ఫార్మెన్స్ చేయండి డాక్టర్ శ్రీదేవి గారు.
శ్రీదేవి గారు ఒక సాంగ్ వినిపించడానికి వచ్చేస్తున్నారు. ఆల్రెడీ మనందరికీ తెలిసిన విషయము. చాలా మంచి సింగర్, క్లాసికల్ సింగర్, సినిమాటిక్ సింగర్ ఆల్సో. చాలా స్టేజ్లో కూడా పర్ఫార్మ్ చేశారు.
డాక్టర్ శ్రీదేవి గారు మనందరికీ సుపరిచితురాలు. వారి ఎంతో మనందరూ కూడా ఆలోచించినటువంటి శ్రీదేవి గారు మనకు మంచి సాఫ్ట్వేర్ ఈరోజు మనందరి మీద వారి పాటలు ఆలోచించిన చేశారు డాక్టర్ శ్రీదేవి గారు.
So next, Ready Hospital Consultants, Dr. Raghav Garu, Dr. Dikshit, Dr. Damodar, Dr. Ravindra Garu, Dr. Vikram sir. Please welcome sir.
We are లైఫ్లో ఇలాంటి పర్ఫార్మెన్స్ చూడలేదు సార్ నా జీవితంలో షర్టు నలగకుండా ఫ్లోర్ అలగకుండా నిల్చున్న చోటే డ్యాన్స్ చేసేటువంటి మామూలు కాన్సెప్ట్ కావాలి సార్. ఎంత అద్భుతంగా చేశారు సార్. ఒక్కసారి ఏంటి అందరూ వెనీ అంటే ఫ్లవర్ అంటే అంటే పర్ఫార్మెన్స్ మాత్రం తగ్గేదే అనే రేంజ్లో ఉంది. సూపర్ నిజంగా సార్. ఇది రోజు చదువుతున్నప్పుడు పువ్వు పట్టుకొని రాజశేఖర్ గారు చూపించాలి అసలు జీవిత అదైతే సూపర్. థ్యాంక్ యూ సార్. థ్యాంక్ యూ. థ్యాంక్ యూ. ఎక్సలెంట్ పర్ఫార్మెన్స్. క్రేజీ డాన్స్, క్రేజీ పర్ఫార్మెన్స్. చాలా 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 క్రేజీగా చేశారు.
So next song by Jayashree garu, Dr. Vijayashree garu.
Next singer sir. Yes, a super song. Thank you sir. Dr. Vijayashree garu. Please welcome. డాక్టర్ వెంకటేశ్వర గారు. థ్యాంక్ యూ సార్. ప్లీజ్ మేడం. ఈ సాంగ్ తర్వాత రామేశ్వర రెడ్డి Thank you, ma'am. Thank you so much. Super song. Thank you. Next one, please welcome on the stage, Dr. V. Ramas Mohammed. Dr. Ramas Mohammed. The song from Brazil. So, Samprada DJ started with the open door. Dance sympathy. Dance program. Okay. Ramas Mohammed is the dance performance from the DJ only. Dr. V. Ramas Mohammed from Brazil. Thank you, sir. Please.
Manjula, Marasu
Dr. Nikki Garu and Dr. Vivek Garu. Please welcome. ఈ డాన్స్ పర్ఫార్మెన్స్ తర్వాత ఓపెన్లో డీజే స్టార్ట్ అవుతుంది. మీరు హ్యాపీగా డీజే ఎంజాయ్ చేయొచ్చు. మీకు ఎవరైనా ఆడాలనుకుంటే ఆడవచ్చు, పాడాలనుకుంటే పాడవచ్చు. Now, dance performance by Dr. Shiv Garu, Dr. Nikki Garu, Dr. Vivek Garu.
కొట్టేశారు లాస్ట్ పర్ఫార్మెన్స్. కానీ ఒక రేంజ్లో మామ నీకు పెట్టలా ఉంటుంది. ఓకే, all of you children, come on to the men's stage. Children, అందరూ కలిసి ఒక మంచి సాంగ్ డీజే పిల్లు. ఈ మాట సో స్వీట్ ఆఫ్ యూ. అరే తమ్ముడు పాట పెట్టామంటే నామకం చూడవద్దు, పాట పెట్టాలి. డీజేటీ అన్నప్పుడు డీజేటీ ఏం పెట్టాలి, ఇంకేం పెట్టాలి? అరే మాట నువ్వు నామకం తీసుకుని కాదా, పాట పెట్టాలి. పాట పెడితే అది పోవాలి, పిల్లలందరూ చేసింది అది చలో. ఓకే, మీ అందరి కోసం డీజేటీలో ఓకే. So, DJ please, fast. Only boys and girls, only children, okay? Yes.